வெளில வருது. கீழே இருக்கு. செக் செக் வெளில போகுது. Shake, shake, test, 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 shake, shake. மணி அந்த மைக் செக் பண்ணு. Shake, shake, test, 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 shake, 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 test, 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 shake, one, shake, shake, test, 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 shake, one, shake, 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 test, test, shake, one,
shake, test, test, shake, one, test, test, 1, 2, shake, test, shake, one, test, shake, one, shake, test. Shake, test, test.
shake, shake, test, 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 shake, one. எப்படி வெளில
பேசவும்
shake this, shake this, shake one, shake one, shake this, shake one, shake one, shake.
Workspace. With Google Workspace, you can create a Gmail account with your own domain and branding, helping your business look professional in any inbox. That's business email made easy with Google Workspace.
A very good morning to one and all present here. We shall now commence the last day of our conference, starting off with the free paper session to be presented by our very own aspiring dermatologist, which will be chaired by Dr. Malar Nisham. She is a consultant dermatologist at Derm Glitz Clinic and Apollo Hospitals. I kindly request you to take over, ma'am. I request Professor you are Dhanlakshmi ma'am to kindly co-chair this session.
Dr. Shri Sheta SJ. Come for the presentation.
Yes, sir. Yes, sir.
A gentle reminder to all the presenters today. Kindly strictly adhere to the time limit of 6 minutes. Warning bell will be rung at 5 minutes time. Thank you.
and ascorbic acid can be given. The management of paracet tongue is mainly with 20% of benzocaine gel for surface anesthesia and metronidazole to prevent secondary infection. Hemoperfusion hemodialysis can be given. Serial monitoring and renal and hepatic lung injuries and long-term follow-up is mandatory in case of paracet poisoning. Gastric lavage, oxygen therapy and atropinization is usually contraindicated in paracet poisoning. These are the other clinical features of tongue. Cherry red tongue is seen in carbon monoxide poisoning. Brown and black tongue is seen in bismuth, lead, iron poisoning. Blue tongue is seen in nitrates, and pale white tongue is seen in arsenic and phosphorus poisoning. And atropinization is burnt or necrotic tongue are usually seen in corrosive poisoning, and white, patchy or sluffy tongue in mercury poisoning. Dry tongue is usually seen in carbon monoxide poisoning, and fur tongue in chronic metal poisoning. Excessive salivation is seen in OB poisoning. In spite of easy availability of paracet in India, it is usually reported as rare or not reported at all. Being traced out only when the patient is referred to the dialysis unit for acute kidney injury. This is because most of the poison cases are usually treated as organophosphorus poisoning. In spite of easy availability of gastric lavage and atropine is usually given, which is contraindicated in case of paracet poisoning, which causes mortality in the patient for acute kidney injury. My take-home message is because most of the poison cases are usually treated as organophosphorus being the first and the most characteristic feature of paracet poisoning, which is contraindicated being diagnosed earlier. The intervention and the management can be changed, which helps in the proper management of the patient. The paracet tongue being the first and the most characteristic feature of paracet poisoning, if being diagnosed earlier, the intervention and the management can be changed, which helps in the proper management of the patient.
And one thing, they have to come first before the gastric lavage to us. Then only we can say. Otherwise, although the poisoning unit for the nice presentation, it's a very rare presentation. Rare of the rarest thing. What is that sodium thionite to come first before the gastric lavage to us?
In urine, if the urine turns blue, it indicates the presence of paracet poisoning. It is the diagnostic test for paracet poisoning.
For this person, it might be negative.
If the urine turns blue, it indicates the presence of
paracet poisoning. Making aware
it is the diagnostic test for paracet poisoning.
So this person, it might be negative. Next, Dr. Trisha, yes, to present her aware of it. Paper on comorbid conditions in psoriasis. Higher frequency in the females to present her study. Paper on
comorbid conditions in psoriasis. It's a higher frequency in females. So background, psoriasis is a chronic inflammatory disease and shares immunological links with cardiovascular diseases, diabetes, obesity, depression, inflammatory arthritis, and the comorbidities worsen morbidity and mortality, and severe psoriasis leads to an increased risk of cardiovascular mortality, and in females in general there is a greater reduction in life expectancy, and in females in general so the objective of the study was to study the association of obesity, diabetes, hypertension, abnormal lipid profile among psoriasis patients attending a tertiary care hospital, and compared the results with 4 different centers. So the methodology, the sample size was 200 consecutive psoriasis patients in a tertiary care hospital, and the general systemic and dermatological examinations were conducted. BMI, BP, blood sugar and lipid profile was also checked, and this was compared to 4 previous studies in an urban private clinic, urban private medical college hospital, urban government medical college hospital, and a semi-urban government medical college hospital. And the results, the overall incidence of comorbidities were in an urban private clinic was 85, urban private medical college was 52, urban government medical college was 58, and semi-urban government medical college was 33, and the tertiary care hospital was 18%. And the results for a female specific incidence was for an urban private clinic was 85, for urban government medical college was 78, semi-urban government medical college was 38%, and a tertiary care hospital was 23%. So the interpretation was that psoriasis is more common in males, but females have a higher rate of comorbidities. Urban centers and working women showed higher comorbidity rates. Rural housewives showed a lower incidence. So it's likely that lifestyle and immunization are contributing factors. So the conclusion was that female psoriasis patients are at a higher risk for comorbid conditions, urban lifestyle influence and early screening and lifestyle modifications are essential, and preventive care, especially for working women, should be emphasized. So these were my references.
Thank you for the message. Thank you for the message. To live in the rural area, rather than city now. Because rural area women are more prone for comorbidities and Thank you for the nice presentation.
I invite Dr. K.V. Pushpanjali for her presentation on NCOOP mimicking Parry-Romberg syndrome.
Good morning, everyone. NCOOP mimicking Parry-Romberg syndrome, which is a case report. Introduction. NCOOP D-Saber is a rare linear variant of localized scleroderma, which is also known as morphia. Parry-Romberg syndrome is a progressive hemifacial atrophy. Both conditions involve progressive facial deformity, but with a different pathophysiology and prognosis. Objectives are to present a case of ECDS with overlapping feature of Parry-Romberg syndrome, to discuss the clinical radiology and differential features, to emphasize the importance of early diagnosis. Case presentation. Age and sex of the female is a 12 years old female. Complains of progressive indentation or oval left forehead and scalp for 6 months. There is no history of trauma, seizures or systemic illness. There is no similar family history. Clinical examination. Linear depressed groove over left frontal scalp extending into forehead, which is known as sabbatical. Skin tightness and hypopigmentation along mild atrophy of underlying soft tissues, and there is no significant facial asymmetry or enophthalmos. This is the image showing the linear depressed groove over the forehead. Differential diagnosis. Let's differentiate between the NCOOP D-Saber and Parry-Romberg syndrome. The onset of NCOOP D-Saber is in childhood, whereas the Parry-Romberg syndrome is childhood to adolescence. Present is linear and sclerotic in NCOOP D-Saber, whereas in Parry-Romberg syndrome it is hemifacial atrophy. The skin involvement is prominent in NCOOP D-Saber syndrome, whereas in Parry-Romberg syndrome it is less prominent. The neurological signs in NCOOP D-Saber is less prominent, whereas it is more common in Parry-Romberg syndrome. The bone involvement is rare in NCOOP D-Saber, whereas more common in Parry-Romberg syndrome. Investigation. The MRI brain shows mild soft tissue atrophy in frontal region. There is no intracranial abnormality. The CT face shows subcutaneous fat atrophy and there is no bony erosion. Antinuclear antibodies is negative. Skin biopsy shows dermal fibrosis and inflammatory infiltrate, which is consistent with morphia. Management, we give topical steroids, which is the initial control. Methotrexate 15 mg per meter square weekly with folic acid. And photoprotection is given. Regular monitoring like neurological, dermatological and ophthalmological monitoring is essential. Follow-up after 6 months of methotrexate therapy, the progression is halted. There is no new lesions or neurological involvement. Cosmetic counseling is planned. Discussion, ECDS and Parry-Romberg syndrome may coexist or overlap. Both conditions share pathogenesis related to autoimmunity and vasculopathy. The imaging helps differentiate and monitor diseases. Early immunosuppression is crucial to prevent disfigurement and neurological sequelae. Conclusion is that ECDS may mimic or overlap with Parry-Romberg syndrome. Early recognition and treatment can prevent progression and disfigurement. Multidisciplinary approach is essential. And these are my references. Thank you.
Okay, ma. Thank you for the presentation. It was a good presentation.
Thank you.
So I invite upon Dr. Shri Pooja K. For presenting her paper on correlation of C-reactive protein and severity in psoriasis and psoriatic arthropathy.
Good morning all. My topic is correlation of C-reactive protein and severity of psoriasis and psoriatic arthropathy. Introduction. C-reactive protein is an acute phase reactant. It is produced by liver in response to interleukin 6. It is a marker of systemic inflammation. It has role in innate immunity. It is useful in tracking disease activity in inflammatory disorders, elevated in rheumatoid arthritis and inflammatory diseases, and some psoriasis case. It rapidly responds to therapy. Psoriasis is a chronic immune-mediated skin disorder. It affects 2 to 3% of global population, triggered by Th1 and Th17 pathways. The common types are plaque psoriasis, guttate, and pustula. The associated comorbidities are metabolic syndrome and arthritis. It is measured by PASI score, BSA score, DLQI index. Inflammatory cytokines involved are TNF-alpha, interleukin 17 and 23. Systemic nature linked to CRP elevations. Psoriatic arthritis, it occurs in 30% of psoriasis patients. Seronegative spondyloarthropathy. The patterns are oligoarthritis, symmetric polyarthritis, and spondylitis. Joint destruction can occur early and may be asymptomatic or subclinical. Inflammatory markers are ESR and CRP. Imaging will aid to early detection. Study objective. Evaluate CRP as a biomarker in psoriasis. Correlate with skin severity and psoriatic arthritis to assess CRP utility before and after treatment and to determine predictive and monitoring value. Methodology. 50 psoriasis patients were included and divided into 2 groups. Group A, body surface area of less than 20%, and Group B, more than 20% of body surface area. Psoriatic arthritis is assessed clinically and the infections are ruled out. CRP is measured at baseline and post-treatment. Results 11 out of 50 patients showed elevated CRP, and there is no clear link between CRP and BSA severity and joint involvement. Post-treatment, the CRP levels were normalized in all the elevated cases, suggest treatment responsiveness. Discussion. CRP is not consistently elevated in psoriatic arthropathy, may reflect systemic inflammation in the subset. Subclinical inflammation can exist with normal CRP CRP more useful to monitor therapeutic response, and it cannot replace imaging or clinical judgment. Literature, there are mixed results on CRP correlation in psoriasis. CRP levels may correlate better with pustular and erythrodermic psoriasis. Not all psoriatic arthropathy patients show elevated CRP. Interleukin 6 blockade reduces CRP, but not the skin lesions. ESR may complement CRP for assessment. Imaging such as USG and MRI are superior in detecting early joint disease. Clinical scoring remains primary in skin severity grading. These are my references. Thank you.
Okay, ma. Thank you for the presentation. So next I invite Dr. Samyukta for her paper on coexistence of psoriasis and atopic dermatitis and immune genetics wing.
Good morning, everyone. My topic is coexistence of psoriasis and atopic dermatitis and immune genetics swing. Introduction. Both are chronic relapsing inflammatory skin disorders. They're both major causes of neonatal and infantile erythroderma. Psoriasis is strongly associated with HLA genes. Atopic dermatitis has no strong HLA association. Transmission risk, both are 4 times higher from affected mother rather than the father. Maternal or mutual antagonism of Th1 and Th2 cells causes psoriasis and atopic dermatitis. These are pictures showing the first picture is a mother and the child. The mother shows psoriasis and the child is showing atopic dermatitis. The second picture is the father showing palmoplantar psoriasis and the child showing atopic dermatitis. This picture shows a sibling with psoriasis and the other child with atopic dermatitis. Overview of case series. 10 patients in a tertiary care hospital were reviewed. 2 children and 8 adults. Age range is between 85 days and 52 years. Erythroderma was noted in 1 infant and 1 adult as presenting feature. Family history of psoriasis and or atopic dermatitis were in all cases. Serum IgE levels, elevated serum IgE in 4 patients were noted. This suggests an atopic component in mixed presentation. IgE is typically elevated only in atopic dermatitis and not in psoriasis. Histopath findings. 2 cases had psoriasis and eczema features in the same biopsy. 8 cases showed features present in different biopsy sites concurrently. Overlapping features usually noted are acanthosis, parokeratosis, inflammatory infiltrate, hyperkeratosis, and epidermal hyperplasia. This is a biopsy showing features of both atopic dermatitis and psoriasis. Key clinical findings, mixed presentation, scaling, plaques, eczematous patches, and pruritus were noted everywhere. Erythroderma was also noted in 2 patients, and all cases had early onset. Pathophysiology, they both had epidermal hyperplasia, immune dysregulation, and skin barrier defects. Distinct immunological pathways are there. Psoriasis Th1 and Th17 are dominant, whereas in atopic dermatitis Th2 is more dominant. Despite these differences, overlap happens. Implications. This indicates a complex immunogenetic interaction. Early recognition and tailored treatment is the future. Conclusion. Coexistence of psoriasis and atopic dermatitis is possible as early as infancy. Mixed features support shared pathogenesis. Further research is needed to decode the immunogenetic overlap. These are my references. Thank you.
So both of them, they were common features, skin barrier defects, immune dysregulation, all those things. That's why they come together, even though the pathophysiology is different. Like so, it's very difficult to manage. When one comes down, another will flare up like that. This is making aware. Always don't label only psoriasis when you have mixed features. You have to label both of them. Thank you for making aware of it. Thank you so much.
Thank you, ma'am. I now request Professor U.R. Dhanlakshmi, ma'am, to kindly felicitate Dr. Malarnisha, please. Ma'am, please. We now move on to the second group of free paper presentations of the day, which is to be chaired by Professor Gopal Krishnan, sir, Professor and HOD, Department of DVL, Chettinad Hospital and Research Institute. I kindly request you to take over, sir.
A very good morning to everyone gathered here. At the outset, I would like to thank our beloved JT Singh for giving me an opportunity to be a chairperson of this session. And in this session of pre-papers, we have about 7 students presenting the papers. So I invite Dr. Kirtana to do her presentation.
Very good morning to everyone present here. Today my topic for presentation is cutaneous horn overlaying malignancy, a case series of squamous and basal cell carcinoma. So introduction, cutaneous horns or conical projections of hyperkeratotic material. It may arise from benign, pre-malignant or malignant skin lesions. Malignancy presents in 20% of cases, and most commonly the malignancy presenting is squamous cell carcinoma. Basal cell carcinoma is rare, but it is also documented. So the underlying dermatosis include in benign conditions there are seborrheic keratosis, actinic keratosis, viral wart, molluscum contagiosum, keratoacanthoma, and inverted follicular keratosis. Pre-malignant includes actinic keratosis, Bowen's disease, and solar keratosis. Malignant conditions include squamous cell carcinoma, basal cell carcinoma, malignant melanoma, Kaposi sarcoma, and metastatic renal carcinoma. the risk factors for malignancy include increasing age, large height to base ratio, large size, induration at the base of the horn. It means it is thickened and firm. Presence of erythema, which is increased blood perfusion, and horizontal terrace morphology on the horn, and it is more common in sun exposed areas. So here we are seeing two cases. Case 1, the first is 70-year-old male. He is a known case of psoriasis vulgaris for 30 years. He came with the complaints of 7x5 cm, hot, foul-smelling, cutaneous horn over a psoriatic plaque on the left thigh. So he is a known case of psoriasis for 30 years. And biopsy showed well-differentiated squamous cell carcinoma, showing features like hyperkeratosis, parakeratosis, absent granular layer, horn pearls and lymphocytic infiltrate. The management was wide local excision was done, and he was advised long-term follow-up. So here we can see the yellowish proliferative growth. It is over the psoriatic plaque. And in histopath we can see hyperkeratosis and parakeratosis. In the third figure we can see the horn pearl, which is the eosinophilic thing seen there. And the right one we see lymphocytic infiltrate. So the second case, here a female presented with a rapidly growing horn over the forehead. She came with history of itching, burning sensation over the lesion, and there was also history of bleeding on touch and discharge from the lesion. On examination, it was a 4x4 cm friable crusted cutaneous horn. Biopsy showed features of hyperkeratosis suggestive of cutaneous horn, and basaloid cells with palisade arrangement with retraction clefts around it, suggesting features of basal cell carcinoma. So the treatment was surgical excision. So here over the forehead we can see the proliferative growth, and in the histopath A shows hyperkeratosis showing cutaneous horn, and indicated by the B arrow is the basaloid cells, palisade arrangement around the basaloid cells showing basal cell carcinoma. So what is cutaneous horn? It is an elongated keratinous nodule with conical projection composed of compacted keratin. There are four types: sebaceous horns, nail horns, wart horns, and cicatrix horns. Sebaceous horns usually arise from the scalp. Nail horns usually from the great toe. Wart horns it can arise from chest or penis, most commonly reported, and cicatrix horns usually arises post burn scars. And it is common among Caucasians. Male are most commonly affected, and the site commonly involved is face and scalp. So the predisposing factors are elderly, trauma, burns, and fair complexion. It presents as hot, white to yellowish, brown papules or plaques. Size may vary from 2 to 60 mm. The height of the horn is always at least double the largest diameter. So this is the most important feature. And squamous cell carcinoma, it is the most common malignant base of cutaneous horns. It is most commonly reported from lower lip and penis. It affects the sun exposed areas. So in psoriasis it is the most common non-melanoma skin cancer. And basal cell carcinoma is the second most common non-melanoma skin cancer in psoriasis. The first being squamous cell carcinoma, the second being basal cell carcinoma. And basal cell carcinoma, the most important predisposing factor is chronic UV radiation exposure, and it commonly arises from lower eyelid. So in basal cell carcinoma, even small rapidly growing lesions, we have to be really suspicious because it could be malignancy. So diagnostic and treatment protocol, we have to always do biopsy. We can either simply shave or perform excisional biopsy. For malignancy, we have to do wide excision with margins, and follow-up for at least 3 years is required. So take home points. Cutaneous horns usually appear very benign, but there may be malignancy, so we have to be really careful. So risk is higher with size, rapid growth, bleeding, and chronic dermatosis. So in case 1 we saw psoriasis and chronic inflammation may predispose to neoplastic change, as in squamous cell carcinoma, and in case 2 in basal cell carcinoma, even small rapidly developing horns may require biopsy. So thank you. These are my references.
Very well presented, doctor. Though cutaneous horns are commonly associated only with benign conditions, you beautifully brought out that it can be associated with malignancy also. Thank you.
Thank you.
Next presenter is Soundarya. Dr. Soundarya.
Good morning, everyone. My topic for today is one more cutaneous dirt like Telederm disease, malaria rubra with exfoliation. Introduction. Cutaneous dirt-like adherent diseases are a group of dermatoses with a dirty appearance. Lesions mimic unclean skin due to keratin retention, pigmentation, or incomplete desquamation. It includes disorders that partially or completely resolve with cleansing. Currently described conditions under CDAD are dermatitis neglecta, terraforma formi dermatosis, malassezia dermatosis, atopic dermatitis with post-inflammatory hyperpigmentation, X-linked ichthyosis, confluent and reticulated papillomatosis, and acanthosis nigricans. The most common one seen among the CDAD is dermatitis neglecta, which is closely associated with TFFD, but dermatitis neglecta is due to inadequate washing, whereas TFFD is seen despite adequate hygiene. Dermatitis neglecta resolves with soap and water, whereas TFFD clears completely with 70% isopropyl alcohol. The other conditions are malassezia dermatosis. In KOH examination, you will be able to notice the spaghetti and meatball pattern. Atopic dermatitis with PIH, there is flexural involvement. 80% of the cases will have serum IgE elevation and a positive family history. X-linked ichthyosis is commonly seen in the lower legs. There's winter flares and the scales are centrally adherent and peripherally free. In CARP, usually seen in the interscapular intramammary regions with reticular plaques can be seen. Acanthosis nigricans is velvety hyperpigmented lesions seen over the intertriginous areas, and it's often linked with insulin resistance. Malaria is a disorder where the sweat duct obstruction is most commonly seen in hot or humid climates. There are 4 types: Malaria crystallina, and here the obstruction is seen in the stratum corneum. Malaria rubra, where the obstruction is seen in the intraepidermal region. Malaria profunda in the DEJ or the upper epidermis. And Malaria pustulosa, where there is secondary infection. Malaria rubra clinical features. It presents as itchy, erythematous papules or vesicles, which are found on trunk, neck, intertriginous areas, and is triggered by heat, sweating, occlusion. Lesions resolve with scaling or exfoliation and may mimic dirty patches as healing occurs. There are 7 patients that we saw, age range from 18 to 36, and all had history of malaria rubra, which presented with brownish scaly plaques, which resolved with dirty adherent look. These are the 4 female patients with malaria rubra with exfoliation. You can note the dirt-like appearance on the skin. These are the 3 male patients. There are no active lesions, but you can see the dirt-like lesions. Differential diagnosis. Malaria rubra with exfoliation can be mistaken for dermatitis neglecta, TFFD, CARP, and ichthyosis vulgaris. It can be differentiated by the acute history of malaria, the seasonality, exfoliative phase, and the distribution pattern. Management principles. Cooling and avoiding sweating are the mainstays. Emollients can be used to soothe these vomiting areas. Topical steroids if inflammation persists, and oral antibiotics if pustules develop. Conclusion: malaria rubra with exfoliation mimics CDAD. It should be included in the differential diagnosis of dirty appearing adherent lesions. It's important to recognize the post-inflammatory exfoliative phase to avoid misdiagnosis and unnecessary intervention. We propose classifying it as one more CDAD. These are my references. Thank you.
Well presented, doctor. Well presented, doctor. In these conditions, when you do a biopsy of those lesions, you will see a subacute eczematous picture. So it is actually a chronic MR which turns out slightly eczematous. Thank you so much. Thank you so much.
Thank you, sir.
Next, I call upon Dr. Gandhi to deliver his presentation.
Good morning, everyone. I'll be presenting a topic on do atopic children with alopecia areata have a guarded prognosis. Introduction. Alopecia areata is a non-scarring autoimmune T-cell mediated disorder with genetic basis targeting the hair follicle. Atopy includes atopic dermatitis, asthma, and allergic rhinitis. It's a background of increased immunological reactivity. Coexistence of alopecia areata and atopy has been reported in 10 to 60% of the cases. Pathogenesis, atopy-like alopecia areata may be triggered by stress and has been associated with more severe alopecia areata phenotypes such as alopecia totalis and universalis. Cytokine profiling has shown elevated levels of interleukin-1 alpha, TNF-alpha and interferon gamma in alopecia areata patients compared to non-atopic ones. Certain HLA-DQB1 alleles have also been implicated in both alopecia areata and atopy, suggesting a genetic predisposition. Clinical features and severity patterns. Atopic patients more likely to have severe alopecia areata patterns such as uveitis, persistent or recurrent forms, and sometimes less favorable response to therapy. Associated findings, higher frequency of nail involvement and other autoimmune features in atopic alopecia areata children have been seen. Case report. A prospective observational study was conducted on 100 children diagnosed with alopecia areata. Detailed personal and family history was elicited to detect atopic diathesis. Clinical examination and serum IgE estimation wherever necessary were done to confirm atopy. The children were followed for a period of 3 years post-treatment. Discussion. Out of 100 children, 27 showed evidence of atopy. Of these, 15 responded well to treatment, 6 had recurrence, and 2 progressed to alopecia totalis. Reticulate and uveitis patterns, persistence, recurrence, and a family history of atopy were more commonly seen in atopic alopecia areata children, and children without atopy demonstrated better hair regrowth outcomes. Prognosis in children with alopecia areata. General prognosis was unpredictable. Up to 50% showed regrowth within 1 year, but course is unpredictable and relapse is common. Poor prognosis factors. Young age at onset, extensive involvement, which is totalis and universalis, nail change, family history of alopecia areata, atopy, and atopic dermatitis was seen. Atopy as a factor, coexisting atopy, especially atopic dermatitis, as a poor prognostic factor for pediatric alopecia areata. Management overview. First-line therapy, topical corticosteroid remains standard therapy for children. And immunotherapy, topical immunotherapy may be less effective in presence of atopic dermatitis. Psychological support essential due to frequent recurrence and cosmetic burden. Prognostic markers, clinical pattern and extent of hair loss, age of onset, and disease duration before treatment. Laboratory, not routinely predictive, except perhaps for elevated IgE seen in atopic cases. Family and personal atopic history should be elicited in all pediatric alopecia areata patients. Limitation and consideration. Course is unpredictable. Even limited alopecia areata can progress to more severe disease, especially in children. Interpretation. Importance to be given for long-term follow-up since relapse are common and spontaneous regrowth occurs in many. Conclusion, a shared mechanism involving aberrant major histocompatibility complex expression and immune targeting of self-alopecia areata versus environmental antigens may underlie both conditions. The presence of atopy appears to be a negative prognostic marker in children with alopecia areata. However, interpretation is limited by potential recall bias, laboratory variability, and follow-up constraints. These are my references. Thank you.
So atopic dermatitis is itself a very complex immunopathogens mechanism is there. It complicates every other association it has. Thank you for bringing that out. Thank you, Dr. Gandhi. Thank you, Dr. Gandhi. Next I call upon Dr. Ahalya.
Good morning, everyone. My topic of presentation is cutaneous clues to child abuse, a case series. Introduction. Child abuse is a series of often underdiagnosed, profound medico-legal implications. Cutaneous signs include often first indicators, especially in non-verbal children. Cutaneous manifestations of abuse including bruising, contusions, erosions, laceration, burns, bites, and traumatic alopecia. Early recognition by dermatologists and pediatricians are key for prevention and intervention. Overview of case series. 3 pediatric patients findings suggestive of abuse are included. Age included varied from infants to older children, all with lesions in protected areas or inconsistent with history. This is a first child showing multiple lacerations over the lower limb of the child showing physical abuse. This figure shows lesions of condyloma acuminata over the genital region of 2 children indicating child abuse. Key clinical findings include sexual abuse indicators that are perianal genital condyloma acuminata, which are caused by HPV infection, multiple papillomatous growth. Physical abuse indicators include facial linear scars over the temple or the cheek from sharp trauma, healed and fresh pattern scars on limbs and thighs from wires or rods can be seen. Hallmark features include pattern injuries, varying healing stages, protected site involvement. Genital wart in children are high suspicion for sexual abuse, rarely non-sexual. Recurrent trauma patterns points to chronic abuse, requires multidisciplinary approach and medico-legal protocol adherence. It is essential to take a thorough history with separate child and parent interviews and to perform a full examination of the skill, appendages and mucous membranes. The investigation should also include X-rays and where appropriate blood tests are also included. Warning signs of abuse include a vague explanation by the caretakers of how the child's injuries occurred, conflicting versions by the parents, a story that changes over time, a history of frequent visits to the emergency room or of multiple fractures and an unjustified delay in seeking medical care. Conclusion, dermatological assessment is vital in detecting child abuse early. Maintain high suspicion for unexplained or pattern lesions. Prompt recognition prevents ongoing harm and ensures child safety. The POCSO Act, Protection of Children from Sexual Offences Act 2012. The Protection of Children from Sexual Offences was enacted by the Government of India to provide a comprehensive legal framework for the protection of children, defined as individuals below 18 years from sexual abuse, sexual assault, harassment and pornography. It serves as a deterrent to potential abusers and ensures that the perpetrators are held accountable for the crimes. Under Section 21 of the POCSO Act, doctors who fail to report cases of child sexual abuse may face penalties including the imprisonment for up to 6 months, a fine or both. This is my references. Thank you.
Thank you, Dr. Ahlia. It is actually a very tricky situation. When the sexual abuse, if you are able to confirm it, you should definitely report it to the police. The doubt happens when we are not very sure of it. We'll be caught in a catch-22 situation. We'll be damned if you do, damned if you don't. What if it's not a sexual abuse and we report it to the police? So we should be careful. Thank you for bringing that out. Thank you. Next, call upon Dr. R.T. Praveen.
Good morning, everyone. Today I am going to present a topic on a comparative study of intralesional triamcinolone acetonide, 5-fluorouracil and hyaluronidase versus combination of triamcinolone acetonide and 5-fluorouracil alone in the treatment of keloid. My aim of the study is to evaluate the efficacy and safety of triple combination of triamcinolone acetonide with 5-fluorouracil and hyaluronidase versus double combination of PAC and 5-fluorouracil in the treatment of keloid. The objective of the study is to measure the improvement in pliability, vascularity, pigmentation, and overall scar appearance using Vancouver Scar Assessment Scale. The inclusion criteria, patients between 12 to 60 years of age are included. Participants having keloid with greater than or equal to 5 cm in length and duration greater than 1 year. Exclusion criteria, pregnant and lactating females, patient who received other treatment in the past 3 months, presence of active inflammation, infection or ulcer at treatment. Patients were divided randomly into 2 groups of 10 each in Group A and Group B. Procedure. Group A received 6 sessions of triple combination of 150 international units of hyaluronidase along with 0.4 ml of triamcinolone acetonide and 0.6 ml of 5-fluorouracil at 4 weekly interval. Group B received 6 sessions of double combination of 0.4 ml of triamcinolone acetonide and 0.6 ml of 5-fluorouracil at 4 weekly interval. Results were assessed by Vancouver Scar Assessment Scale. Clinical assessment was done using Vancouver Scar Scale. All parameters were recorded at baseline and 4 weekly intervals for 24 weeks. Vancouver Scar Scale score was calculated at every visit. Photographs were taken at baseline and thereafter at each visit. Results were measured by comparing height, pliability, pigmentation, vascularity between 2 groups. height after 6 sessions, a percentage reduction in mean height was 69%, 46% with triple combination and double combination treatment. The pliability response from firm to yielding was seen with Group A in 3 sessions, whereas 5 sessions were required in Group B. Vascularity at 24 weeks, 93% and 38% of participants improved to normal vascularity with triple combination and double combination. Pigmentation at 24 weeks, 48% and 15% of participants showed normal pigmentation with triple and double combination treatment respectively. The Vancouver scar assessment scale score at 24 weeks, the percentage reduction in mean Vancouver scar assessment scale score was 58% and 37% with triple and double combination treatment respectively. We can see the mean Vancouver scar score reduced from 9.8 to 4.2 in Group A and from 9.9 to 6.3 in Group B. Adverse effects. Two patients had telangiectasia in Group A. Similarly, 2 patients had telangiectasia in Group B. Atrophy also we can see only 2 patients had skin atrophy in Group A and Group B. Pain after injection, 3 patients had pain after injection in Group A, whereas only 2 patients had pain after injection in Group B, which was not statistically significant. Discussion in this study, VSS score decreased from 9.8 to 4.2 in triple combination and from 9.9 to 6.3 in double combination. Mohammed et al. Investigated a combination therapy involving TAC, 5-fluorouracil and hyaluronidase among 30 patients for a period of 24 weeks and found significant improvement in keloid stiffness, thickness, vascularity and size compared to triamcinolone acetonide alone. White et al. was the first to evaluate the triple combination used in our study, comprising TAC, 5-FU and hyaluronidase among 20 patients with 4 monthly sessions and monthly follow-up for 1 year, and demonstrated its tolerability and potential efficacy in treating keloids. Despite some injection-related discomfort, the triple combination was well tolerated by patients with no serious adverse effects. The results observed in the study were similar to Group A arm of our study. Although all patients experienced minimal pain during the procedure, only 3 patients in Group A and 2 patients in Group B had pain, which lasted for a few hours. This was not significantly different between the groups. This is the before and after treatment in Group A and Group B. Conclusion: the present study shows triple combination is better than double combination in treatment of keloid, with no significant difference in adverse effects. Limitations: VSS scores are largely subjective and thus highly observer dependent. Limited number of participants were taken for this study. These are my references.
Very well presented, doctor. Just have one reservation in this study. At the outset itself, your one arm has 3 drugs, and the other arm has only 2 drugs. Automatically, don't you expect the one arm with the 3 drugs to be better than the other? So my suggestion is that maybe you could have included topical cryotherapy in the other arm, just to even out the both. Otherwise, it's a fantastic study. Thank you.
Thank you.
Next, I call upon Dr. Ardra Padma.
Good morning. My name is Ardra. The topic is to compare the efficacy and safety of 15% trichloroacetic acid peel with topical 0.05% tretinoin cream in the treatment of acanthosis nigricans. Acanthosis nigricans is a pigmentary disorder which affects large number of people. Presents as thick, dark, velvety, symmetrical patches over the neck, axilla, groin, popliteal fossa and antecubital fossa. The first drug of choice in the treatment of acanthosis nigricans is topical tretinoin. TCA, which is an exfoliative agent used as peel, has also shown some efficacy recently. Aims and objectives to compare the efficacy and safety of 15% TCA versus topical 0.05% tretinoin cream in the treatment of acanthosis nigricans. So here, total 80 patients were taken, 40 in each group were included in the study. Patients with acanthosis nigricans was then graded based on the Berkey scale, which is a standard scale. Every consecutive patient with acanthosis nigricans was assigned to Group A and Group B. Group A was treated with 0.05 creatine cream and Group B with 15% TCA peel. Assessment for improvement and side effects were done using a grading system and serial photographs of each session and followed up for another 2 months. This was a Berkey scale which we used to grade acanthosis nigricans, which grade 1 will be only visible on close visual inspection. Grade 2 will be limited to the base of the skull. Grade 3 will be extending to the lateral margins of the neck but will not be visible from the front. Grade 4 will be extending anteriorly, so it will be observed from the front. Results, the demographic profile. Here, mean age in both groups was somewhere around 33 years with a standard deviation of 9.956. Males were more in Group A and females were more in Group B. But these all did not prove to be a statistical significance in our result. Predisposing factors which were noted were hypothyroidism, diabetes mellitus, positive family history, PCOS. Among this, patients with positive family history was found to be more in both the groups, but this doesn't bring any statistical significance to our result. Grading distribution of acanthosis nigricans. The first graph shows the grading distribution. Grade 3 was found to be more in Group A and Grade 4 in Group B. Involvement of other sites other than neck was found to be more in Group A. These are the side effects which was found in both the groups: persistent erythema, burning sensation, desquamation and hyperpigmentation. Among this, burning sensation was seen more in both the groups, but Group A, which patients were treated with creatine cream, was found to be having more side effects. So based on the grade of improvement, Group A showed better improvement, almost more than 50% of the patients. Then Group B, which was treated with TCA peel, where only 80% study subjects had improvement. These are the photographs taken after 2 months of treatment for each group. Discussion in our study, topical tretinoin was found to be more efficacious than TCA peel based on the grade of improvement and safety profile, which was similar to the study done by Harish et al. In the study of Lahiri et al., topical tretinoin once at night was found to be more effective. In the study of Dunstan et al., topical tretinoin showed significant clinical improvement after 1 month. Conclusion, topical 0.05% tretinoin is more effective when compared to 15% TCA peel, which showed a statistically significant relation. Side effects were more with topical tretinoin cream when compared to TCA peel, but it is not statistically significant. These are my references. Thank you.
That was a good presentation, Doctor. Thank you. Next I call upon Dr. Grishma.
Good morning, everyone. Title of my paper is Atypical Presentations of Acroangiodermatitis of Mali and the Diagnostic Insights from 3 cases. Starting with introduction, acroangiodermatitis, also known as pseudokaposi sarcoma, is a rare benign vasoproliferative disorder. It was first described by Mali and others in 1965. It arises due to reactive vascular proliferation secondary to chronic venous insufficiency and arteriovenous malformations. It resembles aggressive conditions like Kaposi sarcoma and requires histopathological examination for its diagnosis. This case series highlights the diverse clinical presentations of acroangiodermatitis and the diagnostic utility of histopathology and dermoscopy. First case was a 54-year-old female presented with 10-year history of progressive itchy skin lesions on both legs. On examination, multiple discrete and coalescing firm hyperpigmented papules and flocks with few showing central depigmentation along with visible varicosities noted over bilateral lower limbs, and all peripheral pulses were felt. DDs considered were acroangiodermatitis of Mali, prurigo nodularis, lichen planus, and Kaposi sarcoma. Biopsy was done which showed lobules of capillaries with plump endothelial cells along with perivascular lymphocytic infiltrate in the papillary dermis, which was suggestive of acroangiodermatitis. Dermoscopy showed multiple red dots and globules along with white structureless areas. Venous Doppler confirmed bilateral lower limb varicosities and HIV serology was negative. Patient was started on calcium dorbicillate, oral antihistamines and topical corticosteroids and was referred to vascular surgery for the further management of varicosities. Second case was a 29-year-old male presented with 12-year history of recurrent episodes of pain and swelling in both legs along with dark raised skin lesions over the lower third of both legs for the past 8 years. Family history was insignificant. Patient underwent surgical vein stripping for bilateral lower limb varicosities 8 years ago. On examination, multiple form erythematous to hyperpigmented nodules and plaques ranging from 1 × 1 cm to 6 × 4 cm with surrounding hyperpigmentation noted over the lower third of bilateral lower limbs. Lead is considered were deep fungal infections and acroangiodermatitis of Mali. Biopsy and dermoscopy were done which was suggestive of acroangiodermatitis. Venous Doppler confirmed bilateral lower limb varicosities and HIV serology was negative. Patient was started on oral pentoxifillin and topical corticosteroids and was referred to vascular surgery for further management of varicosities. Third case was a 48-year-old male presented with red lesions over left leg since 2 years along with swelling and pain for the past 1 week. On examination, multiple soft erythematous nodules with surrounding erythema, induration and peripheral desquamation extending from below the knee to the dorsum of left foot was noted. Localized warmth and tenderness were noted and all peripheral pulses were felt. Lead is considered were acroangiodermatitis of Mali, sporotrichosis and Kaposi sarcoma. Biopsy and dermoscopy were done which was suggestive of acroangiodermatitis. Venous Doppler confirmed bilateral lower limb varicosities and HIV serology was negative. Patient was diagnosed with left leg cellulitis along with acroangiodermatitis of Mali and was started on parenteral antibiotics given for 1 week, following which patient was lost to follow-up. Moving on to discussion, acroangiodermatitis is a benign reactive angiodysplasia of cutaneous blood vessels often seen in association with venous insufficiency or with certain vascular anomalies. It presents as violaceous macules, indurated nodules or blocks, usually bilateral on the extensor surfaces of lower extremities. It occurs in 5 different clinical settings such as chronic venous insufficiency, arteriovenous malformation, chronic renal failure treated with dialysis, paralyzed legs and amputation stumps. Pathogenesis, severe venous chronic venous stasis leads to elevated capillary pressure, which further leads to chronic tissue hypoxia, resulting in neovascularization and fibroblast proliferation. Variants, Stewart-Bluford syndrome is a congenital arteriovenous malformation of lower leg with multiple avulsions. Mali type is an exaggerated stasis dermatitis seen in elderly patients, usually bilateral, associated with chronic venous insufficiency. All the patients in our case series had this variant of acroangiodermatitis. Third variant is known as dermite occur of favor, is an acroangiodermatitis occurring in first pregnancy, presenting as gravity purpura on lower legs over the site of venous varicosities. Fourth variant is an angiodermatitis occurring after placement of arteriovenous shunt for hemodialysis in chronic renal failure. Histopathology findings include diffuse proliferation of small blood vessels lined by plump endothelial cells, along with superficial perivascular infiltrate of lymphocytes, histiocytes, and plasma cells, extravasated RBC, hemosiderin deposition, and minimal perivascular fibroblast proliferation. Unlike Kaposi sarcoma, vessels are regular in morphology, and lining plump endothelial cells do not show any atypia. Dermoscopy findings include irregularly distributed polymorphic vessels, along with white structureless areas, which correlates with proliferating vessels and dermal fibrosis respectively. Differential diagnosis include Kaposi sarcoma, stasis dermatitis, prurigo nodularis, lichen planus, and deep fungal infection. Treatment options, mainstay being the correction of underlying vascular abnormality, usage of compression stockings, macrolide antibiotics, dapsone, and topical corticosteroids. To conclude, our case series showcases the varied clinical spectrum of acroangiodermatitis, which frequently leads to diagnostic confusion with other dermatological conditions and underscores the importance of biopsy in establishing an accurate diagnosis. Addressing the underlying vascular abnormality is essential for effective treatment and resolution of cutaneous lesions and preventing the recurrence. These are my references. Thank you.
Thank you, Doctor. You presented a good compilation of a very rare condition. Thank you so much. So that brings to the conclusion of this session. I once again congratulate all the presenters and wish a great success ahead for you. And I conclude the session by thanking the organizer for giving me an opportunity to be a chairperson for this session. Ladies and gentlemen, have a great day.
Thank you, sir. Thank you, sir. I now request Professor Dr. Jayaka Thomas, sir, to felicitate Professor Dr. Gopalakrishnan, sir. We shall now break for tea. I request you all to report back in 20 minutes so we may begin the next session on time.
Good morning, everyone. Good morning, everyone.
Welcome back everyone. Welcome back everyone. We now have a very informative recorded guest lecture session which will be chaired by Professor M. Krishnakant sir from Department of Dermatology at Ramachandra Medical College and Research Institute, Professor Murali Narasimhan sir, Professor and HOD at SRM Medical College and a visiting consultant at Hyundai Medical Center. I request sirs to kindly take over for the session. Sirs, please.
Good morning all. Good morning all. Welcome you all to the third day of Teledermatology conference. First of all, I thank Professor J.T. sir and Professor Parimala ma'am for giving us the opportunity. So it will be recorded session today of Dr. Rajat Kandari. So the topic will be practical aspects in the use of botulinum toxin. There is no introduction required for Dr. Rajat. He is well known as master injector. So he did his PG from SRMC. So he is keeping up the legacy of Dr. Kandari's family. So we'll go on to the talk of Dr. Rajat.
Good morning, everyone. First of all, a big thank you to Telederm India for giving me this opportunity to present practical aspects with botulinum toxin in clinical practice. I'm afraid I couldn't be there, but I'm sending across this presentation on recording. Botulinum toxin is also known as the art of balancing facial expression. And you can see in this photograph that there are elevators and depressors of the face, and they have a balance in between them. And if you knock one out, the other one seems to compensate or become a little more active. It is key that we maintain this balance while we are injecting our patients. And in the upper face, we've got the frontalis, which is the elevator of sling out here, which is the eyebrow, and the depressors are the corrugator supercilii, the depressor supercilii, the procerus, and the orbicularis oculi. In the lower face, the other sling of the face is the lip, which has again elevators and depressors, wherein we are mostly working on the depressors, which are the DAO, the platysma, the DLI, and at times masseter, not really the depressor, but in the lower face, a muscle of mastication. Botulinum toxin treatment can sometimes be a little more complex than it appears to be, because there is huge inter-individual variation in anatomy. Each patient has a unique desired aesthetic preference, especially in brow aesthetics. And no universal treatment protocol can suit all the patients, which is why one needs to tailor the approach to maximize our patients' satisfaction. Starting off with the upper face, these are glabellar injections. What we have been taught about the glabella is targeting the depressor muscles in a particular fashion, wherein we target the procerus, the medial and lateral aspects of the corrugator muscle. The latter is injected above the eyebrow, and a 5-point injection strategy with 4 units each site, which is suggested, and this is how we typically used to do them. And this corrugator, you can see that I'm a little higher than the brow into the belly of the corrugator, needle pointing away from the orbit, and that's how we used to inject the corrugator bellies. However, what we have learned that when we did this or treated the corrugator a little higher up on the brow and the tail even higher up than that, it led to something called a medial brow drop, because of the toxin diffusing into the lower medial fibers of the frontalis muscle, which is the elevator of the brow. And the reported incidence rates for eyebrow ptosis were reported to be 3.1% due to hitting this frontalis muscle. So what we were doing, we have changed that strategy, or there is being a change suggested, wherein we place our injection a little lower than what we were taught. That means the procerus comes in a little lower down, as does the corrugator just below the brow, and the tail of the corrugator very close to the brow. And something like this you can see in the red are the points wherein we were injecting, and in the green are the points shown wherein we should inject. And just placing these muscles precisely maybe a centimeter down or helps us in avoiding hitting the medial fibers of the frontalis and does not cause a brow drop. This is also known as the GLOW 3+2 injection technique. And you can see here now on the corrugator, once I'm at the corrugator, I'm asking the patient to frown, and I'm more perpendicularly deep down rather than going up on the corrugator belly, which was previously practiced. So this is also known as the 3-point injection technique, and it has been suggested to avoid medial brow ptosis. Once again, the procedure is a bit low, and you can see that the corrugator deep down, closer to the bone rather than up wherein the frontalis is lying, so as to avoid the fibers of the frontalis. A common problem faced, not that common, however, but a problem faced sometimes with labellar injections is blepharoptosis, and this is a photograph shared by Dr. Greg Goodman, mentor for me, a 1 to 2 millimeter or more drop in the upper eyelid, obscuring the upper border of the iris. This can appear as early as 48 hours and up to 7 to 10 days after an injection, and can last 2 to 4 weeks or even longer. And it happens due to hitting the levator palpebrae superioris muscle. Out here you can see that when we're doing the tail of the corrugator a bit low, this muscle can be hit through the superior orbital foramen. This is the retractor of the upper eyelid. So if you hit this, you will tend to get a brow droop. So inject as superior as possible from the boundary of the rim. However, we don't want to go too superior, so we want to maintain a balance. We want to be close to the brow, yet not below. So non-dominant finger can be kept just below the brow to prevent this diffusion. Apraclonidine drops or brimonidine gel both have been tried to give the patient a retraction of the upper eyelid in the event that this occurs. There has also been suggested small dose of botulinum toxin into the pretarsal part of your orbicularis oculi in order to raise the lid. Coming to upper forehead expression lines, there are various ways to tackle these. One is the parallel line or the wave pattern. We've got the C line concept, the M pattern, and the brow lift. So you can see that out here this is the wave pattern, or you can do the same thing in a parallel line. However, the number of points and the number of units required in men many times is more than what we require in women, and we have done a systematic review of the current recommendations in men which concur with this theory. This is also known as the C-line concept. Now, what is the C-line concept? I would like you to see this video. And if you see my hairline comes down, I'm going to play it again, and my eyebrows go up. So it is suggested that the frontalis muscle has a bidirectional movement, and it converges at a particular point, which is known as the convergence line or the C-line. And this is typically 60% and 39% or 40%. So 40% on the top and 60% below on the forehead, and this is where the line converges. So one part of the muscle is taking your brows cephalad, however the other part of the muscle is bringing your hairline chordally. Where they two converge is known as the C-line. Why this is important is that it is said that a higher dosing can be suggested above your C-line intramuscularly, and a lower dosing maybe even in an intradermal pattern below your C-line in order to not cause your brows to drop and not affect the medial and the lower part of the frontalis too much, and give the patient a reasonably and nice outcome. And the third technique, also known as the M-point injection technique, and I'm just going to go through this in this short video. What is the glorified M-point injection technique while treating the frontalis with botulinum toxin? We mark the lateral limbal lines on either side of the patient. We leave 2.5 centimeters as a no-go zone above the supraorbital ridge. So this is a no-go zone in the ridge. This creates a box on the The base of this box forms the base of the M per se. 2 points at the lateral limber lines and 1 in the center. In between these 2 points forms the peaks of the M at the top. 4 units of onabotulinum toxin, and each of these points forms 20 units for the frontalis. This is the M technique for treating the frontalis. So this is what's been suggested as the M technique, wherein you do 20 units for the frontalis. But if you see this photograph in men, because of a longer frontalis, this is me being treated by the M point technique. And you can see that the lateral fibers of the frontalis have been left out, and which is giving me a Mephisto or a Spock appearance. So all you need to do when you're doing the M point is you see this yellow point, and that's the anti-Spock point. Do not forget this point and maybe make a slight modification to your M in people with a longer frontalis. Be wary of individuals with a primary lid ptosis, these people already have a slight lid ptosis or a brow ptosis, because these are individuals wherein if you hit the lower frontalis, they will feel worse, or they might even feel that they are getting a secondary blepharotosis. And 45 to 65% of Asian women may present this, so please document with photography pre and post. This is a patient of mine who already had lid ptosis, and I injected as per the textbook. However, I possibly did too much of a dose on the lower frontalis and ended up giving her a secondary blepharotosis or a pseudo blepharotosis. That means it was already existing and I made it worse. And hand-holding and counseling is required, and it wears off in some time, but it is rather frustrating for the patient. So be cautious in such scenarios. As for the lateral canthal lines, in this particular area, we've got from outside inwards epidermis, dermis, muscle, fascia and fat. So your injections need to be superficial, raising a bleb, just like you see in this photograph, to hit the lateral fibers of the orbicularis oculi, the lateral vertical fibers of the orbicularis oculi, to treat the crow's feet or the lateral canthal lines. Be 1 to 1.5 centimeter away from the lateral orbital rim, giving digital pressure out there. At times, these lines extend way beyond the usual boundary, and in such individuals, one needs to be wary not to go too down towards the zygomatic arch, because you might end up hitting the origin of the zygomaticus major and minor, and this may lead to an upper lip ptosis or an oral sphincter incompetence. So be wary in such cases. Maybe a filler would be a better option. Coming to the lower face, that's me again. You can see elevators and depressors. That's the elevator, and these are your depressors. And again, a big depressor is the platysma muscle. And again, so we've got elevators and depressors and a balance between them. This is an ideal patient of lower face injection with botulinum toxin. You can see the DO hypertrophic, the mentalis hypertrophic, and so is the platysma. So inject these muscles when you can feel them and see them. Do not inject the lower face if you cannot feel and see your muscle, because the margin of error here is a bit minimal. When we're doing the depressor anguli oris, it's a fan-shaped muscle, broad at the base, and while it is suggested to treat this muscle a little higher up towards the belly, maybe a centimeter across the oral commissure and about 2 centimeters below. In many of the old textbooks, it is suggested that in Asians, the modulus may lie at the interchelion line or below the line. So it's a good idea in Indians to keep your injections towards the base of the muscle. And an easy way to do that is to draw a line from the nasal ala down to the mandible, and just medial to that line, we inject 2 to 4 units or up to 5 units of neurotoxin superficially. We don't want to go deep here, and we want the needle to be pointing away from the midline. Because if you're towards the midline, you may end up hitting your depressor labii inferioris or your orbicularis oculi muscle. which will cause a sphincter incompetence or an asymmetric smile. This is how we do it. I've asked the patient to express. You can ask them to invert their lower lip, needle pointing away from the orbit, from the midline, and a small bleb raised. Hitting the DLI leads to something like this, which is an asymmetric smile, and it's again fairly frustrating. One may try to hit the DLI on the other side, or wait it out for about 2 to 4 weeks, and this starts improving. So as for the mentalis, you've got the needle pointing medially, not laterally, again to avoid hitting the DLI. Stay below the mental crease. Be conservative with your initial dosing to avoid diffusion to the auricularis oris muscle in order to avoid a sphincter incompetence. 2 to 4 units either side or 2 bellies of the mentalis, as seen here in this photograph. Coming to the masseter muscle, the masseter is a muscle in the lower face, which is a muscle of mastication. This muscle has 3 heads. In the yellow, we see the deep head, the blue, the intermediate head, and the red denotes the superficial head. We want to restrict our injections when we're doing the masseter to the posterior inferior quadrant and the anterior border of the masseter, which can be felt when you ask your patient to clench the teeth. The reason for injections in the lower posterior quadrant is that you restrict into the belly of the muscle, as well as not going towards the other muscles which help in attaining the smile, such as the risorius. You can see I'm using a longer needle while I'm injecting, a 13 mm needle, so as to hit all the heads of the masseter and not just the superficial head with an insulin needle. Minimal dosing is 20 to 25 units in the masseter, and should be restricted to 60 units per masseter to avoid inadvertent diffusion. We barely ever do 60 units. It is a high dose and a recommendation which is fairly old. So I would say 20 to 25 up to maybe 40 units is a good even for a bulky masseter. You can see out here I've done 40 units each side on the right, and 1 month post-toxin, no effect. So this is because I used a smaller needle, insulin syringe, and did not hit the deep head. And on the left you can see that I've hit the risorius muscle. And a crooked smile, 10 days after toxin for the masseter. This is because of hitting the risorius muscle, which attaches superficially on the surface of your masseter. Or you attempt to do a not so bulky masseter. So make sure it's bulky. Don't be in a hurry to do it so as to avoid such inadvertent side effects. And a proper needle length used can hit the deep head and give you very satisfactory outcomes, as seen in this photograph. Rarely you may get popping of the deep head, wherein you hit the superficial fibers but not the deep fibers, as seen in the photograph above. And in the photograph below, you see a soft, flabby, superficial masseter belly. That means you hit the deep head but miss the superficial head of the masseter, which is typically suggested to be due to a deep inferior tendon. So at the end of the day, what should one do? Because if we're going deep, we might even miss the superficial head. So some authors have suggested a bi-level technique. That means you go deep and also a little conservative dose superficially in order to do justice to your masseter muscle and all 3 heads. Rarely, even after doing the masseters, a little broadness is left below, and this is your parotid gland, and injections into the gland can give a good outcome and a complete narrowing down of the face. Even after doing the masseter muscle with treating it with botulinum toxin, sometimes the parotid is left out as a boggy swelling around the jawline. To conclude, I would just say that botulinum toxin should be used in a precise manner. Know your anatomy well, and treat the lower face muscles when they are visible as well as palpable. Thank you very much for your patient listening.
Definitely, we all could have been very well explained by this toxin practical tips. Dr. Rajat clearly explained how to balance the elevator and all the pressors in all the injection points. Thank you, Dr. Rajat.
One important thing that he stressed upon is, as Sir said, the balance between the elevators and the depressors, and it is very important to know the facial anatomy and its variations, because as he said, pre-treatment photographs, many of the people above the age of 55-60 will have liptosis that is already present. And we may exacerbate it by injecting into the normally told areas. So pre-treatment photographs should be taken and assessed before we go on for the injection. So the next lecture would be on post-COVID status and patients' feedback on teledermatology from Nepal by Professor Anil Kumar Jha. Can we have the presentation?
Namaste, everyone, and greetings from Nepal, Kathmandu, Daishak. Good morning, everyone. First of all, I would like to congratulate INSTED for organizing this conference, and I wish it as a grand success one. I would apologize that I was supposed to present it in person, but due to some unavoidable reason, I could not come and meet you all. So I want to present it as from here virtually or as a recorded slides. So my topic, post-COVID status of teledermatology in Nepal. Before presenting it, I would like to thank the organizing committee and especially the Professor Jacar Thomas and the whole team for giving me opportunity to present this topic. Now, post-COVID status of teledermatology is particularly meant after the COVID. But first of all, I would like to highlight something about the pre-COVID. Why it has been named as a post-COVID is the total scenario changed after the post-COVID, and pre-COVID system of teledermatology and post-COVID system, especially in context of Nepal, had changed. So that is what I would like to talk about some history of pre-COVID situation. Then I'll come to the post-COVID one. Now, this is just to introduce my DI Skin Hospital Daishak family with consultant groups, the same one, the nursing groups, our the management and doctors group and the management team. As I said, I'll try to just express some part of the history of the teledermatology in Nepal. It in fact started in 2009, and I was impressed by this book, especially teledermatology. This telemedicine and teledermatology by Gunter Bob, the Professor Emeritus in Switzerland Medical University, and I happened to go there for small training and under him, and he gave me a book, and in fact this was mainly meant for the e-learning purpose. But I thought that in country like ours, geographical status like ours, more than e-learning, the distant service was more important. So I tried to think over it, and then after that, we started a project free of cost in 3 villages. As you can see, this Mudikwa, Nuwakot and the Babangama in different geographical region of Nepal. This is the map of Nepal, and in different the mountain area, the high mountain area, and the Tarai region. And these three were the target villages operated to start with the telemedicine, not through the internet, because there was no internet present at that time in these areas, no health centers, no health personnel as such. But we chose, our criteria was that only, so we chose 3 target villages, and we started the services through intranet and not internet. So, I would like to just highlight the pre-COVID situation, and we can see the different villages situation, the roads, and without any health services provided to that village. And very interesting is this prescription, that from here in Kathmandu we used to write prescription on the board with the name of the institution, the council number, and prescription written on board, and it was projected in the villages through intranet method, and the patient used to take photograph and mobile, and they used to buy medications from the pharmacy or get it from the Kathmandu itself, which was not available there. In some of the villages, we used to provide the medications through pharmaceuticals sponsorship also. So these were the activities of different 3 centers where we used to give the services. This is one of the examples from Kathmandu. We are giving services with this tower. You can see we are providing the internet method, and this is the pre-COVID situation. Now the infrastructure of this technical infrastructure was that we were providing at that time real-time streaming, store and forward method, various services provided, not only the dermatological but health services, skill development training, public awareness through internet in these 3 villages. And CHEST was our organization or non-governmental organization registered as CHEST, Community Health Education Services by Telehealth, and this is still the organization under the DISHAC. We are working together, and this system went till COVID, and surprisingly, I would like to share everyone that though we are providing these services free of cost in 3 villages, and still we have those satellite centers. Before COVID, those people from those villages, they were not believing our services. Maybe it was because it was free of cost, or they could not understand the purpose, and we tried our best to give the services. There were people accepting, but not many of them. But this totally changed after the COVID era, because of the internet facility, people being aware of mobile, using the mobile, and using the services from home during the COVID period. So pre-COVID, COVID and post-COVID we are talking about. This publication that we are seeing, reaching the unreached, a model for sustainable community development through information and communication technology, was the first publication regarding our services through the CHEST and teledermatology. This was the second publication, Teledermatology in Nepal, 2011 and onwards, a model providing sustainable healthcare and educational services helping overall community development in community dermatology. This was published in that one, and we can see Professor Gunjabov here. He used to come here on and off and help us to run these services. This is one of the villages where we wish to give the services through intranet method. Now before COVID, the publications were published with the intranet system of the teledermatology services were in 2011, Journal of Nepal Medical Association, then Community Dermatology Journal, after that Daishark Newsletter 2017, and 2017 again reaching the unreached Daishark Newsletter. We had a challenges while providing telehealth services in developing countries, and this was because we were feeling difficulties, mainly the people acceptance of these services. Why I am repeatedly saying this is that I am going to highlight that in post-COVID era, how much people started accepting the teledermatology, and to make them believe we were not only giving the services in dermatology or for treating skin diseases, but we are giving the services as a skill training and the educational training too in the schools. Now this Daishark Newsletter success factors of telecommunications in rural areas, innovations and acceptance. So this was one of the publication 2019, and where we started facing the COVID era. So we will be going beyond that now. Daishark Community Services, teleconsultations and related activities. Just we are saying we were after the villages, target villages, then we started giving services, and that was paid services. The 3 village satellite village was free of cost till date, but other villages and other provinces of Nepal, the services started through that system. You can see many districts and zones and provinces we had provided the services. We started giving the services from the like follow-up cases from Daishark, and even the fresh cases from the village area and the remote area in different places in Nepal. We can see November 2029 to 20, then here it is very significant that we can see during the COVID era, the maximum number was there patient, because it was shut down, so more people were taking the services. Then 2020 reduced, 2021 reduced, and again reduced, and this was intranet method. But after that, when we started the internet method after COVID, after few 1 year pause, you can see suddenly the graph increases because people started taking the services through internet from their home itself, and we started the online home consultation after that. Not only the services to the villages, but we did a few activities like ISAT International Conference based on the first international in Nepal, first international conference on e-health and telehealth. This was done by this chest and Daishark in 2000. You can see there the ISAT, our logo who are involved from abroad and from Nepal. And I'm sure you all recognize this great personality, Professor Jacob Thomas, who is the organizing chairperson of this conference, the in-state chairperson, and you know him very well. So I would like to regard him because he was one of the persons involved in this international e-health and telehealth. So for this region, these activities were done to make it more familiar, make it more interactive, so that you can do more and more activities. Now, just to before the COVID, we are at the end of the slide, almost before COVID history. After that, we will be entering in post-COVID era, the main topic for today. And here we see that community health education services, Chest Nepal activities, different types of services, certificate distribution, skill training, the medical dermatology services, and all the conferences and all that. Now this is before the COVID area. This is I would like to say, it's my pleasure to say that we were awarded, Daishark and Chest was especially awarded from France Periphawa Foundation for this community services related to the teledermatology and the distance services. It was in 2017. This is the slide I would like to share very well. That here we see that Sarat Teledermatology Subcommittee. This is very interesting. In South Asian Regional Association of Dermatology, we made a subcommittee for teledermatology, and from different South Asian countries, these were young persons helping me to in regard to this type of interactions regarding teledermatology. We had a various the virtual meetings and sharing while COVID time and even after that. Now I'm trying to sum up the history along with the publications of regarding teledermatology from Daishark and Chest altogether. And we can see that we have already talked about till 2019, then 2021, 2022. We'll be discussing this in detail in post-COVID area regarding the acceptance of the patient. Consultation, data analysis, we can see how the things are going on here, and we started giving the services out of the Nepal, especially for the non-residential Nepalese staying in India, out of the Kathmandu, that is out of the valley, then India, USA and other countries. So gradually these services increased to 11 countries that I'll be focusing very soon. And that's the online services for the Nepalese who are staying outside the valley or Kathmandu, that is capital where we are at present, and the other cities of Nepal and outside the Nepal, that is abroad. This one is a very iconic presentation, or you can see the publication of the Daishark, like telemedicine and community health projects in Asia, multiple authors, international authors, and from many countries. We said we studied on this and we published this in Global Dermatology and Telemedicine. Some of you might have seen that it was in January 2021. just after the COVID, we also did a virtual international conference of teledermatology on 2nd October 2021 called as VCode, and again the whole SAARC countries was involved in it as an organizing committee, and all the youngsters that I have focused before were involved in this the virtual conference. The organizing committee of VCode, the detail, and this is what I want to today in this topic of post-COVID era. This is my focus article where I am going to explain you, especially regarding just a comparative evaluation that the public were not accepting or believing on especially the free services, but after COVID, when they were started taking the services from home, and after the internet era all around the country, the people started accepting very well. Especially this article is very important in this regard, and I would like to thank my junior colleague Krishna Jha, who helped me to make this or study this article and helping in for publications too. We can see the number of the cases, how in 20, then 20 I have shown the previous graph. Now we can see how after 20 slowly going on, then relieving the internet services from home, and there was a spike after that from national and international level or in abroad, we started giving the services. So the trend of teledermatology consultation. Here we are. The main objective of the presentation today was the patient acceptability post-COVID area and the detail regarding our last publication. You can patient dermatology, the demographic data. Total patient 122 we had taken. New cases were 60.7%. Follow-up cases 39.3%. Mean age 17.89, the gender male 40.2%, female 59.8%. Mean duration of illness, there are 4 days to 144 days and months too. And then average distance from the capital or from our hospital 157.20 kilometer. All of you know by now Nepal is a small country geographically, so 157 kilometers matters for the country like Nepal. From the institute to the patient, the distance I have explained, the residence from institute to the residence of the patients. Average travel time 889.52 minute. Definitive diagnosis 91.8% clinical diagnosis. Probable diagnosis 8.2%. Then Daisha teleconsultants during COVID-19 and onward, in a study of 22 cases, we see that acne vulgaris, eczematous disorders, fungal infection, pigmentary disorders, papilloesquamous disorder, bacterial and viral infection, hair and nail disorder, sexually transmitted diseases, urticarial disorders, others then immunoglobulous disorders, and both acne vulgaris and melasma. And diseases acne vulgaris 8.2%, acne vulgaris pigmentidura 3.3%, eczematous dermatitic disorder 13.9%, fungal infection 24.6%, papillosquamous disorders 2.5%, bacterial and viral infections 0.8%, arterial disorders as such 15.6%, hair and nail disorders 5.7%, sexually transmitted diseases 0.8%, immunobolus disorders 0.8%, other diseases 2.5%. Sexually transmitted diseases we can imagine in distance services or the teleconsultation or the teledermatology, how difficult it is, but still we had some patients. Other diseases 2.5%, total 100% and 122 were the total number of the patient. Parameters, responses and percentages. This is very important. I would like to request everyone to kindly give your attention here. The convenience, ease of use, yes and no. So 91% said yes. No, 9% able to express oneself, yes, 84.3%, no, 15.7%. This is very important study. Same as an in-person visit. So comparison between the in-person and the distant or the teleconsultation. Yes, 55.05%, no, 44.95% or 95%. Satisfied with the service, yes, 89.9%. This study was done in 122 patients, as I have mentioned earlier. So satisfied, 89%, not satisfied, 10.1%. Will use in future. So patient said, 85% said, 95.5% said, yes, they will use this service, but they said no, that was only 4.5%. Now teleconsultations, patients feedback to the previous one feedback 1, this is feedback 2, age, sex, male, you can see the female, then registration, new 153, and here too diagnosis, definitive diagnosis we have already discussed 73, and the no was 8, definitive diagnosis, probable diagnosis 7, and here the 1. After that patient residence inside the city institute location, we can see the 27, and out was 2, outside the city 53, and here 7. Disease diagnosis, we have already read about it, gone through it, but I'll just read the name of the disease: acne vulgaris, pigmentary disorders, acne vulgaris and pigmentary disorders, eczematous dermatitic disorders, superficial fungal infections, papillosquamous disorders, bacterial and viral disorders, arterial disorders, hair and nail disorders, sexually transmitted diseases, then immunobolus disorder, other diseases too. P-value was significant. This is very important. As you might have seen, 95% acceptance was there for accepting these services, but surprisingly, this was almost post-COVID, after internet service was provided, not with the internet services, and because the patient had to come to the centers, and here they were taking the services at home. home. So they like to take services at home. Now, this is a model of prescriptions that is on online home consultation, DI Skin Hospital Referral Center, the detail and this, and after that we have this setup. Now it is more modified, but this is the previous prescription that we use to provide the services. This is sent to the patient, and of course inside the country they can make the medication available. But interesting is that outside the countries, abroad, of course this prescription is obviously not honored. And once it is not honored, the arrangement is that the patient who are staying outside or non-residential Nepalese receiving this online prescription, they send back this prescription on Viber or WhatsApp to their relative. That is printed out, and once it is printed out, they printed out prescriptions, and purchased medications are sent to any part of the world where the patients are, and through the person or through the post, and till date this service is provided, and this is supposed to be a legal one along with the printout prescription. Because all details are here, the consul number and the name, the institution, the stamp and everything. This is also one of the interesting slides to show you all that this is one of the apps made for online home consultation, how the patient can go on. But initially it was through the Skype, and in Nepal the paying service, the most prevalent one is eSeva, and now we are providing it through the WhatsApp or Viber and eSeva. They follow this step, and from any part of the world they get services from us, especially for the Nepalese who are staying outside and those who are staying outside of the valley, so that they don't have to come from far distance for follow-up in 15 days, 2 weeks or 4 weeks. So this is mainly meant for them. It is not promoted for the patients staying inside the valley, except in very extraordinary situations where the patient cannot move. This is just to show you that in 2000 different countries now, from the initially you saw that during the, especially till the end of the COVID and all that, it was only few countries, and the services has been extended now to 11 countries. Now another interesting thing is just to have a comparative chart. The services are, numbers of the patients are increasing, number of the countries are increasing, and more interesting is sometimes it has been seen that the local patient who comes to us, they say that they have been recommended from, suppose, Australia, US and Europe, where they were from their relatives to come to this hospital. Another interesting thing I would like to tell you, the fact that suppose non-residential Nepalese staying in UK. Now in UK NHS services, when they refer a patient to a dermatologist, usually the fact is they have to wait around 2 years, not 2 months, it is 2 years. In US, average period after referring a patient to dermatologist, we may be aware of that, it is 2 to 3 months minimum. And mostly they are seen by GP, general practitioners, or the general physicians in US, and in UK the services are provided by National Health Services. So Europe, the other part of the Europe also, it takes 3 to 6 months for the patient to get dermatologist. So in this situation, if we want to serve our countrymen, the country people, I think these distant services or the teleconsultation or teledermatology or digital dermatology, whatever you say, is very important and practical method to provide the services to our people. And I think I try to express myself. I am very thankful again to whole organizing committee members, and again wish them all the best. And Professor J.K. Thomas, if you are watching this, I am very much thankful to you, and I am very much sorry for the inconvenience that I could not present this in person. Thank you, everybody. Thank you so much.
So the next recorded talk will be the role of IL-23 in the treatment of plaque psoriasis.
So these are my good morning. I have already conflicts of interest with regard to the content that I am presenting. I regret I cannot be there in person to deliver this talk. Nonetheless, an absolute honor to be able to share my thoughts with you. And I thank the organizing committee at INSTEC in particular. A thank you to my mentor, Professor J.K. Thomas, for inviting me to do this. So I was actually pondering what would be a good topic to talk about, and it struck me that the advantage of practicing in Dubai is that thanks to a relatively robust healthcare system and healthcare insurance, we have access to quite a lot of the biologics and other so-called high-cost drugs, selective treatments, which are available for a host of immune-driven disease. And with Telederm just hitting the Indian market a few months ago, I thought it would be best if I share with you my experience in the use of selective anti-interleukin 23 inhibitors in the management of moderate to severe plaque psoriasis. I do hope you find this useful. So these are my disclosures. I have no relevant conflicts of interest with regard to the content that I am presenting. Few numbers before we start. We're familiar that psoriasis is a very common disease. In India itself, the prevalence rates are about 2.8%. Figures are even higher in Scandinavian countries. In the Middle East, the region where I practice, the prevalence rates reach up to 0.5 and 8% in literature. But I'm inclined to thinking that these are probably underestimated figures because we have a paucity of organized studies in the region. All in all, psoriasis contributes to a reduced life expectancy by about 3 to 4 years. And this is largely due to the systemic comorbidities associated with the disease. And that brings me to this concept of the psoriatic march. We've all heard of the atopic march. The psoriatic march is a less spoken about entity, and it refers to the amplification of what appears to start off as a localized cutaneous phenomenon. So psoriasis on the skin gets amplified over a period of time into a more systemic inflammatory response. And that is why we see psoriasis can be linked with so many systemic diseases. It's a well-known fact that 3 out of every 10 of our patients with psoriasis are at risk of developing psoriatic arthritis at some point in time in their life. The link with cardiometabolic disease is very common. There are other systemic diseases as well. And what I'd like to focus on is the link between psoriasis and inflammatory bowel disease. Again, an entity that is hardly talked about. So it is estimated that a patient with psoriasis is up to 3 times at greater risk of developing Crohn's disease. And a patient with Crohn's disease is up to 7 times at risk of developing psoriasis. So there appears to be a strong link between the two. Now it is for these reasons, the prevalence of the disease, the physical and psychological morbidity of the disease, and of course its association with various comorbidities, that the WHO has now recognized psoriasis as a serious global health problem. And they have urged physicians like you and me to diagnose the disease early. They have encouraged early intervention with safe and effective therapies in order to halt the psoriatic march. I think gone are the days where we relied on salicylic acid, coal tar, or balneotherapy for moderate to severe disease. Thanks to the advent of biologic therapies, which started way back in the early 2000s, we can now promise our patients a better quality of life. So in 2003, we know that alifacept was the first agent that was approved as a biologic in the management of psoriasis. It was later withdrawn due to its side effect profile. But after that, we had an avalanche of various anti-TNFs. And this was because at that time, it was believed that TNF was the key cytokine incriminated in the pathogenesis of psoriasis. We do know now that the concept has changed, and we know that psoriasis mainly revolves around the IL-23, IL-17 axis, and that's why we have all the newer drugs that are being evolved now center around these two classes. I'm not going to go into the intricacies of the immunopathogenesis of psoriasis, but what I would like to highlight is what's in this box here. So we do know that the myeloid dendritic cell, once activated, enters the lymph node, and in the lymph node, it produces a host of pro-inflammatory cytokines. The two notable ones are interleukin 12, which is the key stimulator of the T helper 1 cell, which produces mainly TNF-alpha and interferon gamma, and then there's interleukin 23, which is the key stimulator of the T helper 17 cell, which produces its cytokines, interleukin 17 being the key effector cytokine in the immunopathogenesis of psoriasis, which means that the key master regulator, the kingpin, the dawn of this immune repertoire is actually interleukin 23. So to highlight again, interleukin 23 is what stimulates the pathogenic T helper 17 cell, and that produces the pathogenic effector cytokines. And we are all familiar with what interleukin 17 along with its friends do, and that for your information is highlighted in the green box. But is it prudent to really shut off interleukin 17 completely? Probably not. Interleukin 23 has no effect on the non-pathogenic T helper 17. And this produces some amount of interleukin 17, and shutting this off may not be prudent. And the reason for this is we know that interleukin 17 has important roles in antimicrobial defense, particularly fungi and extracellular bacteria, mainly at the mucosal interface. And that's why when you shut off interleukin 17 completely, what tends to happen is that the patient is more at risk of getting candidiasis. Interleukin 17 also plays an important role in epithelial barrier, particularly mucosal barrier protection. And that's why patients on interleukin 17 inhibitors are at risk of unmasked inflammatory bowel disease in patients who are of course susceptible to the disease. So why should blocking interleukin 23 be an effective strategy? As highlighted previously, it is the master regulator of psoriasis because it stimulates the T helper 17 cell, the pathogenic T helper 17 cell. What's less known is its effect on the tissue-resident memory cells and the Treg cells. Now what interleukin 23 does is that it promotes the proliferation and the survival of the tissue resident memory cell, and we know that this is the reason why psoriatic plaques keep coming back in the same place. It's because of the homing of these tissue-resident memory cells. Additionally, interleukin-23 also promotes the differentiation of the T regulator cells to the T helper 17 cells. Keep in mind that the immune system, put it very simply, is like a seesaw. On one side you have the T regulator cell, on the other side you have the T regulator cell has anti-inflammatory property. On the other side is balancing this act are the pro-inflammatory T helper 17 cells. T helper 1, 2 and 17. And 17 is the one that we blame in psoriasis. So what IL-23 does is that it pushes the T regulator cells towards the T helper 17 cell line, and this dampens the anti-inflammatory effect of the T regulator cell. Also, interleukin-23 induces macrophages to release TNF-alpha. And we know that though TNF-alpha is not primary cytokine in psoriasis, it acts synergistically with its best buddy interleukin-17 to create the havoc that it does. So a little more about interleukin-23. It is a heterodimeric cytokine, which implies that it has two moieties, P19 moiety and a P40 moiety. And this P40 is also present in the interleukin-12 cytokine. So when you use a molecule like ustekinumab that binds P40 that's present on both interleukin-12 and 23, you're blocking the effect of two cytokines. This sounds like a really good strategy, and it sounds like it will probably be one of the most effective agents in psoriasis. But two issues with this. One is that the pharmacology, pharmacodynamics of ustekinumab is not as favorable as the pharmacodynamics of the selective interleukin-23 inhibitors. The second thing is that when you block both these cytokines, you're blocking both the T helper 1 pathway and the T helper 23 pathway. So the T helper 17 pathway. So what tends to happen is that you're blocking off interferon gamma and TNF alpha. We do know that these play an important role in controlling intracellular organisms, not just the tubercle bacillus, also organisms like pneumocystis, toxoplasma and salmonella. And due to this, the theoretical risk of side effects is higher. So we have the selective interleukin-23 inhibitors, and what they do is they bind on to the P19 component of interleukin-23, thereby only inhibiting the effect of interleukin-23. Three that are approved are guselkumab, risankizumab, and tildrakizumab. Put mirikizumab in a separate box because though it did well in clinical trials, Eli Lilly decided not to send it for approvals for psoriasis. Due to a business strategy, it has now been approved only for inflammatory bowel disease. Particularly only going to talk about guselkumab and risankizumab because these are the two molecules that I have personal experience with. Tildrakizumab is just about to hit the Dubai market. I think a molecule in psoriasis can be considered really effective if it does well against what were at that point in time in 2020 the gold standard in the treatment of psoriasis, and that is interleukin-17 inhibitors. So we have studies both guselkumab and risankizumab where they are compared to secukinumab and also to secukinumab. So I'm just going to highlight them, a couple of them. This is the eMERGE trial, which looked at the safety and efficacy of risankizumab versus secukinumab. So what we are inclined to thinking is that the IL-23 inhibitors work upstream, and so they will theoretically have a much slower action than the IL-17 inhibitors. But this study shows otherwise, because in the eMERGE study that compared secu and risankizumab, what we see is short-term in week 16. Risankizumab is not into secukinumab, and you see long-term at week 52, a clear winner, risankizumab sprinting ahead of secukinumab, showing its superior efficacy long-term. There's another study called the AIM study, and here what they did was that they looked at patients who had suboptimal response with either secu or ixekizumab, and they switched these patients to risankizumab. And what we see here is that at the end of 52 weeks, patients who had done poorly with secu or ICSI, 63% of them have clear to near clear skin at the end of week 52 when they were shifted to risankizumab. And this is saying a lot because remember that a bio-experienced patient is always a greater challenge to treat than a bio-naive patient. There's also this concept of modification of psoriasis, and it's been described by at a recent Delphi consensus. It's defined as a sustained improvement in the disease course resulting from a change in the pathophysiology that minimizes the need for treatment. So there are two criteria here. In order to state that a drug has modified psoriasis, it should alter the pathophysiology of the disease. It should reduce the need for treatment. And to highlight that the IL-23 inhibitors will probably be useful in modifying disease, they have two trials, one using risankizumab sponsored by AbbVie, and this was the knockout study. The other was a study by Janssen called the GUIDE study, and it's one of the landmark studies, and it's a very interesting read, and it looks at early intervention using guselkumab in the management of moderate to severe psoriasis. What we see with both these drugs is that the drug is given, the patient responds really well, and the drug is discontinued. The patient continues to have long durations of remission, over 1 year of remission after cessation of the drug. So indeed, when you use an IL-23 inhibitor, you're minimizing the need for treatment. Just going to focus a little bit on the GUIDE study. What they did here was that they looked at patients who were super responders, meaning patients who had clear skin at the end of week 20, and they maintained clear skin, a PASI 100 clearance at the end of week 28 after being on the standard dose of guselkumab. After this, patients who had clear skin at week 28 were re-randomized. So they either continued to receive the 8-weekly dose, or the other fraction received the dose once in 16 weeks instead of 8 weeks. And what they saw at the end of week 68 was very interesting. Whether a patient received an 8-weekly dose or a 16-weekly dose, if the patient was a super responder having clear skin at week 28, there was no difference in the efficacy. They did equally well, even if the dose was staggered and they received it every 16 weeks. Again, showing us that there is definitely a reduction in treatment using guselkumab. Does the drug change the pathophysiology of the disease? Yes, the GUIDE study also showed us that when we measured tissue-resident memory cells in lesional skin, what they found is as early as 4 weeks, the TRM started dropping and it reaches normal levels at the end of week 68. And therefore, we can consider the IL-23s to have disease-modifying role. We'll have to wait for more data on this. So this is why I find that the IL-23 selective agents, and I'm not looking at risankizumab here because it's not a selective agent, has an edge over the others. So what's the edge? The obvious thing is the dosing, the active streams, so they're given every 8 weeks to every 12 weeks depending on the molecule. They found to have sustained efficacy and they have durability. That means they act reasonably fast and their effect lasts long. And very importantly, patients are able to enjoy remissions even after cessation of the drug, which can sometimes last for over a year after stopping the drug. The side effects usually linked with the anti-TNFs, as highlighted in the red box here, are not encountered in patients on the anti-IL-23 inhibitors. The side effects, which are not often, but have been documented to be associated with the IL-17 inhibitors, are not seen in patients with IL-23 inhibitors. Particular mention here is that IL-23 inhibitors, guselkumab, risankizumab, they have been approved even in inflammatory bowel disease. So I'm going to end by just sharing a few of my cases. I've selected three of them. The first one is basically to highlight that the IL-23 inhibitors do act reasonably fast, not as fast as an IL-17, but when you have a chronic disease, I think 3 to 4 months is not a bad time at all. So this was a patient who had class 1 obesity. He was already on methotrexate, moderate to severe disease. He had in fact very ostraceous plaques which came down with the methotrexate. But despite being on this, he never had a PASI less than 10. And so he was started on guselkumab. He also had PAMAR and nail involvement. And these are his results as early as week 12. He's achieved optimal clearance, and that's a PASI improvement of more than 90%. Complete clearance of PAMAR lesions, the nails also looking very healthy. The second patient is a young adult male who had type 1 psoriasis, had used every treatment in the books, severe psoriasis, and these are pictures again whilst he was on methotrexate, touched him at all. He had PASI over 30, so very severe disease. He had scalp and nail involvement, which we know are predictive markers for arthritis. This is him after 4 weeks of risankizumab. This is after just a single dose of risankizumab. You can see tremendous clearance. Absolute PASI has dropped to less than 10. And this is him after 4 months, just after 2 doses of risankizumab, when he came in for his third dose. His absolute PASI is less than 3, which is optimal response. And these are pictures of him before and after, going strong. In fact, these are pictures of him 5 years after treatment. Human tendency is to stagger treatment once better, but he still maintains a PASI 100 clearance. And the third patient was actually a difficult case for me. Again, type 1 psoriasis, middle-aged Filipino male. He'd used every treatment. These are pictures of him while on cyclosporin. He almost always presented in erythroderma when a drug was tapered. Severe psoriasis, PASI over 30. I started him on secukinumab. He initially improved very well with it, but unfortunately developed secondary failure after the 6th month, and particularly bad between month 9 and 12. That's when I started him on risankizumab. These are his pre-pictures before risankizumab. This is him at the end of 1 year. Absolute PASI less than 3, doing very well. A minor recurrence or relapse of his lesions at the end of 2 years, but the PASI is still hovering around 3. For the fact that he's lasted now 3 years with the PASI hovering around 3 is very impressive for a patient who's failed multiple therapies. And my last line in conclusion is to tell you what's new in the field of IL-23 therapy. It is this drug called icotrokinra. Excuse me. It's the first in class oral interleukin-23 receptor antagonist that's completed phase 3 trials and it's shown good promise. In fact, it's made by J&J, makers of infliximab, secukinumab, golimumab, and guselkumab. So we have the fifth drug hopefully soon by J&J. And if this drug is found to be effective, especially if it's cost effective for us, I think it will be a boon to not just us but to our patients more importantly, because their oral convenience will meet this biologic precision. And with this, I'd like to say thank you. I wish the organizers the very best for this conference. And if any of you would like to reach out to me, I'm happy to answer your queries about biologics and psoriasis in general. My contact details are mentioned here. Thank you so much. Good day.
Thank you, Dr. Rohini. It was a really informative talk on the IL-23 inhibitors, risankizumab, tildrakizumab. Now, the good news is that in India, tildrakizumab will shortly be available in about 6 months' time. the biggest advantage with these IL-23s are that you have a longer interval between two doses, and as she rightly has quoted studies saying that even with 8 or 16-week intervals between two doses, patient is able to maintain remission for a very long time. So this is one of the biggest advantages of IL-23s, which are also approved for inflammatory bowel disease. And as you all know that psoriasis and inflammatory bowel disease often coexist, and we are not able to use IL-17s in those patients. And for these kind of patients with coexisting diseases, IL-23s are sure to make a big difference in the lives of patients. With this, we come to the end of this session. I thank the organizers for having me here as a chairperson for this wonderfully informative session.
Thank you all. Thank you all.
Thank you, sirs.
I now request Professor M. Krishnakant sir to felicitate Professor Murli Narasimhan sir and Professor Murli Narasimhan sir to felicitate Professor M. Krishnakant sir.
It is now time for a mind-boggling coffee with expert session where our very own Professor Dr. Jacob Thomas sir will have a lively discussion on practice ethics, legalities and quackery with Dr. Satyanarayan Rao sir and Dr. Rajita Damshetty ma'am. I request Dr. Jacob Thomas sir to kindly take over for this session. Sir, please.
Hello everybody. Hello everybody. I'm sure you guys are ready for a great session. Whether you guys are ready or not, I am not ready. I'm going to have two stalwarts with me. We're going to take care of this particular session. Can I have their CVs, please? Dr. Satyanarayan Rao, SKHS Rao. He is from Bangalore. And he has a diploma from the National Law School. He's been with us. I don't know whether he remembers. I remember 2008 he was with us for Telederm Congress. And we really enjoyed this way. Then he called me for some other meeting at the Dermacon. Then we said when we're having a session like this, we should have Dr. Rao. The next person, of course, she is known as the lioness in dermatology. The lioness. I'm scared. Starts rolling now. I might have to run away. So can I? I don't want to talk much about Rajita because she was my. I did teach her for a brief while when she was in Madras Medical College, and I'm sure she enjoyed attending my classes. Now, can I invite Dr. Rao and Dr. Rajita Damshetty. Welcome to the two of you. The session is called as Coffee with Expert. So you want coffee or tea? Tea. You? One tea and one coffee. One tea and one coffee, please. Tea, coffee, please. It's going to be fun. It's going to be fun. It's going to be fun. Let's not take it very seriously. Certain matters which need seriousness. We will take it seriously. We will take it seriously. Let us start off. We have the next slide. The next slide. It would be nice, first of all, if we could define quackery in the context of modern medical practice, and how it can be distinguished from emerging but unvalidated therapies. I would request Dr. Rajita to please comment on that.
Good morning, everybody.
Good morning, everybody.
It's truly a pleasure
and an honor to be here.
And I'm going to say a few
things about how privileged I feel to be here and to have been in Chennai during those formative years of my life. But for now, I'll tell you how Supreme Court has defined quackery. Supreme Court of India.
So quackery is
an act by an unqualified person or a charlatan.
So when in dermatology,
what is quackery?
Any
non-doctor uses
any prescription medication,
a Schedule H drug, that is quackery.
And this non-doctor
could be,
for our context,
a BAMS person, a BHMS person, or a dentist.
Because they are not
registered medical practitioners.
Then any specialist
or any MBBS doctor who claims to be a dermatologist,
or somebody
who does not have a NMC recognized degree in dermatology, but is claiming to be a dermatologist is considered a quack legally in India. For example, somebody's got a MSc dermatology from St. John's Institute, UK.
Now it sounds very
fancy, but it is a correspondence course. It is a 6-month correspondence course, 1 week of contact classes.
These people call
themselves dermatologists. Sometimes they call themselves celebrity dermatologists.
And right now we have
a case going on, IADVL versus somebody.
CA we call it,
and in the Karnataka Medical Council.
So
most of you would have understood.
So basically
when you lack a degree,
when you are claiming to
have a degree that you do not have,
and you are doing
things that are beyond your expertise.
So when it
is a MBA person
who's doing a filler,
MBA is qualified in
maybe in finance,
but not in fillers.
So these are
in a nutshell how we define quackery in modern dermatological practice.
And regarding
emerging and unvalidated therapies, when an expert in the field, any of us, let us say, or forget expert, anyone who's qualified
and is
using an unvalidated therapy, let's say exosome. Exosome is not approved by any
FDA, not Korean,
not US.
But you tell your patient,
give full disclosure, say that none of the
drug authorities have
approved it, but there is some very good emerging evidence. This is a tried and tested thing in terms of publications of safety and efficacy.
And with full disclosure you do it,
then that is use of a emerging but unvalidated therapy.
Thank you very much. Thank you very much, Dr. Gita. Since you're talking about qualifications, what crossed my mind suddenly is the dispute that is currently going on about membership and fellowship of the Royal College. Do you have any comments on that? Very briefly.
So neither MRCP nor FRCP are recognized in India. They could be honorary, they could be something that you earned by giving the exams.
But if you have
only a FRCP
in India without
having trained in India,
then you would still not be
eligible to be called a dermatologist.
Thank you very much. Thank you very much. We go to another segment. This is to get Dr. Rao involved. About informed consent. Is it necessary for teleconsultation? Your comments on that, Dr. Rao?
Informed consent is necessary even for teleconsultation. Because the telemedicine practice guidelines clearly mention that you both that caregiver and the caretaker have to identify themselves. Only then doctor-patient relationship is established. And you will have to explain the limitations of teleconsultation. And whenever required, or when the situation or the condition or the complexity of the condition demands in-person examination, you are supposed to explain and take consent for teleconsultation. Informed consent is a must before we proceed with the teleconsultation.
With the very fact that they are coming for a teleconsultation, does it mean that they are giving a consent?
As you rightly said, if there is a suppose a telehealth unit where a healthcare or a primary health provider is contacting the specialist through technology and getting the consultation and treating the patient, then the consent is said to be implied. That means they have agreed. They know the limitations.
My dear friend, what is important is you must have a middleman. You must have a middle medical man who is communicating between the patient and with the consultant. Dermatologist or anybody else. You should be there. He is the one who be the first point of contact for us when we teleconsult. And he gets the patient for us. Am I understood correctly?
Yeah. But if the dermatologist initiates, then you will have to take specific explicit consent and record it.
And to be safe and not to burn your fingers, I have a middleman. That's the best thing. A middleman can be a medically graduated person, or it could be a person who's running an institution which also encourages teleconsultation. What socioeconomic and systemic factors encourage patients to seek care from quacks, my dear Aditya, instead of qualified practitioners?
The very interesting and very deep questions. So socially, I think the accessibility, the availability, the language that they speak, the words that they choose. I think patients relate more to them. Economic factors. Now, if you take me, I would let's say somebody requires some acne scar treatment, and I would say, okay, you're going to need maybe 4 to 6 sessions of this, and each session is going to cost. I'm not going to say any of this. My front desk person will say this much, and then you come, you get it done, you pay. We are not going to offer them packages, discounts. We are not going to be offering them a zero interest EMI loans, which is a ridiculous thing, because there is nothing like a zero interest loan anywhere in the world. So, none of us are going to do this. Why don't we? And why don't we? Because we are not business people. We are professionals. So it is not wired into our DNA to do any of these things. But for quacks, it comes very naturally. It comes very, without those, they would not be able to enter this. And then the systemic factors, the most important question, the lack of regulation, the lack of awareness. In Hyderabad, I don't know how many of you followed the big fight that I had with dentists, and all I did was I went to one podcast and I called dentist. I did not say anything bad. I'm not known to swear. So that itself upset them, because for the longest time they used the fact that they had a DR prefix. And then once you say Dr. So-and-so, cosmetologist, a lot of people thought that they are equipped to do this. Now, how many of us are calling ourselves cosmetologists? How many of us know that cosmetology is not a medical specialty? So this lack of awareness, lack of regulation. So in short, the accessibility, the academic packages, and the government lack of initiative.
So there is no buy two, take one. Right, that's what we understand. But do you as a person give any discounts for patients, under which condition you'll be giving? Of course you'll be giving.
Basically, if it is any doctor, consultations are free. But these days we've started asking doctor means which doctor. So for dentists we don't give. Even for so many times it's an engineering college professor with a PhD and all. So there we don't. Only for medical doctors. This is a very recent development. And for all procedures, for doctors, we give the maximum, so a standard of 20-25% discount, which is usually the margin that we have over and above the consumer.
But otherwise we don't.
But otherwise we don't. If somebody wants discount, then we say sorry. If you are not comfortable, then we just do the medical treatment.
Trust me, all these young people out here,
if you say that,
because I am not dying to do their
procedure. They want the procedure, let them get it done.
So they are dying to get the
professional
procedure.
courtesy, only a professional courtesy.
You said something, doctor?
As a professional courtesy,
that's
not as a marketing package.
It need not necessarily be given also. Sometimes I have charged doctors. I don't do any procedures. I have charged doctors. Because what happens is you don't charge Dr. X, Mrs. X. Then they come with X's mother, X's mother-in-law, X's grandmother. Everybody comes. That is not fair, and we cannot afford that. They are not studied for that. And my dear Dr. Rao, what about standard of care to be provided in teledermatology? Do you have anything like that?
Though teledermatology has its own limitations, the expected standard of care is as in-person consultation that we have to make ourselves sure. So the onus of deciding whether teleconsultation is appropriate and enough for assessing a patient online, we have to decide and take a decision. If you have any kind of doubt in assessing online, or if you have seeing a possibly complex case, it is better to suggest in-person consultation. And don't take the risk. Because if a benign lesion is treated over a period of time and followed up, suppose it turns out to be a malignant lesion later on, patient always can allege that there was lack of proper care, and the doctor did not suggest in-person consultation. When suggested by the doctor, probably patient would have taken it seriously and gone in for, in spite of the difficulties in accessing healthcare, they would have taken the trouble of consulting in person. But if the teledermatologist does not suggest it at the right moment, that becomes lack of standard of care. So we will have to take care. And when we come to practicing teledermatology, we need to know the protocols. First of all, you have to identify the patient. Then, in case of minor, the presence of a parent is a requirement. You cannot advise. Anonymous consultations are not allowed. And according to the legal status in India as of now, pan-India consultation is legal. But you cannot teleconsult for a patient who is not residing within the boundary of India. Because often we get requests through WhatsApp or WhatsApp calls. Somebody, close friends, NRI uncle has some problem, and they will send an image and get your advice. So always be careful. Because you are advising a person whom you don't know, and you can get into trouble. About the drugs that we can prescribe online, they have been classified into 4 groups. Of course, X group of drugs, which pertain to psychotropic drugs, addicting drugs, and other Schedule X drugs you cannot prescribe online. And the other drugs have been classified into O, A, and B. O often refers to drugs which are available over the counter, like paracetamol, or maybe in our dermatology we can say calamine lotion. As such, drugs can be prescribed freely. Drugs which are classified as A can be prescribed only on initial video consultation only, like certain antibiotics and certain steroids. B drugs, group of drugs which are grouped under B can be given on the follow-up visits, even when you are not seeing the patient. Suppose for anti-diabetic medications, anti-hypertensive medications, antihistamines, or when we are treating chronic urticaria, we can prescribe those drugs and follow-up without a physical consult. So when we adhere to these prescription protocols, document everything, then it becomes a legal teledermatology practice.
Thank you very much, Dr. Rao. Both of you being fair and square. But being unfair in one thing. Is that only the Experts will have the coffee. Moderator will not have it. Oh my God! I never knew this. Okay. Doesn't matter. Dr. Rajita. That's quackery contribute to delay diagnosis, microbial resistance, and other long-term health burdens.
Absolutely.
It certainly does.
All of us have had patients with LE being treated as melasma over the counter with all kinds of triple combination regimens. I'm sure everybody here has seen one of those. Not to mention the kind of horrific dermatophytosis, the treatment of which costs a small fortune eventually, because in the initial days it was not treated well. And now we Indians have this misfortune of having to deal with the species name Indothene. We are proud of our exports, but this is not an export that we are proud of. And that happened because clobetasol containing quadruple and triple combinations were widely used. Most commonly by whom? By the chemist. I can't even call them the chemist. Whoever this person is who sits in the medical store. The person I call them, the person who mans the pharmacy counter. He is not a pharmacist though.
These are the people and they are obviously quacks. And they have led to antimicrobial resistance extensively in terms of dermatophytes, and in terms of bacterial resistance, less said the better. A Delhi study once showed that azithromycin sensitivity in C. acnes strains was 100% resistance. That was Dr. Kabir Sadhana's study. So what led to all this? It is the widespread misuse and long-term health burdens, not just in our country, but even globally, has stemmed from quackery.
I understand that there is a little bit of gender bias also here. You only mentioned the person who manages the pharmacy. What is the person who manages the pharmacy?
Sir, you can rag me, but you understand.
Okay. Now, Dr. Rao. Is there any responsibility for data security, and who is responsible for that?
Yeah, now that there is a Data Security Act in India. So in teledermatology, the data security as far as the health information or health data stored in your system, the doctor is responsible. So suppose there is a leakage of sensitive photographs or sensitive information like HIV positivity or the patient's intimate photographs, then the doctor is responsible. So you will have to take care that it is stored safely and access is only limited to whenever required.
A robust password should be good enough.
But if the platforms lead to leakage because of their deficiency in their system, then the platforms can also be held responsible for data security leak.
Are the current laws and enforcement mechanisms in India adequate to curb quackery, and where are the loopholes? Very dear Rajita.
Certainly not adequate, sir. We all are feeling the because of this, and the loopholes are too many. Starting with the clinical establishment licenses. The regulatory authorities being too few, the number of quacks being too many, and some of our own colleagues who lend their certificates. Now, how many of you know a colleague who's given their certificate to 5-6 clinics and goes maybe once in a week to each of these for an hour or doesn't go at all? We all know these people. So how come these people are allowed to do it? Because how can the joint director in Tamil Nadu, in Telangana, it is the district medical and health officer. Number of people they have, the manforce and the women force they have to check on all these. How well the guidelines are being followed. We don't have the mechanism. So that is why I think all of us should start doing this vigilante's job, the job of policing, which we have taken up. It is not an easy job. You will get a lot of hate. But we also need to do much more as a fraternity of doctors to get the judiciary and the government to listen, because finally we are going to be all right. But in Kanpur, sir, 2 people died. One engineer who was in his early 30s, 32-year-old, died in November. on the third day after a hair transplant was done by a BDS doctor. The same lady, the BDS graduate, did another hair transplant in March around 15th, and this person died on March 17th or 18th. So two engineers died in the hands of a BDS person. Now how could she have done the second one? First one, I won't say it's okay. I won't say it's okay, but then it happened. So that speaks about how many loopholes are there, and how poor our regulation is.
Has she ever done a hair transplant successfully?
We wouldn't know. We wouldn't know that. Has anyone survived? Has anyone survived? We don't know.
Dr. Rao, we all know about the Consumer Protection Act. Is it applicable to teledermatology also? I personally feel it is. We'll get the experts.
As we all know, Consumer Protection Act was reenacted in 2019. The earlier act was 2006. There are certain changes in the act. CPA is equally applicable to teledermatology consultation. So we will have to be careful as with in-person consultation. So the one change that we'll have to note is this. Of course, the pecuniary consideration of the jurisdiction we call. Up to 20 lakhs they can approach the district commission for civil negligence to ask for compensation. Of course, criminal negligence is there. When there is gross negligence, the chances are much less in teledermatology. And of course, such cases have not yet come. And yet to evolve legally. But here, in case of teledermatology, what happens? The CPA says that the patient can lodge a complaint online. They have a website where they can complain directly. They can even demand that it has to be the jurisdiction has to be in a place where you reside. Suppose you consult for a patient who is in Assam or Northeast, and if he complains there to the district commission, what will be your fate? How to face such situation? So that is something which has to evolve, and some solution has to be found. Of course, there is scope for e-hearing also. So if even expert witness can be taken on the online mode, and such proceedings can happen. But we are yet to see such things.
That's why after the COVID pandemic in 2019, 2020, the government of India came up with some guidelines. But of course, they are not foolproof again. At least guidelines which are not just mind lines, which are truthfully guidelines. What about the social media, Dr. Rajita?
Social media has been probably the biggest factor in creating this level of this magnitude of quackery. Because earlier days, how would we get patients? We would have a board and we would sit there. We were allowed to announce starting of a practice. That is what is allowed legally as per the code of ethics. But now, if you have a lakh or two to spend on social media, your reach can be extensive, and combine that with consultations done by these quacks. Their reach is almost unstoppable at this point. So how can we counter the misinformation? I think the best way is to counter it while good information. So while regulation and judicial action and taking these people to task and closing their clinics and all is a tough one. All the people here who are on Instagram, who are on YouTube, if we can all start a campaign, that's what we've started. We've just announced the Insta Reel contest on the occasion of the Independence Day. So if we can all do this, if we can tell people that if you go to a doctor for a skin or a hair concern, please make sure that they have a MD or a DD or every MD same? Is it MD dermatology? Is it MD Ayurveda? These kind of simple things. So sitting here is Dr. Praveen, and his son Dr. Avinash Praveen is one of our crusaders, and he's hugely popular as Kanyakumari dermatologist. Makes these amazing, real simple ones. They are
things like that are going to go a long way in educating the public. So that is what we can do as individuals, as an association, as a body of professionals. I think we will have to do much more.
You're very correct. How much? But how much? Okay, that is not. Okay, that is not.
One more thing, sir. Thanks to Dr. Jacob Thomas, we were able to release something unprecedented. In IADVL, we released the social media etiquette guidelines for Indian dermatologists, and that has actually not gotten its due. Hopefully, it will. So, sir was the chairperson, and I was the convener of the ethics committee. It took us almost 2 years to put it in the shape that it finally took. And we are beseeching all our dermatologists to behave in a way that is befitting of our professional status. So please don't promote moisturizers and sunscreens and do dances to promote your fillers and things like that. And if you have a friend who is doing this, please tell them, because we have started giving out show cause notices. We are taking it up with the medical council. How many are we going to do? But conscience awakens from within. I think it's going to be much more effective.
So for that, sir,
thank you so much, because I don't think we met after that. It is something that will go down in history. I mean, at the sound of cost of sounding pompous, I'm saying this, but that is something that no IADVL has done, and thanks to you, we were able to do it.
What about filing a complaint against the platform that is providing facilities for teleconsultation, Dr. Rao?
As we know, there are several kinds of platforms which facilitate teleconsultation and telemedicine. The first group only act as intermediaries. That means they only arrange appointments. So they will not be in any way. They cannot be pulled up for lack of good service. But the second group, where they take on appointments as well as consultation with a panel of experts. It is their duty to see that the patients get proper advice from a qualified doctor. So they are supposed to check the credentials, experience, etc. of the doctor providing teleconsultation. So to that extent, they are liable. So there are other platforms which not only even door deliver drugs. And there are platforms which have a package. They will arrange even surgeries. Till the patient returns home, they will manage. So such platforms are equally liable to be pulled up for their lack of proper service.
This I think we almost covered about who is a whistleblower. You very much, Dr. Rajita. Of course. Trying to farm advocacy against quackery, and let's hope we get to it correctly. What are the ethical challenges in teledermatology practice, Dr. Rao?
The basic ethical principles that govern medical care are equally applicable to teledermatology practice also. The first principle is autonomy. We have to respect the patient's autonomy and take proper advice and see that the patient's privacy and confidentiality are taken care of. Even when we do a video consultation, we must make sure that there is nobody else peeping through on our shoulders. Patients are always they hesitate to come out with their complaints, especially with respect to sexually transmitted infection, HIV or vitiligo, whichever disease carries social stigma, they may hesitate. So unless we ensure that privacy and confidentiality of data is ensured, they will not come out with their true complaints. So it is very important that we take care of that. So what other issue you were raising? I didn't get. Can you go back? The second principle would be, of course, beneficence. You must always act in the interest of the patient. At any point of time, think that the patient will be better off consulting in person. Please go ahead and advise the in-person consultation and don't take a chance. Because in case there is an eruption which is evolving, you may not be able to appreciate its importance at that point of time. Erythema multiforme minor can after a few days develop into Yes, syndrome. So we don't know. So whenever you are in doubt, whenever there is ambiguity, whenever there is assessment is not possible online, please advise in-person consultation. The third principle, of course, is the first principle of non-maleficence. Don't do any harm. So when you are not sure, give some first aid or some early treatment, and then call the patient for in-person consultation. So these are the principles which telemedicine practice too.
Dr. Ajit, please tell us a little more about what is being flashed here.
So these days we have
AI to detect
plagiarism. We have softwares to detect plagiarism. All the PGs
do their own plagiarism checks before they submit their thesis and they submit their papers.
So this I think is become only a matter of technology.
The main concern
is
if somebody steals your entire work,
if somebody steals a little bit of work, then that is one thing. But if somebody steals your entire work,
that becomes
a problem. So somewhere, I think
we should start
calling out
people.
I don't know how it sounds when I say it, but naming and shaming, because somebody's worked for 2 years on their thesis and then somebody else has published it. This is not plagiarism, this is plain text. So these kind of things we do here. Right now in Telangana, there's a complaint against someone who's
very senior in IEDVL,
and he's been accused of insisting that his name be put as first author in all publications from the institute. Now, how is it possible that the professor's name is first author everywhere?
So
these kind of peer judgment, because we are all too polite. We don't call out people. Except someone.
I don't hesitate in
calling out. Please. Sir, please.
Here I would like to quote regarding informed consent. I had published an article. Informed consent, whether it is legally and ethically a requirement. That was published in IEDVL. But an MBA candidate studying in Symbiosis Institute of Management copied my article in toto and published in their journal. When I was doing some search online, I saw that my article with somebody's name. Totally. This is the extent of plagiarism that is happening. 100% copy. Even the references. I wrote to that editor of that journal. He said, we are sorry. Nothing else.
Now, talking about
they removed it from the online. So it remains in that physical journal.
I think I heard that Dr. Ajit said they copy a little bit. How little? Little bit if they copy is okay, you said, no? How little?
So these plagiarism
checks, they say that up to 10% is
words. Up to 10 words. 10 consecutive words. You are allowed. More than 10 words consecutively. You are not allowed.
Consecutive 10 words. It will pick up.
Yes. Immediately it will pick up. This I learned from a lady in Mumbai, a pediatrician. You have to be careful about. Not that I did it. Even Parivalam knows. I forget the name. Adolescent specialist. Okay. This is what we just told. Deliberate and unintentional plagiarism. Now, before we go any further, I would like to know from both of you, please. How can peer review transparency be improved to minimize editorial bias, and misuse of authority? I already discussed this some time ago with Dr. Rajita. In a journal, if you take the 20 articles, 10 will be by the editor. So how can we stop that? How can we do something about that?
Only anonymous review has to be.
What anonymous? Rajita should be able to make a talk on one of the Democrats. What ails the journal? Will you do that for us, Rajita?
Sure, sir.
Sure, sir.
What is
But
the journal?
Don't have to be
holding favoritism for anybody. We're not going. I'm sure you're not going to contest for post of president.
Not in the next decade.
Not in the next decade, sir.
After a decade,
After a decade, we'll think about that.
So I think we should be
So I think we should be able to do that.
Talk to them.
Talk to them. And
Make a presentation.
Make a
you know,
presentation, like this way. What is the
Very
journal?
many years ago, I'm sure
Major General Saab might remember. There was a presentation. What is the journal? I love that. That time, let's not mention names.
Editor who was
very popular person, but still,
half
more than
the
half the journal lab is named. So that's the thing.
Now,
I think we'll have to finish off. My coffee is still not come from unfair.
That's why I say
when people use fair and lovely cream,
it might be lovely,
but not fair at all.
Not fair at all. Do you agree with me?
Do you agree with me?
It's
Dr.
not lovely also.
It's not lovely also.
It is neither.
It
is neither.
Okay, you are lovely.
Okay, you are lovely anyway.
In an era
where we talk about corporate sector of
how can
healthcare, doctors maintain ethical practice while ensuring financial sustainability?
Either of you can take it. I know it's a little tricky. We are not attached
to any corporate hospital, so we can handle this.
We have no conflict of interest.
Yeah.
Ethical practice
while ensuring financial sustainability.
I
was for some time attached, about 20 years ago, attached to the private hospital.
Then the
medical data comes.
Please send in some more investigation.
Please send in some.
You write investigation
in your clinic, but here you are not writing.
So how do you handle that?
They always talk of the volume and the amount that you generate for the hospital. They are always MBAs. They are all MBAs. They talk more of marketing and sales and the monthly earnings, etc. But as long as the individual consultants stick to basic ethical principles, and if they are ready to face the management and even ready to quit the situation demands, then I think the hospitals cannot dictate terms to the consultants to practice in this way or advise unnecessary investigations or advise more number of hospital stays, etc., just to boost the income of the institution. So I think it pertains to individual doctor who is doing medical practice. They have to decide whether they want ethical plan, they want to stick to medical ethics or go the way the other institutions go. So it's individualistic.
I totally agree, sir.
I think the key is being ready to quit. What happens is immediately, let's say you're a young dermatologist, you're in this situation, and you're being pressurized to prescribe maybe expensive things or maybe ask for expensive investigations. And if you say, sorry, this is not how I practice medicine.
They might say, okay,
now you go your own way. You have to be ready to face it. But imagine if all of us stuck to that,
then there would be no problem.
The problem comes when some of us stick to this and many of us don't. But still, I'll tell you one thing: none of us can have enough money.
Even Ambani
doesn't have enough money.
And all of us
have enough money.
So if we remember
if we stop comparing and going after this, and we stick to our values, we will be very comfortably able to do an ethical practice.
So the bottom line, my dear friends, is
learn to live with
what you have, rather than wanting to
grab more and more.
That's not going to stay with you for too long a time.
It's time for me to say
a very big thanks to
Dr. Rao,
and to Dr. Ajita.
Thank you very much for
being with us, my dear friends. Thank you. Lovely to have you around.
Really, thank you
very much.
Thank you, sirs and ma'am.
I now request Professor Dr. Jayaka Thomas sir to felicitate Dr. Satyanarayana Rao sir and Dr. Ajita Damishetty ma'am.
I also request
Professor Dr. Satyanarayana Rao sir to felicitate Professor Dr. Jayaka Thomas sir.
We shall now commence our last set of guest lectures for the day, to be chaired by Professor AJS Praveen sir, Professor and HOD at Sri Mookambike Institute of Medical Sciences, Kanyakumari. Over to you, sir.
Good morning, everybody. Good morning, everybody. It's a great privilege to be here. And I thank my professor, Dr. Jacob Thomas, and my batchmate, Professor Parimalam Kumar, for giving this opportunity. We have two guest lectures. One will be virtual, one will be in person. I invite Dr. Rajita Dharmashetty to talk on hormonal challenges in dermatology, teledermatology to the rescue. Over to Dr. Rajita.
It's truly a pleasure to be here to speak about two things that are very close to my heart: the quackery and ethics issues, and of course the hormonal milieu and dermatology. So for that I can't thank Dr. Parimalam Kumar and Jacob Thomas sir for the invite. Now over the next 20 minutes, how much time do I have? 20 minutes. 20 minutes. Okay, I'll try and finish off in 15, 18 minutes. I'll speak about the hormonal challenges dermatologists face, an understanding of obesity for dermatologists, and how teledermatology can help bridge the care gap. So we deal with androgen excess, insulin excess, thyroid problems, once in a while even prolactin. Corticosteroid excess we frequently used to be the culprits. Iatrogenic Cushing's is much more common than real Cushing's in our OPDs. But our main concern seems to be with insulin more than with anything else. So what are the skin conditions that can be associated with hormonal etiology? Acne, of course. They say that all acne is hormonal. Hirsutism, unmistakably, alopecia, with or without miniaturization, chronic telogen effluvium, or acute telogen effluvium after hypo or hyperthyroidism, respectively, or a miniaturization in the form of a frontal thinning like in female pattern hair loss, or something we call DUPA these days because of the insulin excess. And then SAHA, seborrhea, acne, hirsutism, alopecia. This is a good acronym because many times these things come frequently as a group. Now, what are the skin conditions that are associated with insulin resistance? Acanthosis nigricans is considered synonym for insulin resistance by endocrinologists. Whereas we dermatologists, we still want to give only tretinoin cream or do TCA peel, but we don't look beyond that quite frequently. Acne and psoriasis also are very strongly associated with insulin resistance. And you have various other things, including vitiligo, which could be associated with insulin resistance. So, what is the reason for insulin resistance playing such a big role in a host of skin conditions? Because of the chronic inflammation, increase in the pro-inflammatory cytokines, and the sequence of events that follows the serine phosphorylation. This leads to the various hyperkeratinization, whether it is the follicular infundibulum in acne or whether it is all over as a psoriatic plaque. So before we go any further, we need to understand what insulin resistance is. So when a given concentration of insulin is not producing the expected biological effect, that is when we call it insulin resistance. And what happens because of it? Because the body has insulin reserves till a point of time. It produces extra insulin so that your sugars can be controlled. And this extra insulin is going to cause a host of metabolic changes, from increase in triglycerides to impaired glucose uptake by the muscle. And in terms of the skin, what does it do? It causes thickening of the keratinocytes. It causes increase in the stratum corneum thickness, and it can cause
facilitation of testosterone action. So basically numerous causes are there for insulin resistance. Things like genetics and age we cannot change, but obesity is something that we are all battling. And what are the consequences of insulin resistance beyond the skin? Type 2 diabetes, PCOS, atherosclerosis, premature cardiovascular and cerebrovascular morbidity and mortality. So now we are fast becoming the most obese nation in the world. We are going to beat China soon. And India is already the world capital of diabetes, and Hyderabad happens to be India's capital of diabetes. So it's not any wonder the amount of rice we consume, the too little amount of protein we eat, and the lack of physical activity, not just in the form of exercise, but in just the form of movement. Most of us get into a lift, get into a car, then get into another lift and sit in our clinics. That's what we do most of the time. So as non-exercise physical activity has become very, very minimal for most of us, including school kids. So what is wrong with obesity? Is it a cosmetic problem? I wish it were only a cosmetic problem. The problem here is that obesity is now considered a health disorder by WHO, and it leads to chronic inflammation. And I want to bring to your notice a very important concept about fat mass disease, which we understand, that is anthropometric obesity. You look at someone, they look obese, they are obese. But there is another concept called the sick fat disease. That means the fat need not be excess, but healthy, not healthy. And why is it not healthy? Because it is producing too many macrophages. The ATM stands for adipose tissue macrophages. So adipose tissue macrophages emerge when fat is packed very tightly, and in the center you have necrosis of adipocytes. So from there you have these kind of exosomes. Now not all exosomes are healthy, not all exosomes are good. These are naturally derived unhealthy exosomes, and the kind of exosomes that are produced from lean adipose tissue versus obese adipose tissue are very, very different. So adipose tissue is now considered a biologically endocrine and paracrine tissue, and because of the hypoxia that happens because of the way it is packed, you can have a host of interleukins and TNF alpha and even prothrombotic factors as well. This is where advanced cardiovascular morbidity comes from. I will give you one example of this young man. He was around 27 or so, and he was brought by his mother for tan in quotes. So they wanted to get him married. The mother thought that he should become fair. I should give him some cream to get rid of his tan. This is what the anterior neck looked like. This is what the posterior neck looked like. And if you observe on his left temple there is a big acrocordon. So how many of us would have just given off just a topical regimen, maybe advised the peel and then sent him off? I'm sure there are enough dermatologists even in today's world who do that. Now this was a girl who came with skin light induced irritant contact dermatitis. That's a mometasone containing pigment. Then I had to give her plain mometasone to reduce the irritant contact dermatitis. And as a part of, so this doesn't look very much like your classic acanthosis nigricans because it is steroid modified. And as a part of our investigation, we found that she had PCOS, and her ovarian volume on one side, I don't think you can read it, is 38 ml. 38 on one side, normal volume being cut off being 10 ml. And by the way, there is no PCOD, it does not exist, it is PCOS. If it were ovarian disease, why would we dermatologists want to even talk about it? We are not interested in ovarian disease. So this was a young male, marriageable age, wanted a cream for his dark circle. I said, I'll give you a cream. I did give him a cream, but I also asked for his insulin, his sugar, and his TSH. And I realized I had wasted his money by asking for insulin because his fasting sugar was 327. There was no way I could have known that. This was a young boy. He was only 14, extensive truncal acne, had taken a ton of doxycycline, given some topicals which he did not use. Imagine a 14-year-old using truncal retinoids. and this was before the age of triferritine. So and then there's this engineering student around 2021, and you can make out his buccal fat excess, quite obese, severe acanthosis nigricans, and these were the investigations that I had asked for him. I wanted to put him on isotretinoin because he had extensive truncal acne. I could not because he had a severe non-alcoholic fatty liver disease. His transaminases were in the 110, 120 range. So I had to manage him after referring him to the endocrinologist. Together we gave him metformin, lifestyle, and then mainly topicals for his acne. And so how do you establish insulin resistance? You can do all these things, but in the real world, what we do is usually HOMA IR. So in this young boy, young male rather, his insulin resistance index, HOMA IR, was 12.97, and you are all familiar with the fact that anything less than 2 is acceptable, and beyond 2.53 you want to institute pharmacological treatment. Now, by the way, his TSH was also elevated. That was treated as well. And this vitamin D deficiency and all is very common in India. You definitely want to treat it. This was a young girl who was brought for dark skin, because everybody in this family was fair, and the mother wanted me to give her something so that her skin would become fairer. Not very severe acanthosis nigricans, but if you observe the HOMA IR, this was 7.1. So this was not dark skin or tan. The nose was normal. It was just diffuse facial acanthosis nigricans. Now, we move on to hirsutism. So in acanthosis nigricans, we all understand what to do. Most of the time, hirsutism is because of PCOS. Idiopathic hirsutism and late onset congenital adrenal hyperplasia can give rise to 5% each. But all these other things together will give rise to only 1%. Which means that if you can master PCOS, then you know how to treat hirsutism 90% of the time at least. So this was a young engineering student. She was around 19 when I first saw her, and she had severe coarse hair. And what did I do? I investigated her, because everybody with moderate and severe hirsutism should be investigated. What all did I ask for? The PGs can take a picture of this if you want. So do not ask for a free testosterone, ask for a total testosterone. Prolactin, TSH, and HOMA IR, because you want to establish. Though if you are very confident, you can just see acanthosis nigricans, rule out diabetes, and then treat off for insulin resistance also. 17-hydroxyprogesterone is not something you do routinely. You don't want to waste the patient's money on LH, FSH, DHEAS, AMH, all these things. Ideally, day 2 to 5 of cycle 8 AM fasting sample. But if the cycles are irregular, any day fasting is okay. Using a LH FSH ratio is a waste of money and time. And remember that most of the time in PCOS, the values of the hormones will be normal. If they are abnormal, then it is not PCOS at all. So if you read the Rotterdam criteria, you will find that the last line is the most important. That is after exclusion of other etiologies. So clinically, we as dermatologists are very good at finding out cortisol excess. You look at the body fat habitus. You look for the broad livid purple striae on the abdomen. You look for acromegaly. You look at the height. You know whether GH and cortisol are excess. And TSH and prolactin, you ask the lab to measure, and you take a good history for menstrual cycles. If the girl is married, then of course you can ask for a transvaginal ultrasound. If the abdominal ultrasound says normal, it still could be very well PCOS. So this was after 3 sessions when she came for her 4th session. We diagnosed PCOS in this very obese girl. She was put on ethinyl estradiol drospirenone combination along with aldactone, that is spironolactone, and metformin. And during this process of around 9-10 months, she became from insulin resistant to frankly diabetic. sitagliptin was added by the endocrinologist, and then during this process she also managed to lose around 18 kgs weight over a period of almost 18 months or so, and then from she went back to insulin resistance from diabetes. So this is basically a spectrum. So that time again the sitagliptin was taken off. So when you do good evaluation and start proper pharmacological and lifestyle treatment, then you can get some great results. It is not enough if you buy a fancy machine with the money that you have or borrow. So this is again from this textbook, a chapter that I wrote. It's slightly complicated one. Maybe you could take a picture if you want, or even better, just get the book. This is a picture that you want to click. So in short, PCOS you want to treat with COC, that is a combined oral contraceptive, with spironolactone. Bicalutamide is a drug which has a favorable side effect profile even compared to spironolactone. It's very well tolerated. Flutamide should not be given for any condition which is non-malignant. So the other things you can, idiopathic hirsutism also needs pharmacological treatment. Now, big question: who needs to give this? Ideally, you should be monitoring the endocrinologist who is monitoring the patient. But if you do not have, so I will say it again. I monitor the endocrinologist treatment. So if the endocrinologist is not giving enough treatment for my laser to work or for my treatment to work, then I am going to call up the endocrinologist and tell her. Please have a good relationship with these allied specialty people. Make sure, because the main keyword here is beneficence. We want the best for our patient. So medical procedural lifestyle measurements are the key. Now hormonal therapy in acne patients, severe premenstrual flares and recurrences after isotretinoin, too early onset, too late onset, all these things are there. Obesity and psoriasis. I was sitting next to Madhu and I was pointing out in Dr. Rohini's talk how all her IL-23 recipients were obese. I don't know how many of you noticed that. And I have a host of psoriasis patients on various treatments, from methotrexate to ixekizumab, who are on strict lifestyle monitoring. And I am very proud to say that after significant weight loss, many of them have not needed systemic therapy. So this disease modification, the JEADV article that she quoted, I think that is beyond biologics. This is where the key is. So what is the BMI you want to aim for? Less than 23. And who told us that less than 23 is ideal for Asians? An institute not far from here in Chetpet itself. So this was when we came to know that our standards are different from the Caucasian standards. And here I want to introduce one concept to you, the concept of metabolic obesity. So normal obesity, you see it, you recognize it. That is anthropometric obesity. But somebody like me who does not look obese, but who's actually having the parameters that obesity entails. So you have these two people who look very similar, same BMI, but they behave very, very differently. And this was my body composition analysis. Percentage body fat of 37.6, when the ideal should be 28 or less for women. So a normal weight can be there with excess fat and too little muscle. So many of us are actually sarcopenic, which is why we should eat more protein, we should do strength training. And this is an old article from Lancet. You can read it up. I don't want to spend too much time on this. So that is why we are all getting into metabolic syndrome, and even our patients are getting into metabolic syndrome. And what is the ideal for treatment for women who have a waist circumference of more than 29 inches women, and for men this one would be around 35 inches waist circumference in men. What should they do? They should start maintaining physical activity and curtailing their intake. And then beyond a waist circumference of 36 for men and 32 for women, what should they do? They should seek medical help. Now, whom are they going to consult? Your patient with psoriasis or acne or hirsutism has obesity. Who is the medical practitioner who's going to help them for obesity. It has to be us. So how are we going to manage them? If they require GLP-1 agonist, semaglutide, tirzepatide, one of those things, then we always have our endocrinologist colleagues, but we all should be trained in lifestyle management. We should understand what kind of exercise is called exercise, is walking enough exercise, what is strength training adequately, and what is the role of sleep, what is the role of stress, recreational drugs, how much alcohol is allowed, how much is not allowed, what about smoking? Now, where does the care gap come from in the management of hormonal concerns? We are all so busy in our clinics. So where is the time to do this kind of counseling? That is where I think teledermatology can help, because you can handhold in the early days. Let's say you prescribed metformin to someone, and we are allowed to as registered medical practitioners, provided you have an understanding and diagnosis, and you can monitor if somebody is going to get into a lactic acidosis. You know enough to check that a serum creatinine has to be normal before you give a metformin. All these things, and you have to be sure that they are not frankly diabetic before you give it. So hand-holding in early days. Let's say you put an adolescent on a COC, she's having depressive symptoms. So you can arrange for a WhatsApp kind of a helpline in your clinic, and you can use it for hand-holding, monitoring of adherence to therapy. If there are some people who are notoriously non-compliant, non-adherent, so there I have patients who have to send me the photographs of their use, isotretinoin, the blister packs. So those kind of things sometimes I don't do. I'm blessed to have 4 good dermatologists who work full-time for me. So one of them does that. And then adherence to medication, but also caloric tracking. Some of these apps like Healthify Me and Fitafly and so many of these are working where normal dietitians are failing, because I can give you a diet, but how many of us can actually follow that? These people are going to give you a diet, change it weekly, and track you 3 times a day. At the end of the day, they're going to say, today you had this many excess calories, this much less protein than required. And exercise tracking, all this can be done using teledermatology and telemedicine and monitoring of progress. So when your acne patients, acne scar patients are saying, I'm just looking the same, let them take a good selfie in a standard light and post it every week if they want to. You lose nothing. You have a front desk person maybe monitor it, and obviously you're not going to charge for any of these services. Hair regrowth, in case you're doing a laser hair reduction, somebody is saying it's coming back too quickly, let them take a picture, let them send it to you. Or if you want to monitor regrowth of hair, then that also you could do. Clearance of psoriasis plaques. It's very, very heartening for a patient to take weekly elbow pictures and shin pictures and track. And weight and also waist circumference. Because how does one know whether you're losing fat or muscle when you're losing weight? So simple way is to measure the waist circumference and see whether it is proportionate to the weight loss. So this is a flow chart for the first consultation in teleconsultation. This is for the follow-up. Now what are we allowed to do here? Rao sir has already told you about the list A, list B and all that. So would I encourage you to do a teleconsultation for any of these people in the initial days? No. I would encourage you strongly to use it for a follow-up and to use it as a mechanism of being in touch with the patient in between your physical consults. Because lots of times I want to see them only once in 3 months, once in 2 months. So to monitor your responses. Now let's say somebody is staying far off, you want to see them once in 6 months. They are on methotrexate or a biologic, their liver function, their CBP, you can be checking online as well. But you don't want to prescribe these kind of drugs, so please play within the rules. And my last slide for all of you, we are not cosmetologists. This is a Government of India publication, and please read the entry qualification for cosmetology. It is past 10th class examination. So if after 5.5 years of MBBS, 3 years of MD and all this, you want to call yourself a cosmetologist, again, no offense to cosmetologists, I believe in dignity of labor, but let us not call ourselves. We are dermatologists. If you have a special interest in aesthetics, in cosmetic dermatology, just add that to your description. But please don't call yourself a cosmetologist, and please go and tell your friends who are doing that to change their boards and change their stationery. Thank you.
Thank you for highlighting a variety of topics. As usual, you're the star of this day. Thank you for the nice presentation. Any questions? Any questions? Anybody wants to ask? No. No. Sir wants. Sir wants to ask.
This is about writing the degrees in front of her name. I don't know. I am now quite old. 16, 17 years back, I have been out of little. During our time, the degree which we used to get from the university was dermatologist, venereologist, and lephrologist. I don't know even now the same degree is being given. But I yet to find anyone, whether senior or juniors, to chodo baat. None of them they are writing venereologist and lephrologist. One thing. That's the reason why that query has come, because the patient of STD, he doesn't know that venereologist is there, so he has to go to some other people. So are we doing a legal thing by hiding these two degrees? Part of it, number one. And are we doing justice by adding, like you said, cosmetologist, laser surgeon, plana surgeon, and whatnot? So, your opinion.
Sir, thank you for that wonderful question, sir. These has always been in the medical code of ethics that you are supposed to display only those degrees which are recognized by NMC. And what is unsaid is to reproduce those things verbatim. So, if your degree is MD DVL, then you are supposed to write MD DVL and not MD dermatology. Mine is MD dermatology because, sir, that time in Tamil Nadu it was separate. So I am not allowed to call myself a venereologist because I am not. But then many of my colleagues who are MD DVL, they somehow want to hide this, and I think for the reasons that you rightly mentioned. Now, very recently, Karnataka Medical Council and Telangana Medical Council have started penalizing people for displaying degrees that are not recognized. And whether somebody can be penalized for hiding the fact, probably we are not there yet, but I think it is for us to be proud of what we have studied and to inform our patients that we are the right people to be approached when somebody has a ST. We meaning not me, but the others with MD. Many of my colleagues who are senior to Dr. Murli here have only MD dermatology, whereas later on it became a combined degree. Only two states, sir. Yes, sir. Nobody's interested in. I hate to generalize, but only in combined Andhra Pradesh and Tamil Nadu we had separate degrees. Everybody else had a combined degree.
Put it like MD DVL. So people don't know that venereology, lephrology thing. They even try to hide it. Even a lot of venereologists as cosmetologists.
In Hyderabad right now there's a huge controversy. There's someone who is an MD venereology. He's a former president of a state branch also, and he's been calling himself DVL. And I objected, and then he's written some complaints about me to president of IDVL. He wants me to be thrown out of IDVL. So if I need support, I'm going to seek your help. Thank you.
I'll help you. Thank you. So next will be a offline talk by structural building with soft tissue filler by Rajat Kandari. Will be a tele talk.
Good morning, everyone. This talk will be revolving around structure building with soft tissue fillers. And thank you again to the organizing team of Telederm 2025 for giving me this opportunity. So where and how does the aging process unfold in the layers of the face? So before we jump into how we build the structure, a little bit about how it unfolds. So initially we know that the foundation of our face is the skeletal framework, right? And the skeletal undergoes resorption. There are changes to the orbit, the maxilla, and the mandible, influencing the relative prominence and position of your facial soft tissues. Further, there is facial fat atrophy, deep more than superficial, and loss of support for the superficial fat compartment. There There is problem with the muscles. That means the distance between the muscle origin and the insertion. Insertion is typically into the skin, and the origin is mostly the bone or a tendon. So once these bones undergo resorption, the distance between the muscle insertion as well as the origin tends to become a little bigger, and the muscle tends to become a little lax, does not have the same fulcrum to attain a good contraction, and attenuation of your retaining ligaments, stretch to the ligaments due to the bony resorption. And finally, toxic injury to the collagen and elastin, decreased extracellular matrix, and atrophy of your skin appendages. So in a nutshell, this is what's going on while you're aging. It has been said that building structure requires planning, and we all know that. If you're building a house, it requires a certain planning. It requires that we lay the foundation stones well. It requires that the pipework is done well, and finally the facade and the interiors. So there is a sequence to the planning, and there is an architectural mode that one thing should happen first and then the next. And on this particular note, the first thing that came across many years ago was something called as the Mauricio de Mayo 8-point lift, which said that if you do these 8 points in the face, it is akin to building a house wherein you lay the foundation and do the beautification to attain sort of a lift to the face. And then this became more and more, it was improved over time. This vision of this gentleman, Dr. De Mayo, was improved over time, wherein he said the foundation is essentially the cheek, then the contour, which involves the temple and the chin and the jawline, and then everything else is the refinement, which is the tear trough, the orbit, the glabella, the forehead, the nasolabial fold, the lip, and the marionette lines. Now there are certain factors involved while planning the structure. There are product-related factors, there are patient-related factors, and injector-related factors. The product-related revolve around how well you know your product. What is the G prime? What is the concentration, flexibility, malleability, degree of cross-linking, and so on. Patient-related factors. What is the gender and ethnicity, age, other medications, motivations, and goals. Is your patient hypertrophic or hypotrophic? Totic, non-totic, and what is the skin quality like? And finally, injector-related. How well you know your product, your anatomy, and your technique. And depending on this, in the foundation, the initial pillars, we need products to lift and volumize, so we use them supraperiosteally typically and higher G prime products. This is very much in a nutshell. This may vary. Proportion, projection, and definition. We do contour and volumize here, and supraperiosteal or subcutaneous, medium to high G prime, and then finally the refinement, wherein more softer products may be used with a high flexibility, which help in filling lines, creases, volume, hydrate and balance, and these can be subcutaneous or supraperiosteal rarely. So the treatments for the aging phase should always begin at the foundation or the bone, and the bone undergoes resorption more so, as I previously mentioned, in the superomedial and inferolateral aspects of the orbit, the pyriform fossa, the maxilla, and the mandible. And this results, as you can see, in the aging phase, the pyriform fossa, periorbital, and the lower phase. So your treatment should begin at the foundation, which is the bone, which means cheek, mid-face, chin and jawline also form the foundations to a certain extent, along with the contour, and work in the temporal area helps in the contouring. Now, before you make your plan, you need to assess your patient well, and for that you may divide the face into the thirds, see the upper third for forehead height, width, contour of the temples, position of your brows, and so on. Then you see the mid face, upper and lower lids, the anterior cheek, the nose tip, and the upper nasolabial fold, and finally the central and lower nasolabial folds and the lower face, along with the marionette pre-jowl area. And you may divide these into ideal, favorable, acceptable, or unfavorable, and accordingly make your or prioritize your plan. This is known as the MDASA or the multi-dimensional aesthetic scan assessment, which says that the face is somewhat like a book and it has paragraphs, words and sentences. So you divide it into parts so that your assessment can become better and better and you do the best job for your patient. And it has been seen that this aging process of the Indian face is seen through generations. So identifying issues early on and having a thorough assessment will result in delaying inevitable changes. And you can see these in mom and the daughter, very similar areas which are involved and how they've been treated for a more fresher looking face. The structure building part one is the foundation, working on the anteromedial cheek and the zygomatic arch. So zygomatic arch provides anchorage and denting, anterior projection and volume when we are doing this anteromedial cheek. A light reflects bouncing of the apex of the cheek, also known as the zygomatic eminence, and softening of the palpebromalar groove or the lid cheek junction, again the anteromedial cheek. And just so that we are all on the same page, that's the inferior orbital rim. The zygomatic arch, the superior and inferior border, and an important area there is the zygomaticofacial vessels in the red. We've got the deep medial cheek fat pad, the medial and the lateral fat pads, and the important vessel here is the inferior orbital foramen. And we've got the preauricular area with the parotid gland and the facial nerve, and finally the submalar area with the facial artery. So when we are starting off, we need to know these points, particularly when we are covering the cheek. These, of course, in the yellow are the danger zones. So starting off, this is injection in the zygomatic arch. You stretch on bone, aspirate. You can see I'm aspirating and a slow injection. And inject. Straight down on bone. Aspirate. So I'm using a high G prime filler here with a needle. Now I'm going to go to the anteromedial cheek. Feeling for the infraorbital rim. One hand on the rim. Going straight down on bone. Aspirating, and I'm going to wait for the aspirate here because I'm close to the foramen. I'm aspirating for a few seconds in this point. T7. The same thing with the blunt cannula on the other side, and you can see I'm going to do the zygomatic arch here, building the zygomatic arch with a 25 gauge cannula with a high G prime product. It's the same product. One side was with needle, and the other side is with bone. And I'm in the subcutaneous plane now, rather than on bone. Linear threading in the subcutaneous plane, trying to build the cheekbone or the zygomatic arch, thereby providing a tenting effect or a lift effect to the adjacent tissues, and giving her a narrowing to her face as well, and a softening of the palpebromalar groove. The same thing I'm going to be doing now in the anteromedial cheek. And I'm just going to skip this. So I'm entering and this whole zone, the medial and lateral as well as the deep medial cheek fat pad. So this is the lateral soup and the And when you do this, when you achieve work on the anteromedial cheek as well as the zygomatic arch, you get beautiful outcomes, and you set the foundation while building the stage for refinement. I haven't done the eyes in this case, and you can see 2 mil of filler have made a great improvement. Next up is fat atrophy. Fat atrophy is not only predictable but directly influences volume and shape. There is volume loss which we need to reinflate and change in position of the superficial compartment, which we need to reposition. So you can see when we do that, when we're just repositioning and reinflating, we get subtle as well as a pleasant outcome. This is reinflation of the medial tooth and the deep medial cheek fat pad, leading to a refreshed appearance and improvement of the lid cheek junction. Coming to the submalar and the subzygoma space, the preauricular space, so provides volume to the preauricular area, helps contouring the face and achieving a better jawline, and addresses the sunken submalar area. And you can see that here, we're going to do this with a cannula. I am going to go a bit fast. So there we are. I am entering with the cannula. You can see, and the zone should be such that you have easy movement, otherwise you're a bit too superficial, and the parotid fascia can be a little concerning here when you're injecting. So again, the anteromedial as well as the zygomatic arch, which gives a much better appearance. So the foundation and contour with higher G prime fillers, and then lower G prime fillers for the refinement. And same in such a case, which is a hypotrophic case with dehydrated and lustreless skin, and over a period of time a better outcome. And sometimes a heavy Indian face, which is common in India. This is a person with thicker skin, but also wanting a lift and narrowing of the face. So we're going to again use the foundation points, give her the narrowing, but also do the preauricular area, which helps in lifting and giving her that jawline, and in the red you see the low G prime fillers. You can see her jawline appears much improved just by doing the mid cheek or the foundation. Now coming to contour, the temples, chin and jawline. This is how we go about doing the temple, which is known as the gunshot technique or the one up, one over technique, wherein you go straight down on bone, and just next to the superior temporal septum, and its convergence with the superior orbital bridge, 1 centimeter up and 1 centimeter over, and inject slowly. Or you can end up using a cannula for this technique, wherein there is intense amount of volume loss. And there is a concavity in your temple, so as to achieve a smoothness throughout the temple rather than just a lift in the brow. Feel for the pulsations of the superficial temporal artery always before attempting this area, and go slow. Aspiration is mandatory. Even with the cannula, I would tend to suggest it. So when you do such areas such as contour as well as the mid face, you get better thirds, better continuity, projection, better light reflex, and better skin. Next up is the jawline, which is again a contour part. So we have certain points of the jawline. You see, this is known as the MD codes. JW1 is the gonial angle. JW2 the mandibular ramus or the preauricular area. Then the jaw line, which is JW3, and 4 and 5 the chin apex. And you can do it as a bolus, supraperiosteal, or subcutaneously with a cannula. And you can see that here I am doing the chin with a cannula, non-dominant hand below, so as to give him definition, and the same for the jawline in subcutaneous manner, you can see. And this is doing the chin apex, straight down on bone, and inject slowly. and you get a pretty decent outcome. You can see the jawline in this individual, which is appearing quite well defined as compared to what it was. Same for her. You can see the chin proportions are way better after doing the chin, jawline, and the mid face. And you can see the bigonial bizygomatic ratio is much improved and leading to a more oval or heart-shaped face. Same for her. You can see the jawline is much better. So structure building is a journey for the patient, which requires counseling, time, and for the doctor and patient to be on the same page with aligned expectations. Thank you, everyone. Thank you, everyone, for your patient listening.
Thank you. It was a good presentation in spite of being I think a lot of you would have learned from the technique and it will be followed with good guidelines. Thank you for the nice session. Thank you one and all for presenting in teledermatology and all the way, and all the audience for interacting. Thank you. Also to the organizers.
Thank you, sirs and ma'am. I now request Professor Dr. AJS Praveen sir to felicitate Dr. Ajita Damishaki ma'am. We also request Professor Dr. Parimalam Kumar ma'am to felicitate Professor Dr. AJS Praveen sir. Being dermatologists, almost all of us at some point have asked ourselves the question, how do I manage this? Be it a sticky situation, a doubt in treatment, or not seeing desired results. Help us all understand how to navigate such situations in future. We shall now have a discussion on the same from a young dermatologist's perspective. I request Professor U.R. Dhanlakshmi ma'am, Professor and HOD, Animalar Medical College, to moderate the session. I kindly request you to take over, ma'am.
Very good afternoon. Very good afternoon here to Anandal here. Of course, this session is mainly for the young practitioners and the PGs going to practice. Of course, these things are practical importance. Not all the things are evidence-based, but most of them are evidence-based and approved ones. Rijita is here. She will suit you if you go beyond those borders. So that we should be very careful on those things. So we'll go on with the session now. I invite our young panelist to take the chair here. Dr. Padam Kumar, Dr. Soundarya, Dr. Sivaramakrishnan, Dr. Shreya Srinivasan, and Dr. Vignesh Sivaraman here to guide us in our practice. So everybody is hungry. They're waiting for the lunch. So we'll stick on to the time. And this is androgenetic alopecia. Everybody will be seeing in our clinic. The young patients, even 14, 13, will come and ask for the remedy for this. I request Dr. Padam to take over this. How do you manage androgenetic alopecia in adolescent age group?
In adolescence age group, it is ideally better to go with topicals, topical minoxidil or in combination with finasteride. That would be good enough. In case they are not responding, we might need to consider oral finasteride. But I prefer not to give as early before age of 17 or 18 at least.
To safer side, you go with after 18, preferably 20. If they want, they have to come with the parents. Otherwise, the parent will read the YouTube, the patient will read the YouTube. We have to consider that. So after 18 is good. Very important.
The presence of parents is more important because nowadays many children walk in directly without their parents.
With their friends, girlfriends or boyfriends like that. They do their home derma roller. They tried everything. Even the minoxidil, they tried their own. Then they come to us. So we have to tell them that we have read already all those things. After reading those things, after passing our dermatology only, we are practicing. We have to insist that. Then how long you like to go finasteride? If the patient is about 20, the patient failed other things, how long you like to go? How many years?
So at least for a minimum of 1 year for us to assess the response. 6 months to 1 year is most ideal time for us to assess the response to the finasteride. And studies are there up to 4 years, 5 years also. So as long as patient desires and as long as there's no side effects being noticed, we can use safety. But ideally for 2 years, most ideal in most of the cases where we get the stability of disease. So till then we have to
see the maximum result. We have to wait for 2 years most of the time. So we can give that time. But if the patient is going to get married or any other issues, we can stop at any time. It is not a life-saving medicine. We can stop at any time. We can go with other modalities, like so many other modalities. We'll discuss later those things. And this is, of course, very good example. Very good example. The patient. Yeah. Yes, please. Yes, please. Yes. Yes.
If you do dermoscopy of the occiput, you will find that actually even miniaturization and hair diameter diversity is happening in the occiput. So if you're going to do topical, please do 2 ml for the whole scalp, and not just 1 ml for the frontal and the vertex. And this is a patient where I would seriously evaluate for insulin resistance, irrespective of the body weight and the BMI. And it's already published that adolescence and early onset AGA is linked to insulin resistance. Second thing, you want to be more aggressive rather than less aggressive. Because if it is started in adolescence, by the time this person is going to be 25, he might not have enough hair even for a hair transplant, especially for occiput. So oral minoxidil is something that I would definitely consider. And then we have a recent publication which says that dutasteride and finasteride can be given even in adolescence earlier, till the age of 21, because all the secondary sexual characteristics might not be completely developed. It was said that you're not supposed to, but now they say that you could. But main thing is lifestyle management and diet and exercise irrespective of the body weight. And of course, all the topical all over the scalp.
Yes, you correctly said. It is the first picture gives the androgenetic alopecia. The second one it gives like a diffuse alopecia like. So we have to consider. This is just for the discussion sake, we take the picture. It's not the exact picture here what we want. As she told correctly, earlier is the better. And hit hot, even in the alopecia, androgenetic alopecia. Thank you, Dr. Rajita, for the inputs. And this is actually the picture managed by the Dr. Padam. Can you put some insights for them in this?
So this case, he initially presented very high degree of baldness and with topical minoxidil oral finasteride for 1 year. We got this result. He wanted some more. Hair. So we started with PRP therapy, and post completion of 6 sessions of PRP was the second photograph. He wanted some more. So we switched to the mesotherapy aspects, and with mesotherapy has got better. So in resource poor settings where they don't have machinery or equipment for PRP or GFC, one can also consider mesotherapy, and it is one of the good options in getting better results.
There are so many new options.
Many options are available. Many companies are coming up with like growth factor mesotherapy is there. We have QR678. We have many other companies coming in. Exosomes are also there.
Good exosomes.
We can think about all of them.
Thank you. Yes, thank you, Dr. And this is a case of alopecia areata. Of course, it is well evident. It is a diffuse type. Description 18-year-old, sudden onset, and there is history suggestive of atopy available on eliciting history. And what are all your differential diagnosis? Dr. Soundarya, can you take up this?
Since she's a young female with acute onset of hair loss, I would think in terms of acute telogen effluvium and alopecia areata incognita.
Diffuse type. So there is one other bad company that is atopy history is there, suggestive of atopy history. So if it is a diffuse type of alopecia areata, what will be the prognosis in this patient?
Since the patient is a young female, the prognosis will be good only, especially
in alopecia areata, atopy. Two culprits are there together. Alopecia areata, diffuse type with atopy.
With atopy, it has a poor prognosis, ma'am, but tofacitinib, it has a better response.
Now we'll go on to this management part in this. So this is actually post picture. What was your management?
For this patient, we started on tofacitinib.
This patient you managed with that. Dosages 5 milligram? Twice a day. How long you have given?
This is the response that was seen after 2 months of treatment.
Okay. How long you like to continue tofacitinib?
Till the sufficient response, the sufficient hair growth is obtained, then I will gradually taper since it's an autoimmune condition.
Yes, of course. Everybody knows alopecia areata is notorious to recur, and there is another bad company with the alopecia areata, that is atopy is also there. We have to counsel the patient. So it may recur after stopping the thing, those things. And we'll move on to the next case. Suppose everybody is seeing daily in your practice. Without urticaria, we cannot live. Without antihistamine, we cannot live, and urticaria cannot go. So that I like to ask Dr. Sivaramakrishnan. So in this patient, it is of course recurring and not responding to routine treatment. So when you like to call this as a recalcitrant case of urticaria?
I can label a patient as a case of recalcitrant urticaria if he is not responding to the standard dosing of antihistamine. Despite the standard dose being given, he is getting recurrent beans. Probably term him as a recalcitrant case of urticaria.
So duration, any duration?
6 weeks. At least 6 weeks.
Minimum 6 weeks. They are not. Then how you like to investigate this patient?
Probably try to look for a hidden source of infection in this patient. Ask him
History.
to undergo
History. You like to go with the history first, then?
Yes. And I'll ask him to do a dental examination. Look for an ENT evaluation to look for any hidden source of infection, or a stool for cyst and ova sample. And also, I would like to look for any signs of autoimmunity in this patient. Ask for a thyroid peroxidase antibody. Look for an autologous serum skin test if necessary. And if the patient is having any other constitutional symptoms like joint pains, fever, probably evaluate for a possibility of urticarial vasculitis, especially if the wheals are lasting for more than a day.
More than 3 days most of the time. Okay.
Yes, ma'am. And probably check the level. Ask for history of atopy. If there is any history suggestive of atopy, look for the levels of IgE. If it's very high, it can help guide the treatment modality as well. these are the investigations I would like to do.
So in olden days, before investigation, we give a course of antibiotic, thinking that it is some infection somewhere from head to foot, anywhere. Like even candidal vulvovaginitis can cause. There are some papers like that. So that it is to ask for the infection. If it is not responding, patient want immediate relief. What would be the immediate relief?
So immediate relief, I would give him intramuscular dose of antihistamine like chlorpheniramine maleate along with a small dose of steroid as well.
Short course of
steroids, but I wouldn't opt for it as a first option. See if it's settling down with antihistamines alone.
So being a recalcitrant and recurrent, the patient also know that so that we can tell them according the side effects of steroids, so we can avoid it as much. Unless otherwise acute urticaria, angioedema, urticaria vasculitis, we can decide about it. Then what will be the first choice of drug antihistamine in this patient?
Ma'am, I would opt for a non-sedating second generation antihistamine like cetirizine, levocetirizine, or if the patient requires a non-sedating option, a more non-sedating option, I would prefer loratadine or desloratadine in these patients. If the patient is not responding to these measures, first I would like to updose the standard dose, try to give it up to 4 times the initial dose. Still the patient is not responding, I would have to look for a second choice.
In your practice, all this non-sedative antihistamine labeled, but feeling sleepy with that.
Yes.
How you will manage?
Yes,
I feel sleepy after cetirizine for 2 days. Then how you give me antihistamine?
Try loratadine or desloratadine.
I was sleeping with both of that. Even without that,
I find that most patients are tolerant to belastin and fexofenadine. They are not reporting any drowsiness.
Fexofenadine looks a very bulky drug, but still you can up dosing up to minimum 4 times, even 10 times it is allowed. That is the one choice. That's of course second choice. And of course, the patient who is coming with recurrent recalcitrant urticaria, she is giving early pregnancy, almost 3 months or 12 weeks like that. How do you manage with antihistamine in this patient?
If the patient absolutely requires an oral medication, I would ask her to go for a first generation antihistamine like chlorpheniramine maleate. Studies have shown that even loratadine or levocetirizine is also safe. If the patient is very hesitant to go for it, if the patient definitely requires an antihistamine, I'll ask her to go for chlorpheniramine maleate.
That's the best one. Of course, cetirizine is better than the levocetirizine. Loratadine is better than desloratadine. And of course, older antihistamine. Chlorpheniramine is good. And if the patient is not responding but wanting immediate relief, steroid you like to give in this patient, the pregnant patient. Which one? Dexamethasone, betamethasone, or prednisolone? Which one you like?
Go for dexamethasone. It's a longer acting.
No, pregnancy. Through early pregnancy. In all other steroid responding dermatosis, which steroid we give it? Prednisolone is the best one. Olden things are always good. Next thing. This is also another thing every day we see in our clinic. So this patient has a multiple. Again, it's a recalcitrant, not responding to conventional modalities like cryotherapy and radio frequency cautery. Responding. How do you manage, Dr. Shreya?
There are many new options available. Bleomycin is available. Immunotherapy in the form of MMR, PPD, BCG, even HPV vaccine is being tried. But I personally prefer intralesional MMR, given about 3 weeks apart. And I find that if it doesn't respond to the first 3 doses, it usually won't respond. The advantage of MMR over other conventional therapies is that you just have to give it at 1 or 2 sites. And what's at distant sites also, they clear off immediately. In sense, we have to give at least 6 months for it to.
So these are all the pre and post. You saved my questions. You answered already. So MMR vaccine. One advantage. I do radio frequency cautery and cryotherapy, but all of them have a recurrence rate and also some amount of scarring. We have to accept that. But here, one advantage, there is no scarring in this. And of course, you have to discard some of the patients who are not responding for 3 to 5 sittings. Maximum 5 sittings we can go on like. This is of course pre and post pictures. You already mentioned bleomycin and also the after the pictures like that. Which one is less painful? Bleomycin needling or MMR?
Conventional way is to do it intralesionally, ma'am. So if it's given intralesionally, it's extremely painful. But what I've tried here is needling with bleomycin, and basically the pain is less compared to intralesional bleomycin, and definitely pain is less compared to intralesional MMR. So
yeah, our olden days we used to give needling. Now the bleomycin, of course, cost is more than the trichlorotic acid. We do it 20%, 40%, of course. But one problem is some irritant dermatitis, and children won't tolerate. Like those things are the thing, and bleomycin is good in response. That's the advantage. Next thing is of course the same one, but there is a different manifestation. Almost 39-year-old female with skin lesions of 1 year duration, gradually increasing in size, HIV negative, not responding to routine therapy, and patient was started on with citratine and levamisole 150 milligram to as usual dose, and for the past 3 months still the lesions persist. How to proceed with this patient?
Have to keep a diagnosis of bovinoid papulosis in mind, and do a biopsy and maybe HPV typing if it's available. And I would advise a patient, irrespective of whether it is bovinoid papulosis or what, I'd advise a patient to go for either RF ablation or laser CO2, and maybe remove 5 to 6 lesions
by installments. You have to ask the patient may like to finish in one sitting, but it is very risky in this part. And bovinoid papulosis, what is the importance of diagnosing it?
A small percentage of patients can go into malignancy. It's commoner in males than in females.
Bovinoid papulosis itself is in situ aplasia, but some are benign. Malignant is rare, but still we have to keep it in mind, the malignancy part of potential. And even if you are lucky, even before your treatment, patient may get rid of spontaneous resolution also possible. There are so many other immunomodulators, suggestions are there. No, even your clinical counseling may get rid of the thing if you are lucky. This is of course ever-ending problem, melasma. This patient has macules on the face since 2 years. She has on triple regime, all the potent to medium potent triple regimes for the past 5 months. Now you can see the hypopigmentation as well as pigmented macules in between. How will you manage this condition, Dr. Soundarya?
Since this patient has been chronically abusing triple combination, I would like to rule out exogenous ochronosis. I would like to do dermoscopy to see if it has any changes.
Very good. Yes.
I would advise the patient to stop the triple combination. And I will also advise the patient that there might be a flare up of the lesions once she stops using the triple combination. But still she shouldn't be continuing. If it's very severe, I would like to add a low potent steroid and then taper it. I would advise the patient to use a broad spectrum sunscreen along with a moisturizer. And for the pigmentation aspect, I would like to start the patient on oral tranexamic acid 250 milligrams twice a day. If she doesn't have any thromboembolic events, both personal and family history, and if her coagulation profile is not.
Of course, very good. But the patient is refusing to stop the triple combination because it gives immediate relief. And they don't mind become depigmented or hypopigmented, but they don't want the black on the face. That's the thing. So we have to counsel them, and slowly you bring down the steroid usage, alternate days, once in 3 days, like that. Then you can counsel them. Then regarding the tranexamic acid, who are the best patients for the tranexamic acid oral route?
Tranexamic acid is not the first line of treatment for melasma. Of course, triple if you ask me, I would suggest triple combination as the first treatment.
How long triple combination?
To a maximum of 3 months. In between, if they get a response, I would also start the maintenance therapy in between, so that it would be easy for me to taper off the triple combination.
And what are the other depigmenting agents? hydroquinone, arbutin, all the main components in triple combination. So plain anti-depigmenting agents other than this hydroquinone and arbutin. What are the other things?
Glycolic acid and kojic acid.
Which is the best one? Which is the best one in your practice? Glycolic or kojic?
Glycolic acid.
Glycol is doing that. Glycol is doing that. Theory says kojic is alternative and the good, unless otherwise patient is not having any sensitivity to kojic acid. Any other agents other than kojic, glycolic?
Azelaic acid can be. It doesn't give that much of response.
Yeah, it is a very inert one, but you can add in combinations like that. And what about TCA peels? You have any experience?
Yes, ma'am. But especially in the skin of color, patients might, and this patient would actually have a skin irritation because of using triple combination for a very long time. So I would not suggest it for some time. I would give time for the skin to heal first. After that, only I will go for procedural management.
This patient is not at all for the procedure first. We have to stop the steroid, come out of it, and then you can plan it. Better to avoid any peels because she have some amount of atrophy, not macroscopically, microscopic atrophy will be there. That's a lesson we have to take it. And this is again, of course, melasma. This patient is using depigmenting agent, luckily not the triple, but without any adequate sunscreen. So whenever she go out, she gets worsening of the melasma and the recurrence of melasma. How to go with this patient, Dr. Vignesh?
One thing that I experience is a lot of the patients which I write depigmenting agent and sunscreen is they only buy the depigmenting agent. They never use the sunscreen. And they come back to me probably a week later and saying that they've gone a day they become more darker, like a shade darker.
Because of your medicine, it made her to so dark.
So they try to convince me that it's because of the depigmenting agent which I have given them. So then once I asked them, have you bought the sunscreen? They say, no sir, I didn't buy the sunscreen. So now I have
because it is too costly than the depigmenting agent.
So now I have to convince them to buy another sunscreen. At least stick to the old sunscreen that we get these days. So I think a special emphasis is needed whenever we deal with melasma patients, that they need to use a sunscreen. And I think all the people who have occupational exposure, they can stick with the physical sunscreen like umbrella, hand gloves, something would do. I think that would do much better.
The patient will say, I am not at all going out in sun. Why are you prescribing sunscreen? I am an IT job. I am always in the AC room. I am still get darkening. How to convince them to use the sunscreen?
They have like a prolonged usage of the sun.
UV lights.
So
all the LED lights are UV source. Even indoor job with LED light, they need a sunscreen. Especially nowadays, there are so many blue light protectors are coming out, so you can take the option. So even indoor, you are risk of UV light exposure. So we have to insist on that. So the message is without sunscreen, you don't accept any procedure on this patient. And without sun protection, other modalities like umbrella, caps, hat, and full sleeve things, everything we have to prescribe the depigmenting agents. This is of course. Keloid is again a recurring one. Even whatever the modality you do, they will get it to some extent. You have to retreat like that. So there is a patient with this type of keloid, like the sternum, there is some evidence of cyst and getting infected and ruptured and leaving a raw area, erosion and all. Dr. Padam, how to go with this patient with the symptom like itching, pain, infection and cyst formation. Of course, it is evident in the center and the cyst leaving a raw area. How to go with this patient? You cannot give intralesional steroid.
We cannot give intralesional steroid at the first shot. First, we need to do a first culture sensitivity, find out if there's any organisms, treat with antibiotics. You can take an ultrasound and can rule out if there's any sinus tracts inside, or if it is a sebaceous cyst within a keloid. You can do that. And surgical debridement of such keloids is always recommended. And we can surgically debride it and then allow it to heal with secondary intention, and then top it up with, I mean, later you can follow it up with intralesional steroids, and that will be helpful.
So this is after the surgical excision of the excess tissue and cyst, and this is healed by the secondary intention. And now this is a keloid suitable for your treatment. Okay, now
at the end of four series of ILCS, the current status is like this. And now what we notice is there are multiple hair follicles growing within the keloid. So I have also advised for the laser hair reduction, because that also helps. I mean, the hair follicles are the source of formation of future cysts. So we can undergo an LHR with this, and we can prevent further formation of keloids in future.
So better follow up and avoid other things like friction over the site and the dress and tight metals, anything, ornaments, all those things to be avoided. Like that is the worst keloid from worst keloid to better keloid for your treatment. You are making that patient like that. Of course, we also tell them no surgeries, but in the special situations, the surgery and excision, all those things are considered. Then this is again keloid. In the second prick, ear prick after that she developed.
This is keloid on the pinna, and she has developed because of a second prick in the cartilaginous area. And this was again excised, and the ILCS was given during the course of surgery at the base and in the surrounding areas, and it did not recur back.
So of course, with the small keloid on the post-auricular area, there are so many hanging keloids, and more than size of earlobe, there will be a keloid on the post-auricular area. So those things, this is the best option.
Scarring will always be there, and you need to inform them that there will be some degree of scars.
So this patient, surgical excision, and again you follow with the same thing.
ILCS.
Okay. So next we move on to already enough you had with Dr. Regita, and this is like already what other approaches. Now we go with only physical management. How will you manage this patient? Investigated as advised by Dr. Regita, but still they want immediate improvement with other modalities, our modalities to run our clinic. How do you continue? Dr. Seya, can you take up?
I'll skip the workup.
Yes.
As you said.
Yes.
Treatment purposes, topical retinoids are a good option in combination with the urea, lactic acid, glycolic acid combinations. And general advice, they'll have to reduce
lifestyle modification, as Dr. Regita's advice then.
And I also found that adding a low dose metformin or metformin glimepiride definitely helps in reducing the pigmentation and the thickness because of the insulin resistance.
Yes.
They want to go for procedure-wise, we can go for retinol peels, or even 15% trichloric acid peels. But like was mentioned, 15% TCA peel and skin of color can result in hyperpigmentation. Another procedure right now is microdermabrasion, diamond probe. It is still under study, but I think it would be better if it is in combination with the topical retinoids.
Thank you for the inputs. But one thing you have to keep it in mind: without working up this patient, never take the treatment. Like without sunscreen, you cannot treat the melasma. Like that, without working out basic investigations, don't proceed with immediately the day one when they want walk-in, immediately procedure, better not to take. This is for the youngsters. Always work out on this. It is not possible to treat superficially. You can burn the skin or peel the skin, but again it comes. So of course microdermabrasion, in my experience, it's not much doing anything on this. Maybe immediate skin polishing, so-called skin polishing is possible. So next move on to very vexing problem, dermatophytosis. This is how to educate the patient to avoid the OTC steroid misuse. Dr. Vignesh, can you take up this?
Off lately, we've been getting patients more of a steroid modified anemia rather than the regular one. And I think before 5 to 10 years, patients directly came to the doctors or dermatologists. But nowadays they only go to the pharmacist, get a steroid ointment, probably a combination drug. Once the itching subsides, they think that the infection has gone. But again the itching comes back. The lesions have been changed into a different morphology. So that's the time when they come to the dermatologist. So I often advise them to completely stop using whatever treatments they are using, because traditionally we used to taper the steroids, but here I ask them to completely stop it. And to repair the skin barrier, probably I'll give some moisturizer. Then I'll start with my regular itraconazole or other antifungal topicals, and that goes for another month, at least a month or 3 months together.
Maybe after some years, we may not see that classical dermatophytosis. We may see only incognitous only. So it is better to add on the textbooks the morphology of the things in pictures. So in dermatophytosis, there is no tapering of steroid alone. Better stop the steroid. That's the best thing. And combinations. Acne. So this patient worsening of the acne after some treatment. Sometimes skin care products available in the market. Immediate relief is coming. Then again the worsening of the thing. This is all the YouTube prescriptions. It's not by doctor's prescriptions. How do you manage this patient? Especially how to counsel them.
Patients they don't come to us to ask for any prescriptions. They just come to us to get a reassurance that whatever products they are using works. Most of the patients I get, doctor, I'm using all these products, whether all of them work. And there are a lot of companies these days in the market which we cannot advocate for. So I always tell them to stop whatever they're using. Either they should stick to the commercial products or to the medicated ones which I prescribe, and I completely change their routine. Even then, I have seen many patients. Imagine I'm writing like 3 or 4 drugs. They only take 2 of mine and they stick to the other 4 which they are already following. They're so attached to their products.
Because they spend already on that. They bought it from the YouTube big container. That's the thing. We give sample, and if it is happy, they like to continue like that. We prescribe. So how to manage them?
I always tell them whatever they're using, they have to stop. Only then I can give them a proper treatment, and we can assess whether it works or not. So in that way, it's better for me.
You can ask other way also. You complete all the products and come to me later. You can have more benefit. So regarding the doxycycline and isotretinoin, patient want immediate relief. Which one you like to go? Or you like to go both?
Grade 1 and 2, I always go with doxycycline, given the safety profile and all of that. I think even it has a better result compared to isotretinoin. But there are certain patients, when I give isotretinoin, they come back a week later. It's in the purging phase. Some of the patients don't even come back. I think because of the isotretinoin, the acne has increased. So that is again another.
Isotretinoin flare-up.
Yes. So I think I'll always stick with doxycycline. It works for me traditionally, and probably I'll give a topical retinoid or something.
You combine both in some situations?
Yes, ma'am. Probably.
Is there any caution you have to take?
Yes, ma'am. Pregnancy
other than the pregnancy. Otherwise, both are contraindicated in pregnancy. Combination of doxycycline and isotretinoin. Better not to combine. Why? Dr. Padam is ready to answer.
It causes pseudotumor cerebral symptoms.
Both.
Orally it should not be given, but yes, topical retinoids can be prescribed with doxycycline. I would also like to add one more point on this. So we should start writing stop prescriptions.
Pardon?
We should start writing stop prescription. So when patient comes with a huge list, I just keep noting it down. At the end, I just put a box and write it down stop.
Yes.
And when we suspect the things like the patient is gonna abuse it in future, like whenever I prescribe a steroid, I just write down for so many days and stop. So that way the patient become more aware of it, and slowly we can change the tradition of abuse potential.
That's a good point. We have to take up, and of course, yes. Duration, area and duration. I have a seal like that. Even for isotretinoin we have. Okay. Yes. Stop it. That should be in the red or in a box like that. That's always a safer side for us. Otherwise, the lawyers you never told like that. We never told to continue also, but they will say you never told to stop. That only they make the point. That's a problem. Okay. So of course we are going on to the last slide, I think. And last but one. This is of course you know this is acne, upper middle-aged female. And it is coming for the last decade, more than 10 years. And it comes and go with the treatment. And already Rajita had given enough knowledge about the hormonal acne. In this patient, what are the things for the hormonal acne? Dr. Sivaramakrishnan?
Ma'am, apart from the acne, she also complains of hair loss.
Yes.
Of course, there is an irregular menstrual cycle. So all this point towards an hormonal etiology in this patient. Clinically also, she is having lesions on the jawline, which again points towards an hormonal etiology.
And what are the investigations?
And also, I would like to ask her if she routinely shaves. Otherwise, she might also be battling with hirsutism as well.
Yes, of course, any history of PCOS like that. Okay. Then investigations already it was done by Dr. Rajita in a very good slide. So everybody is aware of that. And you do prescribe anti-androgens in managing hormonal acne?
Not routinely, ma'am. First, I would try the traditional treatment options and also ask the patient to do some lifestyle modifications initially. Ask them to go for a weight loss regime, follow a healthy diet, and of course start working out. And if the patient is not showing any signs of improvement with this, or if the patient has an overt hyperandrogenism, there is a symptom of virilization. In that case, probably we'll have to evaluate the patient and start the patient with anti-androgens. Or very resistant cases, I would like to initially start with a combination oral contraceptive provided there is no contraindication for that, like any risk of vascular thromboembolism in the family, or any history of breast cancers in the family. In that case, we can start with an anti-androgen. My choices are combination OCPs or spironolactone.
That's good. Of course, we should be aware of all the side effects of anti-androgen also before prescribing any drug. That should be the first thing. Most of the drugs, they don't want internal medicine. Some of the patients, they come and say, I don't want any internal medicine, give me only external. But we have to explain them. It is not possible only with the topicals in this type of patients. So you have to investigate without making the base. It is not possible to do anything on the top. So this patient was treated for acne for some years, and everything cleared. There is no fresh acne, but some lesions persist on the chin area. This is, of course, everybody knows this is a papular acne scar, persisting acne scars, papular scars. How do you manage, Dr. Soundarya?
Since this is a scar, I would like to give the patient intralesional steroid injections at a very low dose.
So normally we get acne scars, all destruction and ice pick scars are inside. Why the scars like this, coming like this?
Because of the elastolysis that's present.
Of course, in chin and jawline and all, they are more fibrous. There is a dysregulation of the fibrous tissue. They are more prone for producing that. Even any surgeries in these areas, you can expect keloid. Keloid up to the only on the chin area we see, not above the area, face thing. That's why the anatomy differs like this. So which one is best? You told both the thing, no? One is RF and next thing is ILS.
I told ILS, but intralesional RF can also be done. Chances of scarring is more in intralesional RF. So I'd like to first try intralesional steroid. If it doesn't work,
very low dose RF like that. Just for the junior set, how you give the intralesional in this patient, how much dose, how you give it?
Triamcinolone, I would get 10 mg per ml and I would dilute it 3 times, and I would give it like 0.1 ml per lesion. It's always better to underdose than to overdose.
So if I dilute it 3 times, 0.1 ml is almost containing 0.03 milligrams of triamcinolone. So you have to mention the dose, where you give, how much you give, how many spots you give. Then only you can assess later. Yeah, please, Dr. Rajita. That is why. That is the thing.
They are elastolytic scars. A steroid is going to make things worse. These are actually not hypertrophic scars. These are atrophic scars. And it is pouching out, protruding because it is something like anatoderm. So in anatoderm also you have skin which is elevated. So you actually have, if you have a big enough lesion, you will find the buttonhole sign also in it. So doing a steroid injection is going to make it worse. So there are two ways I treated. One is the pinhole method. It was initially described for surgical erbium, pure ablative erbium yak. But most of us have a surgical CO2, fractional CO2 combination. So if you're able to just do that at the center for smaller lesions, that works beautifully. For the larger lesions, intralesional radiofrequency. But intralesional steroid is going to be counterproductive.
Actually, one point, this picture, it is better if it is on the nose. That is actually the gravity makes this, since you told the zanitoderm elastrolysis, it is hanging down, the gravity. But this is for the picture sake we have taken, it is, your point is well taken, but this is to show the papular scar. If it is on the nose, that is the choice. But the RF will be good. Only thing without scarring we have to do.
One more thing, ma'am. You also want to induce elastin fibers.
Yes, 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 yes.
It's going to flatten, but then it will come back again. You want to combine ideally
That's a good choice. MNRF is the best choice. Next, we have to think all this. We have to think all this. The gravity makes it, even though it's atrophic elastrolysis, it is hanging down like a neurofibromatosis, something like that. Even neurofibromatosis, if you do something, you may induce a thing like that. Thing like that. We have to take care of all those points. If it is on the nose, normally it responds very well. If it is here on the back, and on the back, of course, your keloidal scars are the back choice. It is a good choice. We can do acne scar places in different places, in different modalities. Not always in the same modality. Sometimes combinations, as she told, the laser and everything. So we want to induce some, like any acne scar, you can go with the MNRF also. So this is the last slide. Any other? Oh, Dr. Jita is there still. Any other thing Dr. Jita want to add? Any other thing you like to give lights? Thank you for the patient listening. I thank all our committee members giving me this chance to stand here to give some learnings from our juniors. Thank you all the panelists. Thank you. The audience now already started. This slide is. Thank you.
Thank you, ma'ams and sirs, for that interesting discussion. I now request Professor U.R. Dhanlakshmi ma'am to felicitate Dr. Padam Kumar sir, Dr. Soundarya ma'am, Dr. Shivaramakrishnan sir, Dr. Shreya Srinivasan and Dr. Vignesh Shivaram. I also request Dr. G. Suchitra ma'am to felicitate Professor U.R. Dhanlakshmi ma'am. We shall now break for lunch, and I request you all to please be back in half an hour so that we may begin the following session on time. Thank you.
The next free.
Hello, check.
This is for the kind announcement of everyone. We'll be starting the afternoon session in a short while. So please be back.
Is Dr. Vidyashri here? You're ready for the presentation? Yeah.
Welcome back, everyone. Hope you all had a great lunch. We'll get into the next free paper session of the day to be presented by our vibrant young dermatologists. This session will be chaired by Dr. G. Suchitra Ma'am, Associate Professor, Department of DVL, Government Kilpauk Medical College. Ma'am has numerous publications to her name and has received various awards over the years. I kindly request you to take over, ma'am.
Good afternoon to all. Post-lunch session, I think we'll have difficulties concentrating. Let's get started with the first topic of this session. I welcome Dr. Vidyashri, present on threats of fragility, interwoven forms of epidermolysis bullosa.
Good afternoon, ma'am. As we all know, epidermolysis bullosa is a group of rare inherited skin disorder causing skin fragility and blistering. It is classified depending upon the level of skin cleavage and specific genetic mutations into simplex, junctional dystrophica and Kindler types. Although overlap between types can occur, simultaneous features of all three variants in one patient is extremely rare, posing significant diagnostic and management challenges. Case discussion. A 26-year-old male born of second-degree consanguineous marriage presented with multiple fluid-filled lesions and scars over trauma-prone sites and over back since birth associated with itching on and off. Family history was positive, found in his elder brother. He had no history of palms and soles involvement. No history was positive pertaining to associated diseases like pyloric atresia, cardiomyopathy and muscular dystrophies. General examination was found to be normal. Growth and nutritional status was adequate. Systemic examination was also normal. On dermatological examination, multiple vesicles and bulla of varying size present over both knees, left dorsum of hand. Atrophic depigmented scars with surrounding hyperpigmentation noted over both lower limbs, upper limbs and trunk. Depigmented atrophic scar noted over the dorsum of hand. Nail dystrophy and anonychia was present. There was no mucosal involvement. Palms, soles, hairs, scalp were normal. Zang smear from the bulla was negative. Clinical diagnosis of an inherited bullous disorder was considered. On investigating, his hematological and biochemical parameters were normal. On biopsy from the bulla, epidermis showed hyperkeratosis with subcorneal bulla. The first image shows the split below the substratum corneum. Dermis showing a dense periodintic cell and perivascular infiltrates composed of lymphocytes, plasma cells, proliferating blood vessels and fibroblasts. Few areas showed a subepidermal hemorrhage, giving an impression of suprabasal bullous disorder. Immunofluorescence were negative. Rule out the autoimmune etiology. ECG was normal. There was no arrhythmia. Echocardiogram showed no muscle thickness. Ultrasound, no abnormality was detected. Esophageal gastroduodenoscopy was also normal. Genetic analysis showed multiple gene deletions like lectin, laminin beta-3, collagen 7, suggestive of coexistence of epidermolysis bullosa simplex, junctional and dystrophica respectively. With genetic study and histopathology, a diagnosis of epidermolysis bullosa was considered with three types of simplex, junctional and dystrophica. As our patient is an adult male, a main line of management will be of supportive care in the form of psychological care, psychiatric counseling and nutritional support. General measures include avoiding trauma and protect the trauma-prone sites by using cotton socks, to be in air-conditioned, low humid, cool environment. Keep the palms and soles cool and dry. Loose-fitting cotton clothing are advised and to prevent the secondary infections. Discussion. discussion. Even though our case was clinically an EBS of intermediate type, genetic study revealed it as an overlap case of simplex junctional and dystrophica variants. If he is planning for marriage, will advise for genetic counseling. And prenatal and pre-implantation diagnosis has been evolved. Proper wound care with the dressing materials like silicone mesh, lipid colloid content, collagen sheets, biological skin substitutes like amniotic membrane, dermal grafts were evolved. And novel therapies like gene therapy, protein replacement therapy, and cell-based gene therapy has also been evolved. Under gene therapy, ex vivo keratinocyte culture and transfer. Under protein replacement therapy, recombinant protein used topically, systemically, and intradermally injected in the place of into the affected skin. Cell-based gene therapy, human fibroblast therapy, direct injection into the skin, affected skin. Patient-specific induced pluripotent stem cells transformed into fibroblasts, which helps to produce type 7 collagen. CRISPR-Cas gene editing helps to correct the collagen-deficient fibroblast. As we all know, epidermolysis bullosa is one of the devastating genodermatosis. Diagnosis mainly relies on clinical evaluation, histopathology, immunofluorescence with antigen mapping, genetic study to classify the subtypes. Management will be of mainly supportive and multidisciplinary approach. Early recognition, accurate classification, and coordinated care are essential to improve the quality of life and to prevent the long-term complications. These are my references, ma'am. Thank you.
First, let me congratulate you. It's a good presentation and it's an interesting case. As you highlighted, the supportive care takes equal weightage in managing this patient. It's a grown-up male who could be an earning member. So, how to go on with the disease? Because therapy-wise, many are still in research stage. So, supportive care is very important. Good presentation. Any questions from the audience?
Thank you.
The next person is Dr. Elsa, presenting on a closer look at classical juvenile pityriasis rubra pilaris case series.
Good afternoon. I'm presenting a paper titled A Closer Look at Classical Juvenile Pityriasis Rubra Pilaris, a case series. Introduction. Pityriasis rubra pilaris, or PRP, is also known as lichen rubra pilaris or Divergis disease. It is a chronic inflammatory papillosquamous skin disorder with an incidence of 1 in 50,000 in India. It may be sporadic or familial with various triggers and associated diseases. Griffith has classified it into 5 types, and later a 6th type was added, which is associated with HIV infection. Here we discuss about the 3rd type, classical juvenile pityriasis rubra pilaris, which is seen in ages 5 to 10 years, with the characteristic features of generalized discrete hyperkeratotic follicular papules coalescing into orange-red plaques, brand-like scales, erythematous orange background, and islands of spelling. Yellow-orange waxy palmoplantar keratodermas also seen. Nail changes may be present. Its progression is cephalocaudal, starts as scaling over the face and scalp and progresses caudally, with complications of erythroderma and ectropion. Majority resolve in 1 to 2 years, while some persist beyond 3 years or even evolve into type 4, which is circumscribed type. Case 1. A 10-year-old boy presented with 1 month of facial and scalp scaling, followed by raised lesions all over the body. There was history of occasional itching and burning sensation on exposure to sunlight. Here we can see there is confluent skin-colored follicular papules distributed symmetrically over the chest, abdomen, back of trunk, bilateral upper and lower limbs, mainly on the extensor aspect. And there is diffuse scaling of the scalp and face with difficulty in eye closure, and plaques over the elbows and bilateral knees. There is a yellowish palmoplantar thickening, and dorsum of the hand shows follicular hyperkeratotic papules, which is also known as Bayer's sign. The dermoscopy showed orangish background, perilesional scaling, yellow-orange halo, centrifugal scales, follicular plugging with central hair, perifollicular scaling, and diffuse scaling. HP shows orthokeratosis, focal parakeratosis, focal hypergranulosis, acanthosis, and foci of spongiosis, and there was suprapapillary thickening. Case Case 2, an 8-year-old girl presented with widespread scaly lesions all over the body with burning sensations for 5 weeks duration. Here we can see there is similarly distribution of follicular papules all over the body, especially the extensive aspect of the limbs and the trunk. We can see nail changes in this case. There is diffuse scaling of the scalp and face, and there is difficulty in closure of the eyes. There is scaling and erythema of the palms, and there is Bainio sign present here also. Dermoscopy shows orange background, yellowish orange halo, minimal scaling and central hair. Histopathological examination shows compact orthokeratosis, parakeratosis, hypergranulosis, acanthosis, broad reedy ridges and suprapapillary thickening. Case 3. A 10-year-old girl presented with a 20-day history of multiple raised lesions on her abdomen and extremities associated with occasional itching. In this case also we can see there is follicular papules all over the body, but it is to a lesser extent compared to the previous two cases, probably due to the early stage of the disease. Here also we can see the Bainio sign, where there is hyperkeratotic follicular papules over the dorsum or the proximal dorsal fingers. The dermoscopy shows reddish orange background, follicular plugging, central hair, perifollicular and perilational scaling. Histopathological changes were minimal in this case. Discussion. All three cases are in the age group of 5 to 10 years. Both males and females were affected. History of burning sensations present in cases 1 and 2. Classical follicular papules over trunk and extensor aspect of limbs and cephalocaudal progression was noted in all three cases. Nutmeg grater sign or Bainio sign was seen in all three cases. Scaling of scalp and face present in cases 1 and 2, and so was difficulty in eye closure. Waxy palmoplantar keratoderma was seen in case 1 and 2. Biopsy had more classical features in case 2, while the other two cases showed only few of the typical findings. The dermoscopic findings in our case were orangish red background, follicular plugging, central hair, perilesional scaling, and yellow-orange halo. Few of these findings were also seen in a similar study done by Jha, A.K. et al. Few of these findings were not noted. In conclusion, classic juvenile PRP is less common and challenging to diagnose early due to its similarity to guttate psoriasis, atopic dermatitis, lichen nitidis, early lichen plants. Clinical features should raise suspicion, and in the presence of atypical features, diagnosis can be aided by dermoscopy and histopathology. Considering complications of erythroderma and ectropion, early detection and timely management is crucial. These are my references. Thank you.
A good collection of cases, doctor. I mean, as you mentioned, pediatric age group erythroderma is an important thing. Not only the patient, you have to treat the parents as well. So in that case, you need to pin the diagnosis of the original pathology. All the classical and name signs are very important that you rightly highlighted. The histopathology was as you highlighted. If you had classical findings in one case, good presentation. Go ahead. Next topic is Morphe Reimagined, a clinical tapestry of localized scleroderma subtypes by Dr. Shari.
Good afternoon, everyone. I am here to present on the topic of Morphe Reimagined, a clinical tapestry of localized scleroderma subtypes. Morphe or localized scleroderma is a rare chronic sclerosing autoimmune skin disorder. It is more common in female than male. It is characterized by excess collagen deposition leading to thickened and hardened skin or subcutaneous tissues. Etiology is not well understood. Suggested triggers include local trauma, infections like Borrelia burgdorferi, radiation therapy, genetic predisposition, and autoimmune dysregulation. Unlike systemic sclerosis, Morphe lacks internal organ involvement and Raynaud's phenomenon. Aims and objectives. To analyze the varied clinical presentations of Morphe, to correlate clinical, dermoscopic and histopathological findings, to highlight the importance of multimolecular diagnostic approach for personalized management. Methodology. It is a retrospective observational study. The duration of the study is 1 year. It is done in tertiary care dermatology center. Diagnosis is based on detailed history, clinical examination, dermoscopic examination, and histopathology done for patients with clinical suspicion of Murphy. Inclusion criteria were patients clinically diagnosed with Murphy, that is localized scleroderma, based on history and physical examination, and diagnosis confirmed by dermoscopy and histopathology, showing features consistent with Murphy. And exclusion criteria were patients with systemic sclerosis or features suggestive of systemic involvement like Raynaud's phenomenon, sclerodactyly, and internal organ fibrosis, and patients not willing to participate in the study. Coming to results, in the case series of 12 patients, 8 patients were female and 4 were male patients, and all these patients were in the age group between 6 and 60 years. Out of 12 cases, 6 cases were block type Murphy, 4 cases were linear Murphy. In the 4 cases, limb involvement is present in 1 case, NCOOP D-Saber type is present in 2 cases, and Parry-Romberg syndrome is present in 1 case. And 1 case of generalized Murphy and 1 case of keloidal or nodular Murphy. This chart depicts the percentage of distribution of subtypes of Murphy. Block type constitutes 50%, which is followed by linear Murphy, 33.3%, which is followed by generalized Murphy, and keloidal Murphy, 8.3% each. Murphy is a clinically heterogeneous disease with subtypes varying in presentation, depth of involvement, and prognosis. Block type Murphy. It is a most common type. It predominantly involves trunk, and it also involves the limbs. It has 3 stages. In the early stages, it is presented as erythematous or violaceous patch with a lilac ring in the active border. In the sclerotic stage, ivory white firm scale will be present in the center with the lilac ring in the periphery. Hair loss and loss of skin appendages will be noted in the affected area. In the fibrotic stage, atrophy of the skin is present with pigmentary changes like hypo or hyperpigmentation. In this type, only minimal disability will be present, and patient mainly comes to doctor for a cosmetic concern. These are the clinical pictures of 6 patients in this study, showing well to ill-defined hypo or hyperpigmented clot with indurated skin. Dermoscopy shows white fibrotic homogeneous areas, brownish pigmentation or structureless areas, fine linear or urbanizing vessels, loss of pigment network, yellowish orange or structureless areas, loss of follicular opening, shiny white lines or streaks, which is chrysalis structures. On histopathology, epidermis preserved with a mild flattening of rete ridges. Thick and hyalinized collagen bundles are seen in the dermis. Collagen arranged parallel to epidermis. Loss or entrapment of admixture structures are present. Superficial and mid-dermal lymphocytic infiltrates were seen. Partial replacement of subcutaneous tissue by sclerotic collagen was seen. Linear Murphy. This type affected mostly children. In NCOOP D-Saber type, a depressed linear lesion was present over forehead or scalp, which may be associated with alopecia, which may or may not involve the underlying bone, meninges, and brain. In Parry-Romberg syndrome, progressive hemifacial atrophy, that is atrophy of skin, fat, muscle, and bone, which may be associated with the seizures, trigeminal neuralgia, and other neurological features. In trunk or extremity type, band-like induration noted along the Blaschko's lines, which may cause contracture and deformity when it crosses the joint. In our case, the band-like induration was noted in the right upper limb, which extends from right arm, crosses the elbow joint, forearm, wrist joint, and it terminates at the right ring finger tip, causing deformity over the elbow joint and right ring finger joints. On histopathology, replacement of normal dermal architecture with hyalinized collagen was seen with the loss or marked reduction of admixture structures like hair follicles and sweat glands. generalized MRP. Here, more than 4 clocks will be seen over more than 2 anatomical sites. Confluent and widespread induration with skin tightening and restricted mobility noted across a multiple sites. It is more common in adults. Keloidal or nodular MRP. It is a rare variant characterized by keloid-like indurated blocks overlaying sclerotic skin. Clinical features. It is a firm raised shiny nodules or blocks resembling keloids. It typically occurs over pre-existing morphe lesions. It may be skin colored or hyperpigmented. Pathogenesis. It is due to excess collagen deposition in dermis beyond typical morphe, and it is due to aberrant fibroblastic activity similar to keloids. Discussion. Integration of clinical dermoscopic and histopathological features enhanced diagnostic accuracy in all morphe subtypes. Dermoscopy proved especially valuable in identification of stage of disease activity, selection of optimal biopsy response, monitoring response during treatment and follow-up. Histopathology served as a confirmatory tool, providing insights into depth of sclerosis, chronicity of the disease based on collagen deposition and adnexal loss. Multimodal approach supported early diagnosis and individualized management, especially in overlapping or atypical presentations. Conclusion. Morphe exhibits broad clinical heterogeneity. Multimodal diagnostic tools aids early and accurate subtype classification. Importance of early recognition is to minimize functional impairment and cosmetic complications. It is needed for a tailored and multidisciplinary care approach. These are my references. Thank you.
A good presentation. I mean, like whether localized disease or a generalized morphe, yes, you have to pick up the case early. Because early management is going to prevent cosmetic disfigurement and deformities. Once those disfigurement has set in, even if you intervene, outcomes can be variable. But you have a good sense of recovery, and you have an early diagnosis. So that is the key. Okay.
Yes. Thank you.
Now calling Dr. Thirukumaran to present on phases of cutaneous TB, a case series on lupus vulgaris and variants.
Good afternoon. Phases of good afternoon, I am presenting the case series of lupus vulgaris and its variants. Lupus vulgaris is the most common chronic and progressive form of cutaneous tuberculosis in individual with moderate to high degree of immunity to Mycobacterium tuberculosis. It is acquired either exogenously by direct inoculation of bacilli into the skin or endogenously by activation of dormant focus. Clinically, lupus vulgaris presents as plaque, papular, nodular form, ulcerative and mutilating form, tumor-like and vegetative form. We have in the cases of 5 patients present in the age group of 34 to 70 years of age, and 4 of them were male patients and 1 of them were female patients. The present duration is 3 cases for 1 year and 2 cases are present for 2 years. The sites are on the right gluteal regions, dorsum of right hand, right forearm, right knee and right third toe. These are the clinical pictures of 3 or the plaque type of cases. Present with single well-defined annular plaque with central scarring and on the progression at the periphery. And one case of nodular type of lupus vulgaris presents as single well-defined erythematous nodules of size 1 × 1 cm over right forearm. And one case of ulcerative type of lupus vulgaris single well-defined erythematous plaque with ulceration and pus discharge. These are the histopathological images of the patients present with epidermal hyperkeratosis and tuberculoid granulomas, scanty cases necrosis with epithelioid histiocytes and multinucleated giant cells. With a demonstrate no acid fast bacilli. Standard 4-drug anti-tuberculosis therapy was started for all patients. In intensive phase, rifampicin, isoniazid, pyrazinamide and ethambutol, and in convention 2 months of convention phase, rifampicin and isoniazid are started for all the patients. These are the post-treatment pictures of the patient. Discussion. Postbacillary nature of the lupus vulgaris by histology shows tuberculoid granulomas with few bacilli. AFP culture often negative. PCR improves strong tuberculin reactivity. Lupus vulgaris occurs in tuberculin positive, highly sensitized hosts. Multimodal spread by hematogenous, lymphatic, contagious spread or exogenous inoculation by post-trauma or by vaccination. Histopathological findings shows epithelial granulomas, Langerhans giant cells, scant caseation and epidermal hyperplasia may be present. The four drug treatment is effective for most lupus vulgaris patients with healing in 6 months. To prevent the chronicity and risk of malignancy by early detection and treatment. This series highlights the importance of combined clinical, histopathological and molecular diagnosis in suspected cutaneous TB to enable timely effective treatment. All patients demonstrated strong tuberculin reactivity with normal chest radiographs consistent with localized skin limited lupus vulgaris. Plaque type was the most common clinical presentation, but nodular and ulcerative morphologies were also encountered. Lesions occurred on both exposed and cover site, indicate no site predilection. All patients respond well to standard 4-drug anti-tubercular therapy with regression of lesions and no relapse during follow-up. Reference. Thank you.
Good presentation. What was the differential diagnosis you considered for the nodular and ulcerative types? Classical type was there, apart from that, other forms of
lymphocytoma, sarcoidosis.
Anything else? Any other infectious etiology? Anyway, your walk-up is going to guide you in the right direction. And being a paucibacillary type of cutaneous TB, it is going to respond for a short course. 6 months of therapy, very rarely ending up at 8 months therapy. Good presentation, but we need to look out on the case series. Look for the other details.
Okay, thank you.
Now calling Dr. Vinod Kumar to present on clinical variability in lymphangioma circumscript.
Good morning, everyone. I'm going to present lymphangioma circumscriptum, a case series of three varied presentation with dermoscopy. Lymphangiomas circumcision is a hematomatous malformation of superficial lymphatic with deep involvement and a high risk of recurrence. It can be congenital or acquired, presence as grouped vesicles or papules. It involves abnormal saccular dilatation of lymphatic ducts in the skin, and subcutaneous tissue. Common sites involved are extremities, trunk, axilla, buttocks, and oral cavity. Dermoscopy is a non-invasive tool that reveals specific diagnostic pattern which can aid in diagnosis. The three cases, the age ranging from 25 to 40 years. Case 1 patient is primary 35 weeks. Case 1 lesion starts from since birth. It increases in size past 3 years. Patient was asymptomatic. There were nil past significant or associated illness. In case 2, the lesion were present for past 8 years. It gradually increased in size. Recent worsening was noted post-trauma. There was mild pain and clear discharge and occasional blood-tinged discharge. Patient has history of inguinal surgery 11 years and there were no associated illness. In case 3, it was present since 2 years of age. Lesion was stable. There were no symptoms. There were nil past history and associated illness. Lesion morphology. All three cases there were multiple vesicles and papules. In case 1 it was present over right anterior abdominal wall. In case 2 it was present in anteromedial aspect of right thigh. In case 3 it was present in all over the scrotum. And in case 2 it was some mild discharge was present. These are the dermoscopy of all the cases. The common findings were multiple yellowish white lacunae and whitish pale white septa. Pale septa is marked in the first picture in the green arrow, and in yellow arrow it's marking the lacunae. lacunae. The right side image shows that hemorrhagic one. It has additional reddish violaceous lacunae and a unique one hypopian sign half an of lacunae, which is denoted in white arrow. And in third image below one, it has additional pinkish tinge over the green arrow, which is marked in the green arrow. Discussion. Lymphangioma, congenital lymphatic malformations, accounting for 4% of all vascular tumors, 25% of benign vascular growths in children. The most common type is lymphangioma circumscriptum, is currently referred to as superficial lymphatic malformation. Clinically presents as cluster of translucent vesicles resembling frog spawn on skin. Differential diagnosis include lymphangiectasis, hemangiomas, angiokeratomas, molluscum contagiosum, wart and epidermal nevi. The clinical variability exists from asymptomatic congenital form to symptomatic post-traumatic acquired cases. Management, however, remains challenging, ranging from conservative observation in asymptomatic case to surgical excision or laser therapy for symptomatic case, recurrent or cosmetically concerning lesions. Patient counseling is crucial given the risk of recurrence. This to compare my study with the other studies. The dermoscopic finding are yellow lacunae with pale septa, which correspond to pure lymphatic content. It was present in 100% of my cases, and common finding in all other studies. Pink to red lacunae corresponds to some blood inclusion in it. It was present in 2 cases of my study, and very less frequently present in other studies. Hypopian sign which represent sediment of blood component, present in one of my cases. It's the least presentation in all other studies. So we can consider the yellow lacunae with pale signs as a hallmark. The conclusion is lymphangioma circumscriptum superficial lymphatic malformation shows diverse clinical and dermoscopic patterns. Our three cases highlight the clinical spectrum of lymphangioma circumscriptum and the dermoscopic spectrum from simple to complex pattern. While histopathology remains the gold standard, dermoscopy enhances early recognition and can abate the need of biopsy. Patient counseling essential due to high potential of recurrence. These are my reference. Thank you, ma'am. Thank you.
Good presentation, doctor. All the doctors present today, dermoscopic findings were good work, good workup, and they presented well. They went through hell of a practice for presentation. And you managed to pick up hyperpion and all. It's good effort.
Thank you.
Thank you, ma'am. I'll now request Professor Dr. Madhu ma'am to felicitate Dr. G. Suchitra ma'am. It's now time for our last and final 3 paper sessions of the day. I request Dr. R. Satyanarayanan sir, Professor and HOD, Wales Medical College and Hospital, Manjakarnai, to chair this session. Sir, please.
So good afternoon, one and all. So let us come to the closing session of the program. I am Dr. Satyanarayanan, dermatology from Wales Medical College, chairing the free paper session. May I have the first speaker, Dr. Niraimadi, speaking on comparing the efficacy of etanercept and secukinumab in severe chronic plaque psoriasis.
Good afternoon, everyone. Good afternoon, everyone. I am presenting a paper titled Comparing the Efficacy of Etanercept versus Secukinumab in Severe Chronic Plaque Psoriasis. Introduction. Psoriasis vulgaris is a chronic inflammatory disease with strong genetic predisposition and autoimmunity, which affects 1 to 3% of the population. It is caused by inappropriate activation of T lymphocytes and dendritic cells, leading to increase in inflammatory cytokines such as TNF-alpha, interleukin-17, and interleukin-23. Dermatological manifestations of psoriasis are varied, with plaque type being the most common clinical presentation. Psoriasis typically affects the skin, but may also affect the joint. Various treatment options include topical steroids, calcineurin inhibitors, emollients, vitamin D analogs, phototherapy, immunosuppressants, retinoids, and biologicals for refractory cases. The biologic therapy includes drugs which are proteins produced by living organisms to target specific points of inflammatory cascade, including antibodies against cell surface markers, cytokines, and other molecules. Biologics target T cells or antigen-presenting cells or block the inflammatory action of cytokines like TNF-alpha and other cytokines. Biologic therapy such as etanercept, which is TNF-alpha inhibitor, and secukinumab, which is interleukin-17A inhibitor, have revolutionized treatment of chronic plaque psoriasis. This study aims to compare the efficacy of etanercept and secukinumab in severe chronic plaque psoriasis. Indications for biologics, PASI, that is psoriasis area and severity index, score of 10 or more, or a body surface area of 10% or greater, where PASI is not applicable, and a dermatology life quality index greater than 10. Severe disease for 6 months and resistant to treatment. Drug-related toxicity and where alternative standard therapy such as saxitretin, cyclosporin, methotrexate, and narrowband UVB, PUA cannot be used. Intolerant or cannot receive or patient who are unresponsive to standardized therapy. Patient requiring repeated inpatient management for control. Significant coexisting and unrelated morbidity which precludes the use of systemic agents like cyclosporin and methotrexate. And in severe unstable life-threatening conditions such as pustular psoriasis, erythrodermic psoriasis, and psoriatic arthritis. Study objectives and protocol. To compare the efficacy of etanercept and secukinumab in severe chronic plaque psoriasis, primary endpoints include PASI 75 and PASI 90 at 12 and 24 weeks. The study type is prospective randomized control trial with a population of 30 patients who are more than 18 years, with a PASI more than 10 and who are naive to biologics. Duration of the study is from November 2023 to November 2024. Group A include patients receiving etanercept 50 mg subcutaneous injection weekly for 12 doses, and Group B includes patients receiving secukinumab 300 mg subcutaneous injection at week 0, 1, 2, 3, and 4, then every 4 weeks for a total of 4 doses. Follow-up at 12 and 24 weeks for PASI scoring is done. Outcome measures is via PASI 75 and PASI 90 for efficacy. PASI scoring, psoriasis area and severity index. It combines lesions, redness, thickness, scaling, and surface area. PASI 75 is more than 75% improvement from baseline, and PASI 90 is more than 90% improvement from baseline. Higher PASI response indicates better disease control. PASI 90 represents near complete clearance, the modern therapeutic goal. This table shows the results comparing the outcome measures of etanercept and secukinumab. PASI 75 at 12 weeks is 32% for etanercept and 76% for secukinumab, and PASI 75 at 24 weeks is 46% for etanercept and 82% for secukinumab. PASI 90 at 12 weeks is 12% for etanercept and 29% for secukinumab, and PASI 90 at 24 weeks is 24% for etanercept and 46% for secukinumab. The graph shows the PASI 75 comparison between the etanercept and secukinumab at week 12 and 24. This graph shows a PASI 90 comparison of etanercept and secukinumab at week 12 and 24. This is a clinical picture of a patient who was given etanercept pre-treatment and after 10 doses. This is a clinical picture of a patient received secukinumab pre-treatment and after 5 doses and maintenance dose for 2 months. Yet another patient received secukinumab where this is a pre-treatment picture and after 5 doses and maintenance dose for 2 months. Here is a comparison between etanercept and secukinumab. Mechanism of action of etanercept, it is a fusion protein acting as a decoy receptor for TNF-alpha or beta, which blocks the downstream inflammatory signaling. Secukinumab is a fully human monoclonal antibody that neutralizes IL-17A, preventing the keratinocyte hyperproliferation and inflammation. Dosing regimen is 50 mg subcutaneous twice weekly for 12 weeks, and then 50 mg subcutaneous once weekly for etanercept, and 300 mg subcutaneous at week 0, 1, 2, 3 and 4, then every week for secukinumab. Onset of action is slower in case of etanercept and it is faster in case of secukinumab. Adverse effects of etanercept include reactivation of serious infections like tuberculosis, hepatitis B, injection site reaction, demyelination, worsening of congestive cardiac failure, risk of malignancy and lupus-like syndrome. Adverse effect of secukinumab are candidal infections, upper respiratory tract infection, and flare-up of Crohn's or ulcerative colitis, hypersensitivity reaction and mild injection site reaction. Conclusion, this study demonstrates that both etanercept and secukinumab are effective in treating moderate to severe chronic plaque psoriasis, but secukinumab provides faster onset and higher rates of PASI 75 and PASI 90 responses. Secukinumab showed superior efficacy, better disease control and improved patient compliance compared to etanercept. Although limited by small sample size and short follow-up, these findings highlight secukinumab as more potent and reliable treatment option for severe plaque psoriasis. Thank you.
Nice presentation. Nice presentation. So, in your observation, like how long was the remission period in both these groups? The etanercept group and as well as secukinumab.
For secukinumab, it was more compared to etanercept.
Okay. So are you still following up these patients?
Some come for follow-up.
Some are coming for follow-up. Thank you. Okay. Thank you.
Thanks.
So next candidate would be Dr. Sriniveta, presenting on familial woolly hair with neurological involvement.
A very good afternoon to one and all present here. I'm going to present a paper on the topic familial woolly hair with neurological involvement, a rare case association. Introduction. Woolly hair is a rare congenital disorder of the hair shaft characterized by firm or hard coils and increased fragility. Woolly hair is prone to fractures, knots and coiling. This hair phenotype is native to the people of African descent. In a non-African demographic, there are 5 distinct types. Woolly hair navis, which is a localized non-inherited form where the woolly hair is localized to one area of the scalp, which may be associated with epidermal navis sebaceous or Kephea ovate macules. The autosomal recessive type, the autosomal dominant type, and the syndromic ones, which are the Naxos syndrome and the Carvajal syndrome, and acquired types. Woolly hair is found to be associated with systemic manifestations in cardiac and rarely neurological involvement. Case 1. A 10-year-old female child born out of consanguineous marriage presented with tightly coiled scalp hair since infancy. The child was delivered at term via normal vaginal delivery, cried immediately after birth, and birth weight was 2.7 kilograms and was apparently normal at birth. Mother denies drug intake or history of infections during gestation. The mother noticed significant delay in achieving milestones, gross motor, fine motor, language, and social development milestones. At around 4 years of age, the child developed frequent seizures of myoclonic seizures, each lasting 30 minutes, following which the child was evaluated. Her CT brain showed pachygyria, dilatation of ventricles, and hypoplasia of pons and worms. MRI brain revealed microcephaly, implied or simplified cortical gyral pattern, cerebellar hypoplasia, and thin pons. The child's Binet Comet test showed an intelligent quotient of 32, and the Vineland Social Maturity Scale gave a social quotient of 27. Her echocardiogram showed a small patent ductus arteriosus with a right to left shunt and no other significant abnormalities in the heart. Her genetic study was done at ICH, which revealed autosomal recessive homozygous mutation in the VLDLR gene, exon 3. associated with cerebral hypoplasia and mental retardation without quadrupedal locomotion, which fits the clinical phenotype of the child, and also SOGA1 mutation. She was diagnosed with global developmental delay, intellectual disability, and seizure disorder. Upon referral to dermatology, the child was examined to have tightly coiled scalp hair. Her palms, soles, nails, and mucosa were normal. The hair shaft examination revealed brownish hair, and tricoscopic analysis showed brownish translucent hair, variation in hair caliber of 10%, anisotrichosis, and certain hairs with wavy appearance, and was diagnosed to have woolly hair. Case 2 was the child's elder sister, a 14-year-old female who had a similar history of tightly coiled scalp hair, delayed development, and intractable absent seizures. Her CT, MRI brain, and genetic study showed similar findings as that of her younger sibling. Her CT brain showed tachycardia, dilatation of ventricles, and hypoplasia of the brainstem. MRI brain also revealed trichocephaly, simplified cortical gyral pattern, cerebellar hypoplasia, and thin pons. Genetic study was done at ICH, and it showed similar mutations as that of her younger sister, namely the VLDLR gene mutation and SOGA1 mutations. Hair shaft examination revealed brownish hair, and tricoscopic analysis showed similar findings as that of her sister. Both the parents have no similar complaints. Discussion. Neurological involvement associated with woolly hair is a rare presentation. It could be attributed to the common neuroectodermal origin of the cutis, hair, and brain with a congenital predisposition. One such case report of 2 patients exhibited woolly hair with progressive severe form of Rasmussen's encephalitis, and another associated with brain malformation and drug-resistant epilepsy. In this case report, we have 2 sisters with woolly hair associated with global developmental delay, intellectual disability, and seizure disorder with congenital brain malformations including microcephaly, tachycardia, cerebellar, and pons hypoplasia. Genetic study revealed VLDLR mutations, which was consistent with the clinical phenotype of both the sisters, and SOGA1 mutations. These findings in association with woolly hair is the first of its kind to be reported in literature. Thank you. And these are my references. Thank you, sir.
Good presentation. Good presentation. According to the definition of woolly hair, you mentioned it as increased fragility. Is it so? It is not right. It is not right. It doesn't have any increased fragility. So as you highlighted about the 2 other case reports where they had one had Rasmussen encephalitis and the other one had severe cerebral malformations. That's good actually. And the other one which you had presented had a varying picture compared to the other 2 case reports.
Yes, sir.
Have you sent it for publication?
Not yet, sir. We're following up in the neuromedicine department for now, sir. So once the follow-up is done, we'll present it.
Yeah, you have to publish it.
Yes, thank you, sir. Yes, thank you, sir.
So next candidate would be Dr. Nandini, presenting on non-bullous congenital ichthyosiform erythroderma case series.
Good afternoon. My case presentation is on a case series of non-bullous congenital ichthyosiform erythroderma. Introduction. Non-bullous congenital ichthyosiform erythroderma is a rare autosomal recessive ichthyosis belonging to the spectrum of autosomal recessive congenital ichthyosis. It is characterized by generalized erythema and scaling, often preceded by a collodion baby stage at birth. The incidence is 1 in 2 lakhs to 3 lakhs live birth, which is a high prevalence with consanguinity, and early recognition and supportive management are crucial to prevent the complications and improve the quality of life. Case 1 is a 4-year-old male child, third born of third-degree consanguineous marriage, brought by the mother with a history of redness and scaling all over the body since birth, with exacerbations and remissions. There is history of collodion baby at birth. On examination, there is diffuse erythema and fine powdery scaling noted over trunk, face, upper limbs, and lower limbs, with palmoplantar keratoderma. The nails showed longitudinal ridging, and hair examination was normal. Child was diagnosed as NBCIE, and patient patient improved with a short course of acetretin and later maintained on topical emollients and keratolytics. Here we can see the erythema and scaling and thickening of the palms and soles in the child. On case 2, 1.5-year-old male child, firstborn of third degree consanguineous marriage, brought by the mother with the complaints of redness and scaling all over the body since birth. Here also there is a history of collodion membrane at birth. And on examination, the child shows generalized ichthyosis with scaling and erythema seen over the trunk, scalp, upper and lower limbs, no ectropion or eclabium, and hair and nail examination were normal. Here the child is managed with topical emollients with the satisfactory control of the symptoms. We can see the ichthyosis. And case 3 is a 9-year-old male child, born of third degree consanguineous marriage, brought by the father with the complaints of dry scaly skin all over the body since birth. There is no significant family history and history of collodion membrane at birth seen. On examination, there is ichthyosis with erythema of the trunk, upper and lower limbs, with thickening and fissuring of the palms. And nail shows longitudinal ridging, and hair examination was normal, and other systemic examination was normal. The child is diagnosed as non-bullous congenital ichthyosiform erythroderma and treated with emollients. Here we can see this erythema, and the scales are large over the lower limbs. And we can see thickening with fissuring of the palms and soles. NBC is typically present in the neonatal period with a collodion membrane, later evolving into a persistent erythroderma with fine white powdery scales. The complications include fluid and electrolyte imbalance, thermoregulatory dysfunction, recurrent infection, ectropion and growth delay. The most common genetic mutation is seen in ALOX12B gene and ALOXC3 gene. Other mutations it can be NIPAL4 and CYP4F22 and PNPLA1 gene. The management is based upon the supportive management is important with emollients, keratolytics, prevention of infection, thermoregulation, and systemic acetretin may be required in severe cases with careful monitoring. Conclusion, MBCB is a rare lifelong genetic disorder with a generalized erythroderma and scaling from birth. Early recognition, supportive skin care, infection control, and judicious use of systemic steroids are essential to improve the quality of life. This case series highlights the clinical heterogeneity of NBCIE, from mild disease managed with emollients to severe forms requiring systemic retinoids. Genetic counseling plays a crucial role, particularly in communities with high consanguinity. Thank you.
So what is the dose of acetretin?
Sir, 0.5 mg per kg.
Start 0.2 mg, and maybe you can step. Okay. What are the advantages of acetretin over etretinate here?
The acetretin it goes deesterification. It has a short half-life of 120 days, nearly 120 days. And we can stop for 3 years only. We have the teratogenicity risk is for 3 years only.
It is said that the musculoskeletal side effects are less in acetretin compared to etretinate. Okay.
Thank you.
Next candidate would be Dr. Muhammad Ahmed, presenting on bullous striated distance and unusual clinical presentation.
Good morning. Good afternoon, sir and ma'am. I'm going to present striated distance and unusual clinical presentation. Introduction. The stridency are the stretch marks that are common dermatological manifestations. On physiological, they can be present in pregnancy, rapid weight gain, and pathological in Marfan syndrome. Bullous stridency is an exceptionally rare presentation. The exact prevalence is unknown, with only sporadic case reports available in literature. It manifests as tense, translucent, or yellowish bully along the stretch marks, commonly affecting abdomen, breast, luteal region, or lower backs, thighs. Patients often have underlying fluid imbalance like hypoalbuminemia and edema. Represent one case report: a 17-year-old obese female patient admitted in the critical care unit with a complaint of breathlessness or distress over lower abdomen, for which the dermatology called follower was sent and she was diagnosed with hemolytic anemia syndrome and pneumonia. Dermatological examination revealed multiple tense bully with striae over flanks. She had hypoalbuminemia, sepsis, and was treated with diuretics. Protein supplementation was given in the afternoon, after which her condition gradually improved. As we can see in the diagram on the lower rank on the right side, and over on the pubis area, we can see some multiple fluid-filled blisters. Case 2 was a 16-year-old female with a known diagnosis of SLE, presented with multiple linear raised lesions over lower abdomen, flanks, and lower limbs. Since 3 months and subsequent development of asymptomatic bully over it for 5 days. Patient was on treatment with prednisolone, cyclophosphamide for 6 months. While doing the examination, she had central obesity, Cushing-White habitus, and multiple translucent bully along striae over abdomen extending to flanks. Other laboratory investigations revealed anemia, hypoproteinemia, hypoalbuminemia, and proteinuria. Patient was then treated with furosemide, histamine forte was given, and compression dressing was given. The condition after which gradually improved without any dermatological intervention. Now coming towards the discussion, steroid deficiency are linear atrophic skin lesions, which are primarily a form of dermal scarring. It has both physiological and pathological etiologies like pregnancy, puberty, as told earlier, with rapid weight fluctuations present in adolescent age. Cushing-White syndrome and Marfan syndrome. However, the pathophysiology is not yet fully understood. Exogenous or endogenous corticosteroids also increase the risk. It commonly presents as erythematous plaques known as striae rubri or ciliary atrophic plaques known as striae alba. However, few uncommon presentations of the striae like ulcerative edematous, urticated and emphysematous forms have been reported previously also. Among all these presentations, fluid-filled or bullous striae deficiency have been rarely reported previously. Often seen on abdomen, thighs, lower limb, breasts, and flanks. Generally, they are benign but can be cause of cosmetic concern. Pathogenous due to dermal tearing and altered connective tissue, due to reduced fibroblast, collagen and elastin damage. Hormonal influence is there, cortisol and estrogen. Mechanical stress on the skin causes linear tears. Dermal vascular changes also contribute. The site involved, as told earlier, also abdomen, thigh, breast, arms, and back. In the bullous change, the pathologist can be acute dermal edema in the weakened striae. Negative pressure allows a blistral coagulation. Steroid-induced atrophy is a contributing factor. Fragile striae floor causes fluid lifts the epidermis, which appear as dense bully within the pre-existing striae. It's usually a self-limiting. Clinical features, they are the dense bully confined to striae lines surrounding skin may be normal or atrophic. Distribution was already told, often bilateral and symmetrical. It may rupture and heal without scarring. No mucosal involvement is there. Nikolsky's sign negative of absence of any systemic symptoms. The differential diagnosis can be bullous pemphigoid, which can be ruled out through biopsy and histopathology. The autoimmune disorders like pemphigus vulgaris, pemphigoid, epidermolysis bullosa, eczetia, porphyria cutaneous tarda, infected striae with bullae formation, contact dermatitis. So, as told, clinical and histopathology is crucial to rule out autoimmune blistering disorders. Investigations can be the routine lab investigations, Zank smear, which may be negative. Biopsy from the lesion is best followed by DIF. No IgA3C3 deposition is there, which confirm the diagnosis of bullous striae. Non-invasive imaging really needed. Histopathology, as we can see that the epidermis is thinned and stretched. Subepidermic cleft with fluid collection. Dermis, atrophic collagen is there, and the elastin loss is there. The fibroblasts are reduced. There is no acantholysis or immune deposits. Consistent with the striae deficiency changes, no inflammatory infiltrate, and it rules out bullous pemphigoid. Management is done by supportive conservative approach to this benign condition. Topical agents are used, monitoring for recurrence, lifestyle modification. Prognosis is self-limiting, usually no scarring after bully, no systemic involvement, excellent prognosis, early diagnosis, preference over treatment, long-term outcome is benign. To conclude, dramatic events of fitful striae deficiency may cause concerns for the physicians. The emergence of bullous lesions Patients contact likely of chronic use of systemic steroids, which are the main factors. And the awareness of this complication and usually clinical presentation is fundamental prevent unnecessary investigations like pathology, biopsy, and only a handful of cases have been documented. It provides a systemic look to the pathology, and awareness is essential for appropriate management. These are the references. Thank you.
So how do you think corticosteroids are going to increase the risk of bullae formation in stride distance? Is there any literature given behind that? The role of corticosteroids in the formation of bulla.
Yes, sir. The role of steroids is present.
You have done biopsy for these patients, right?
For the patients who were having the steroid intake for past 6 months or more, it was playing a role for the blister formation, and it was.
You have done biopsy for these patients, right?
Biopsies are yes.
You have done. Okay. Thank you.
Thank you, sir.
Next candidate would be the last candidate presenting on palmoplantar erythrodysplasia, Dr. Sharpila S.
Good afternoon all. I'm going to present a case series on palmoplantar dysesthesia. It is a frequent cutaneous adverse effect in patients receiving chemotherapeutic agents. Clinical features include redness, swelling, and blistering over palms and soles. The symptoms can occur anywhere between days to months after administration of the offending medication, depending on the dose and speed of administration. Despite its prevalence, the pathophysiology remains partially understood and the management strategies vary. Case 1, a 55-year-old female with metastatic breast carcinoma started on chemotherapy, came with complaints of burning sensation, pain, and progressive dark discoloration of her palms and soles, associated with dryness and scaling for 2 weeks. She was on capecitabine 1250 mg per meter square orally twice daily for 14 days, followed by 7 days rest, 21-day cycle. Symptoms started after 2 weeks of starting capecitabine. She also experienced difficulty in holding objects and walking due to discomfort. On examination, there was symmetrical hyperpigmentation, dryness, and redness over pressure points was present. She was diagnosed as palmoplantar dysesthesia due to capecitabine. Case 2, a 45-year female with recurrent triple-negative breast cancer complains of burning sensation over palms and soles, followed by history of bright red discoloration, which is followed by dark pigmentation. She was on pegylated liposomal doxorubicin 40 mg per meter square IV infusion once every 28 days. Symptoms started 2 weeks after starting the drug. On examination, there was symmetrical dusky hyperpigmentation of palms and soles, scaling over soles noted. Tenderness over pressure points was present. She was diagnosed as palmoplantar dysesthesia due to pegylated liposomal doxorubicin. Case 3, a 52-year female with carcinoma ovary on chemotherapy presented with complaints of burning sensation and tightness of skin over palms and soles, later associated with dark discoloration and dryness. She was on pegylated liposomal doxorubicin 40 mg per meter square IV infusion every 28 days. Symptoms started 7 days after the first cycle. No other systemic symptoms noted. On examination, there was symmetrical well-demarcated dusky hyperpigmentation of palms and soles noted. Tenderness on palpation of weight-bearing areas present. She was diagnosed as palmoplantar dysesthesia due to pegylated liposomal doxorubicin. As all these patients had grade 1 of palmoplantar dysesthesia, they were treated with topical emollients. It is also known as hand-foot syndrome. It is a dose-dependent cutaneous toxicity associated with several chemotherapeutic and targeted agents, commonly due to capecitabine, 5-fluorouracil, cytarabine, doxorubicin, and docetaxel. Although the exact mechanism is not fully understood, it is thought to result from drug leakage from capillaries and high-friction areas, such as palms and soles, due to repetitive mechanical stress. The eccrine sweat glands and local drug concentration contribute to direct toxicity, leading to inflammation, erythema, and subsequent hyperpigmentation or desquamation. Drugs gets deposited in the sweat and spreads the drug on the skin surface. Then the drug penetrates into the stratum corneum. Since palms and soles have high density of sweat glands, acts as an efficient long-term reservoir for the penetrating drug. There are 4 grades for palmoplantar dysesthesia. Grade 1 presents with mild erythema, edema, desquamation, not interfering with normal activities. Dose modification need not be done. Grade 2 presents with erythema, edema, desquamation, complicating but not precluding normal activities. Blisters and ulcers less than 2 cm in diameter. chemotherapy can be delayed for up to 2 weeks or until resolved to grade 0 to 1. If there is no resolution after 2 weeks, drug should be discontinued. Grade 3 presents with blistering, ulceration or edema interfering with normal activities. The chemotherapy drugs can be delayed up to 2 weeks or until resolved to grade 0 to 1. The dosage can also be reduced to 25% and returned to original dose interval. If there is no resolution after 2 weeks, drug should be discontinued. Grade 4 presents with infectious complications in bedridden hospitalized patients. Treatment is same as for grade 3. Different measures have been suggested to prevent these symptoms, such as avoidance of friction and excessive pressure due to the skin and application of emollients. Reach and cooling via ice packs to the wrist and ankle during treatment has been suggested to be effective. The theory behind this is that cooling results in vasoconstriction and therefore less drug circulation to the distal extremities, which may lead to less drug extravasation to the surrounding tissue, with reduced cutaneous toxicity as a result. Conclusion: although the incidence of severe grade of palmoplantar erythrodysesthesia is low, it can have significant influence to the patient's quality of life and daily routine. If it's feasible, dosage may be modified. General measures may be advisable in order to prevent palmoplantar dysesthesia. The efficacy of these measures still needs to be assessed in control and randomized studies. These are my references. Thank you.
Nice presentation. Nice. So what are the differential diagnoses would like patient is on the patient is on chemotherapeutic. Anyways, you have to think of other differential diagnoses.
Erythromelalgia, palmoplantar keratoderma, post-inflammatory hyperpigmentation, eczematous conditions.
Even certain lesions which have macular pigmentation, you might even think of as secondary results. What other drugs have been tried in treating palmoplantar erythrodysesthesia?
Topical
Pyridoxine can be tried. Up to a dose of 800 milligram per day. It has been given. Right. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir. I now request Professor Dr. Suchitra ma'am to felicitate Professor Dr. Satya Narayanan, sir. On behalf of the entire team of Telederm, we would like to thank each and every single one of you present here over the past 3 days who have helped make the entire conference a huge success. Thank you all.
அவர்தான் அதுதான் சொன்னாரு. நான் கேட்டேன் நானு. அந்த ஜென்சன் பஸ் எங்க சொல்லுவாங்க டெலிகிராம் இங்க தான் இருக்குது. நான் எஸ் டைம் எல்லாரும் ரிமூவ் பண்ணிட்டு வா எடுத்துவாங்க. ரிமூவ் பண்றேன். இது ஜி எதுதான் இது இது எங்களுது பெல் அப்போ இன்னும் கொடுத்தேன் நான். இன்னொன்று ரெண்டு கேமராக்கு அது எஸ்டிஐயா? சரி விடு விடு. இந்த ஆக்ஸ்ல ஒரு எஸ்டிஎம் போட்டுருக்கீங்க. ஆக்ஸ்ல ஒரு இது இல்ல ஷார்ட்டே ஒன்று இருக்கும். அப்புறம் அவுட் கொண்டு அப்போ அந்த பெல்ட்னா அத இருக்கு பாருங்க. இல்ல இந்த ஆக்ஸ்ல குத்துருக்கு அந்த கேபிள் யாரு இல்லடா. ரெண்டு கேபிள் மொத்தம் 3 எஸ்எம்ஏ லாங் ஓட்டிருக்கு. 3 ஒன்று ஆக்ஸில் கொடுத்துருக்கு. ஆமாண்டா இங்கே போடியம்க்கு 2 ஓட்டி இருக்கு. இன்னும் 2 ஓட்டி இருக்கு. ஓகே அது வந்து இதில் கனெக்ட் பண்ணியிருக்கோம். இங்கே ஒன்று அது இல்லாமல் இன்னொன்று ஜூம் பண்ணுவோம். மொத்தம் 3 லாங் எஸ்டிஎம் எல்லாத்தையும் கொடுத்துட்டு அப்புறம் ஒன்று அவுட் ஆக்ஸ் அவுட் ஒன்று. ஆமாம் அந்த யாருன்னு கேட்குறேன். ஆக்ஸ் அவுட் இல்லை இன்னொரு எஸ்டிஎம் இன்னும் ஒரு செகண்ட் இல்லை தேர்ட் இல்லை இன்னொன்று கொடுத்துருவாரு. அந்த அந்த எஸ்டிஎம் டிவி ஆக்ஸ் அவுட் வந்து டிவி நான் அந்த பெல்கின் அவங்கள்தா ஆமாம் லென்ஸ் ஏசி கேட்டிங்களா இப்போ? எஸ்டி கேபிள் எஸ்டியா தானா? எஸ்டி அவங்கள்தானா? ஆமாம் ஆமாம் இதான் எஸ்டி.